At the outset, myself, Dr. Archana Khare, offers a warm welcome to all of you. Childbirth is an emotional experience for every woman. Royal College of Obstetrician and Gynecology says birth is a life-changing event and care given to women has the potential to affect them both physically and emotionally in a short and a longer term. Labor is a divine process for which we obstetrician plays a catalyst. Normal labor, as easy as it may sound, can also become most challenging for any obstetrician. So here we bring to you the A to Z of labor, basics to most advanced from NST to partogram, from PPH to safe motherhood with lectures, interactive session and workshops. Let's enjoy this academic feast to the fullest and be the part of this never event. I will welcome you and thank you again. I request Dr. Ashwini Pawar and Dr. Shruti Yajurvedi, our dynamic MOC for this session, to start with our most awaited workshop by none other than the Fernandez Team Hospital.
Thank you, Archana. We are starting with our first session, workshop of the conference. It's induction of labor and NST by Fernandez Hospital. I will give you a short introduction about Fernandez Hospital. It's on CTG Basics by Fernandez Hospital. So, Fernandez Hospital was founded by Dr. Leslie Fernandez and Lourdes Fernandez in 1948. The hospital is under care of their daughter, Dr. Evita Fernandez, and her talented and able team of doctors since 1985. It's a premier specialty hospital for women and newborn in Hyderabad. It has been providing efficient, reliable, and personalized health care of very high professional level for over 60 years. The hospital is noted for its normal delivery rate as compared to cesarean section rate. I invite our chairpersons, Dr. Nanda Magai Madam. She is a very dynamic person in our society. She is consultant, obstetrician and gynecologist since 26 years, laser and cosmic gynecologist. Recently she started working on it. President Solapur Obstetrics and Gynecological Society 2019 and 20 and recipient of National SOGS Best President Trophy. Welcome, madam.
I request Dr. Neetu Jaikar, ma'am. She is practicing at Jaikar Niramai Clinic since past 15 years. Her special interests are laparoscopy. I request ma'am to join the stage. Also, I request Dr. Raghuji, ma'am. She is practicing in Solapur as OGCN since past 25 years. Her special interests are fetal medicine. Ma'am, please join the stage. Thank you.
We hand over mic to chairpersons to conduct the session.
Good morning. Now we shall start with the workshop on induction of labor and NST by Fernandez Hospital. As we already know that the fame of Fernandez Hospital is worldwide for their specialty in managing high-risk pregnancies. The advanced technology has substantially increased the medical care standards and improved the quality of patient care. Now let us hear from them.
Today we have three eminent speakers from Fernandez Hospital, Hyderabad. They are Dr. Subhashini Y, Dr. Shanti Shri, Dr. Siri Y. Dr. Shanti Madam is MD OBGY. She's consultant obstetrician from Fernandez Hospital. She is expert in managing medical disorders complicating pregnancy. Dr. Subhashini Y She is DNB OBGY, fellow in obstetric medicine. She is consultant in Fernandez Hospital, and her interest also in medical disorders complicating pregnancy. Dr. Siri Y. She's DNB OBGY. She is also consultant in Fernandez Hospital. They all are interested in medical disorders complicating pregnancy. Let's learn from them today. We'll start with the workshop with Dr. Subhashini Y. The stage is all yours, ma'am.
Yeah, a very good morning to all of you. On behalf of Fernandez Hospital, thank you all for giving us this opportunity to learn along with you and relearn and train and share our experience. And this would be a wonderful opportunity for interaction, clarification of doubts, may it be clinical or even practice oriented. So we would want it to be more interactive. Please feel free to approach us with any of your doubts or interrupt us in the talk so that we could go along together. So our first talk, we are starting with the electronic fetal monitoring. So I would be going through to the basics and the classification of the electronic fetal monitoring, which is otherwise called the non-stress test or the cardiotocography. So as we see, electronic fetal monitoring is a form of assessment which basically records the fetal heart rate. This is the new machines which show the maternal pulse. The lower half shows the uterine contractions, and these black marks are the fetal movements which are perceived by the machine. This basics of paper settings, how do we place the probes, uterine contractions, and how do we analyze the CTG. So this is the machine we have been using. It's moving on its own.
Timer is there.
No.
Check now.
So this is the machine, so which we use a Philips machine, and we still have been a central unit. In some units, there are a central unit in which we can actually monitor the whole of the CTGs which are going on in the individual rooms. So a person sits inside a central room and monitors and takes decisions. So the specifications of this machine is basically it's non-invasive, it's external topography, and it has a customized trolley, it has an operating manual, and the optional is we have two probes which we use for twin monitoring. There is a direct ECG leads. Of late we have been using for maternal pulse monitoring, and we connect the mother to an NIBP for concurrent maternal heart and vitals monitoring. So this is the paper, so in which this is a 10 centimeters paper. In this, the lower part will record the uterine contractions. The paper settings, the standard international paper settings is usually 1 centimeter per minute, which gives us a sensitivity display of 20 beats per minute. And the lowest fetal heart rate recorded is 50. The highest fetal heart rate recorded is 210. So as you see, this big color green box denotes 20 beats per minute, and that box gives us 1 centimeter. So this small box denotes 10 beats per minute, and this small one divided further is 5 beats per minute. So fetal movements are the mother is given a fetal movement sensor which is given along with whenever the CTG is started. So whenever she perceives fetal movement, she is supposed to be pressing it. Also concurrently there is a maternal machine detector sensor of the fetal movements which comes as black dots beneath. So the first step of starting any CTG is we should always palpate the maternal pulse and then simultaneously with localizing the fetal heart rate and then put a fetal probe or the NST probe to start the CTG machine. Also, it's very important before connecting to the NST or the CTG machine, we should understand why we are doing a CTG. We should know the fetal indication of why are we starting a CTG. We should have a holistic approach and should know the clinical scenario as to what is the risk factors, antenatal risk factors of that mother, and not just blindly start a CTG, because it's an important intervention. It has its own impacts. It has seen to cause undue worry to the mothers when we tell them that the test is not really well. So before even starting a CTG, it's very important from the clinical perspective to know the case scenario, to know why we are doing a CTG, and are we able to manage its implications? Are we able to deliver this baby if the CTG is not really good? So we would, or time and again, international organizations have reiterated the fact that you should always take the CTG monitorings at a level where your NICU is able to salvage the baby, and not just because the international standards are telling it to start at 28 weeks or 32 weeks. So it has to be individualized, it has to be enhanced, and again supported with other additive ultrasound modalities or BPP. So we'll be going through all of that. So these are the uterine contractions. So this is the basal tone. In between two contractions, the peak denotes the intensity of the contraction, and the two peaks in between, we can, by counting the peaks, we know the frequency of contractions. So fetal heart rate parameters which come to be read in the CTG are the baseline heart rate, baseline variability, periodic accelerations or decelerations. So how do we define a baseline heart rate? The baseline heart rate is the mean level of fetal heart rate when it is stable, excluding the accelerations and decelerations in a 10-minute window. So the normal fetal heart rate is 110 to 160, and anything less than 110 before labeling it as bradycardia, the thumb rule is always differentiate from the maternal pulse and check whether we are recording the maternal pulse and interpreting as wrongly as bradycardia. So basal heart rate, we usually document rounding it off to the nearest 5 beats increment, and if it is indeterminate, we are not able to define the baseline, always continue it for next 30 to 40 minutes or refer back to the previous trace. So when is it defined to have a change in baseline? If the change in baseline persists for more than 10 minutes, that's how we define that the baseline of the fetal heart rate has changed. So tachycardia, as I have told, 110 to 160 is the normal fetal heart rate. Whenever the fetal heart rate is more than 160, it is defined as tachycardia. So the next question arises, is simple tachycardia a sign that baby is in distress? So fetal tachycardia more than 160 is the conventional definition, and it's usually the pathophysiology is because of increased sympathetic and decreased parasympathetic autonomic tone. But if the tachycardia is associated with other additive factors like loss of variability or presence of decelerations, that's when we have to be worried about the fetus. So in term fetus, just having a heart rate of 160 or 165, we need not be so much worried, and definitely it needs evaluation. It would not be without a cause. So let's look into the causes. The most common cause of tachycardia is hypothyroidism, maternal hypothyroidism, or fever. It can also happen that in lower gestational age, the baseline of the fetal heart rate, which you initially had monitored, may be around 130, 140, and as the fetus ages towards term, the heart rate may become 150 or 160. But that doesn't mean that baby is sick inside. Sometimes if fetal conditions like arrhythmia or severe anemia, or when the baby is in sepsis or cardiac failure, can also be one of the causes of tachycardia. Other drugs like parasympatholytics or beta sympathomimetics, atropine or hydroxyzine are also common causes of fetal tachycardia. And the most important and most commonly seen in our clinical practice is definitely chorioamnitis. So isolated tachycardia is not an ominous sign, but if it is associated with other non-reassuring factors like decreased variability or presence of decelerations, then definitely we have to get worried and this baby is calling for help. So next we move down to bradycardia. So anything less than 110 we can call it as bradycardia, but at the same time we should be very important that we are not actually localizing or we are not recording the maternal pulse. Whenever there is a bradycardia, air of caution is always palpate the maternal pulse, relocalize the fetal heart on scan and then start the CTG. In certain conditions like congenital heart block also, there may be a trace wherein we might get a constant rate because of fetal cardiac block as 90 to 110 beats per minute. So this is one of those academic traces which we had put for a fetus who had a complete heart block. So the causes, as I said, prematurity can be one cause wherein the fetal heart rate may be at a little lower range, hypoxia, maternal hypoglycemia, fetal neurological abnormalities, or if the mother is on a beta blocker which is decreasing her maternal pulse, this also causes a bradycardia in the fetus. So again, bradycardia has its own clinical implications. Always differentiate it from maternal pulse. See whether it is associated with good beat-to-beat variability, whether accelerations are present or absent, or is it also associated ominous signs that is associated with decelerations. The next important factor, and which is the most important factor in the whole CTG, is the difference or the baseline variability. The baseline variability is defined as the difference in beats per minute between the highest peak and the lowest trough of fluctuation in a 1 minute segment of trace. So in this trace, as we see, the highest peak and the lowest peak, so that's how we deduct the readings and get the baseline variability. Baseline variability is given such an importance because its presence shows that the cerebral cortex, the midbrain, the cardiac conduction system and the vagal nervous system of the baby is intact and working well. So in this is a clear-cut case of decreased baseline variability. So definitely decreased baseline variability also has its own physiological reasons. One of the most common reason is deep sleep cycle of the baby. Sometimes the baby goes into a sleep cycle of 30 to 40 minutes and after that there is a good reactive trace. So we should always continue the trace for 30 to 40 minutes when there is a decreased beat-to-beat variability, provided it is not associated with other decelerations, and then see and then give a conclusion on that trace. Even premature babies of less than 32 weeks also have shown this as a concurrence of happening. Drugs, hypoxia and enamelous babies are other reasons of decreased beat-to-beat variability. So whenever there is a decreased beat-to-beat variability, always check on scan what is the fetal heart rate, see whether there is association of accelerations and there is no decelerations. Always go back to the previous trace. If not available, continue the trace. And we are doing all these efforts to rule out the physiological causes that the baby is not in sleep. But if the decreased beat-to-beat is associated with late or variable decelerations, definitely it is an indication of hypoxia. It turns the trace into ominous and we should not waste much of the time in delivering the mother. So this is one of the cases wherein we had complete decreased beat-to-beat variability and also associated with decelerations. So this was an ominous trace. So this is another case wherein there was complete absent beat-to-beat variability and a deceleration associated. So next we go on to accelerations. Accelerations are defined as fetal heart rate of 15 beats or more, that is an upsurge and lasting for 15 seconds or more. And accelerations are a sign of well-being. So in accelerations also, like we have seen with regard to baseline variability, in preterm babies there may not be picture perfect accelerations of 15 beats per minute. So in their cases, even 10 beats per minute, which is persisting for 10 seconds, can be taken as an acceleration. So the main accelerations, it is because of the fetal movement or the uterine contraction. Usually because of it, if there is a partial cord occlusion, this gives a baroreceptor response and which increases the fetal heart rate. Accelerations are supposed to be a sign of a healthy baby, a happy baby inside. It indicates fetal alertness or arousal state. So absence of accelerations give us a sign of suspicion is whether this baby is going into acidosis. So clues to avoid difficulties: whenever you feel that you are having difficulty in defining an acceleration, always you can do a vaginal examination and stimulate the baby's scalp. So usually with the scalp stimulation or the fetal movement, there will be an accelerations, and that sign on the CTG gives us reassurance that we are not missing out a hypoxic baby. So in this, if we see, there is a good beat to beat variability, but there is no clear-cut accelerations. But since we have learned before, good beat to beat variability is also a sign that there is less chance of the baby going into hypoxia, so we needed to continue that trace. So next we go into the terminology of decelerations. Decelerations are defined as a transient decrease in the fetal heart rate of more than 15 beats per minute and lasting for 15 seconds. So these are decelerations. There are different types of decelerations. So depending upon the depth and duration, its relation to contractions and how much time it is taking to return to the baseline, whether it is associated and happening most of the trace is associated with most of the contractions, the consensus has been given and classification of decelerations have been made. So even if with decelerations also, like I have said, the beat to beat or the baseline variability is very important. Whenever there is a deceleration and there is an associated decreased beat to beat on the baseline or even during the deceleration, that gives us much alert that the baby is going into acidosis. So we will get into the different types of decelerations. Usually in antenatal period, it is called episodic or unprovoked decelerations, whereas in labor, we call them as periodic or early, late and variable decelerations. So this is an antenatal trace, the mother who had come to us. It was an iseminized baby at around 36 weeks when we started the CTG. So they were unprovoked decelerations. So we had to deliver this man. So these are early decelerations. So early decelerations are those in which the decelerations coincide with the I think it's not coming onto the screen.
We'll give you another one. Just carry on.
Yeah. So the decelerations which coincide with the peak of the contraction, yeah, like I see, this is the peak of the contraction. So these are called the early decelerations. So early decelerations are usually associated with the fetal head compression. So because of the fetal head compression, there is an altered cerebral blood flow which causes a vagal reflex and it precipitates a cardiac slowing. It is usually commonly seen at 4 to 7 centimeters of dilatation and it's not usually associated with any other fetal changes. So hence this has been denominated as not associated with fetal hypoxia or acidosis or low Apgar score. These are the late decelerations. If we see carefully, the dip is coming after the contraction. So the dip is coming after the contractions. So these are called late decelerations. These usually indicate uteroplacental insufficiency. Because of these come onto the trace because there is intervillous stasis of the blood during the contractions and are usually seen in babies in cases where there is hyperstimulation or any acute event like premature placental separation or abruption, or there is a compromised placental exchange like absent end diastolic flow or Doppler compromise in a fetal babies. So these late decelerations are very important in our clinical judgment and these are the babies which need help and which need early delivery and action to be made upon. So this is a trace wherein if we see, we have all the ominous characteristics in it. There is already a tachycardia of around, we can say 175 beats per minute. There is complete absent beat to beat variability. Also there is a deceleration which is coming after the contraction. So definitely such traces are ominous, which do not need, there is no role for conservative management here. This baby, if we do not deliver, will have an intrauterine fetal demise. So next we come to the variable decelerations. As the nomenclature signifies, these are variable, these intermittent, this is periodic slowing and it has no clear-cut sequence with the contractions like we have those with early and late decelerations. Usually these are commonly seen because there is transient cord compression and vagal response. But when these decelerations happen recurrently and it go on to develop more than 50% of the trace and staying for long, taking long time to come back to the baseline, then these become significant in clinical decisions. So the cause of variable decelerations are mostly associated with nuchal cords or at 8 to 10 centimeters of labor where they come onto the trace whenever the mother is is pushing. So usually they come down if you position change, or if there is not much of, usually they are not long lasting, they usually come down on their own. There are also other variable decelerations which we have to differentiate whether they need clinical decisions, and unusual causes like true knots or sometimes with cord prolapse also, it can come as a variable deceleration, but it has other associated significant factors like late recovery and complete loss of beat to beat variability during the deceleration, which helps us to take and pick a decision. So variable decelerations not always associated with significant hypoxia, it could be mild cord compression, but if these mild cord compression move on to prolonged decelerations which is associated with prolonged compression, this may build up the hypoxia and add on to the metabolic acidosis of the baby. So deep long lasting decelerations which have a delayed return to the baseline with or without overshoot, along with association of loss of variability or a baseline tachycardia, suggest that there may be a progressive neurological depression of the baby. So the next concept is about acute bradycardia or prolonged decelerations. It is usually said prolonged decelerations when the deceleration lasts for more than 3 minutes or had crossed more than 2 contractions. It may occur in many acute conditions like cord prolapse or secondary to epidural acute maternal hypotension, or during induction of labor because of uterine tachysystole, or any causes of maternal hypoxia if the mother is in diabetic ketoacidosis or mother is in sepsis, which she is already, or in any acute viral pneumonia wherein or COVID affected mother wherein she already in hypoxia. So prolonged deceleration is usually stays for more than 3 minutes. That's why we call it as prolonged decelerations. It is usually seen to be followed by rebound tachycardia and loss of variability. And these decelerations are sometimes seen more persistently present in traces wherein if you have not acted upon, the baby may be compromised and may have an intrauterine demise. The last pattern which I am discussing is a sinusoidal pattern. So sinusoidal pattern is defined as a regular, smooth, undulating signal which resembles like a sine wave. It has an amplitude of 5 to 15 beats per minute with a frequency of 3 to 5 cycles per minute. Mostly the sinusoidal pattern is easy to identify once we remember the trace, and usually if it persists for more than 30 minutes without acceleration, we can label the trace as ominous and deliver the mother. The most pathophysiological basis is sinusoidal pattern is seen in babies which has severe fetal anemia, or babies who has fetal hypoxia and infection, or babies who have cardiac anomalies. So as we see, this is a typical pattern which is very easy to remember and we would not miss. So like we see, these are all smooth sine wave like undulating pattern, and usually they have here in this trace they have decreased beat to beat variability. The amplitude is between 5 to 15 beats per minute. So take a closer look. So this is how it looks, the sinusoidal pattern. So here is a case wherein we had twins in which the first twin had decreased beat to beat variability and the second twin, like we see, has a sinusoidal pattern. So she was immediately delivered. So there is another pattern called the pseudo-sinusoidal pattern, which usually is characterized by a normal pattern before and after. There is a very transient, less than 30 minutes appearance of this sinusoidal pattern. So usually this is seen in traces post-epidural or any IV analgesia which is administered to mother. In some explanations they have been associated this pseudo-sinusoidal pattern with fetal movements and other mouth-sucking movements. So this is like I see. Usually the pseudo-sinusoidal trace is associated, is very short time and is associated with a reactive trace before or after. That's how we know that it is a pseudo-sinusoidal trace. So all these have implications on the whatever the fetus has its behavior inside the mother's tummy. So like I said, decreased beat to beat variability, we have to wait and continue the trace for at least 20 to 30 minutes to see and determine that it is not the physiological state of the baby wherein the baby is in active sleep or deep sleep. So these are the three fetal behavioral states. Deep sleep is usually, it lasts for 50 minutes. It represents itself as a stable baseline with no accelerations with borderline variability. The most common accelerative trace shows that the baby is in active sleep and moderate number of accelerations and normal variability is there. But if it is a fully reactive trace, that represents the active wakefulness of the baby. So at Fernandez, usually for low risk pregnancies and mothers who have no risk factors, we have a group of midwives who help us a lot and support us a lot. So all our monitoring of low risk pregnancies are done by a group of midwives. We practice intermittent fetal auscultation. We are all trained for it. There are courses online from e-integrity by which we do. So whatever we have spoken about CTG monitoring, usually we limit it and with very specific instructions, with specific indications. If the mother is high risk, if the fetus is high risk, or it needs continuous monitoring, that's when CTG comes. Still now, we practice when there is a low risk mother. Sometimes having CTG monitoring can increase the anxiety of the mother if there is even a transient change. So we should be able to select our cases and then do the required monitoring. At the same time, low risk pregnancies, like we all know, can any point of time turn into high risk. So we should be at a state wherein if there is an intermittent fetal monitoring, have a cutoff for yourself wherein you convert it and counsel the mother for continuous electronic fetal monitoring. So I'll just browse through the antenatal classifications. So antenatally, we classify these traces as reactive and non-reactive. Reactive is when there is a presence of 2 accelerations in 20 minutes period, and we wait for 2 accelerations for a maximum of 40 minutes period. So this is an absolutely reactive trace, nice beautiful trace. This is called non-reactive because we do not find significant accelerations in it. So always when we interpret a CTG, we take the help of this mnemonic called the Dr. C. Bravado. So we will be going through each of these parameters and how do we use. So D stands for the risk. Like we should always know what is the clinical status of the mother. What are the risk factors? What is the antenatal period? What is the complications associated with the mother? How is the mother, whether it is high risk? How is the fetus, whether it is high risk or low risk? So fetal risks are whether it's an average grown baby, is it a growth restricted baby, is there oligohydramnios, and if twins, is there TTTS or any associated or a Doppler compromised baby. C stands for contractions. So in the previous traces, we have seen where we have to see for contractions, how do we count for them. B stands for baseline fetal heart rate. We have to define the baseline fetal heart rate, go to the closest increment of 5 beats and then put it. And to determine the baseline, it has to be stagnant for at least a minimum of 2 minutes. And if there is a change, we have to document the change of the baseline. V stands for variability, which is the most important factor in the intrapartum trace. A stands for accelerations. D stands for decelerations. We saw all the early variable and late decelerations and also the sinusoidal pattern. So last O stands for what do you do with this trace. So how do we give a plan? Whether we stop the trace, if we stop the trace, what is our impression? If what is our impression, what is the next plan? When should we restart the trace? Whether we should continue the trace. So all this has to come into the plan of management. So even if it is a non-reactive trace, it has a very high false positive rate. We should always continue the trace for at least 20 minutes more, and any non-reactive trace should have further evaluation and a support and cross-check with ultrasound modality of BPP and Doppler before taking a decision. We should never have this impression and take a decision solely on the basis of NST alone. Please take the holistic picture. Take the holistic picture, how the maternal homeomiliar interior is, how is she doing, how the fetus is, then corroborate with ultrasound and then take a delivery decision. So this is the antepartum CTG. So we document and interpret that whether and what is our further plan, whether we repeat the CTG every week in her antenatal visits, and how if there is a change, what do we do next. So in intrapartum monitoring, this reactive and non-reactive is not used. We use the terminology which has been given by NICE and has been amended in 2017. Usually this NICE classification is very exhaustive, very difficult to remember. So we have made posters in our labor ward and have stuck it across on walls, and we keep referring to it. So I will be just simply touching the important things. So it's a 3-tier classification wherein fetal characteristics, we see the baseline what is the baseline heart rate and baseline variability, and the changes of accelerations and decelerations, and they have classified it as normal, non-reassuring or abnormal. So baseline, these are the normal parameters. It is normal between 100 to 160. Anything less than 100 to 109 is one of the parameters to label it as non-reassuring. Any tachycardia more than 180 or bradycardia less than 100 gives it an abnormal. Like I have told before, always be careful before labeling it as bradycardia. Check maternal pulse and see that we are not tracing the maternal pulse instead of the fetal heart rate. Baseline variability 5 to 25 is the normal baseline variability. Anything below or above gives us a parameter for non-reassuring. If it is sinusoidal trace constantly for 30 minutes, or it is decreased beat to beat variability of less than 5 beats per minute for almost 50 minutes, then it goes into the abnormal trace. Decelerations, definitely if it is variable decelerations with concerns like decreased beat to beat variability or prolonged decelerations more than 3 minutes, or decelerations continuously happening, late decelerations present for almost half an hour, it goes into the abnormal trace. Any of the 2 factors like variable decelerations but not throughout the trace or less than 50% of the trace goes into the non-reassuring category. So depending upon these definitions which has been given by our NICE classification, we separate these traces as normal, non-reassuring or abnormal, which can be in which there is one non-reassuring factor but it does not need immediate delivery. We can do conservative management, we can correct the correctable causes and then wait and watch and then take a decision. Abnormal traces are those traces which have bradycardia or prolonged decelerations which need urgent intervention. So this is the snapshot of the freely available guideline which is there online. So these are difficult to remember, so we keep going on and to go back to the classification and we trace and we read our traces. So these are the stickers which we have made in our hospital which help us and also the midwives interpret the traces. So these are the stickers which we put for all our antenatal mothers who are on CTG monitoring weekly or bi-weekly, and a consultant signs it as normal or abnormal. We usually help by writing and filling all this, which helps us differentiate it as normal or abnormal or reactive or non-reactive. And sometimes if our first clinician has a doubt, we show it to a second clinician and take her or his opinion. So this is a sticker which we use for our intrapartum all labor CTGs, wherein we have put the definitions so that it is easy for us to interpret that CTG. So we have put the definitions which are required for normal, we have put the definitions which are required as suspicious and what are pathological. So the other classification which is a little easier to follow is the FIGO classification, which was released in 2015. This also is a 3-tier classification, but it has simpler definitions. So the normal, like every other classification, says that there is no intervention required. Suspicious is there is a scope of waiting and correcting the correctable causes. It requires closer monitoring whether it reverts back to the normal trace or it moves to an abnormal trace. So identifying the correctable causes could be mother's positioning or crystalloid therapy to increase her hypertension or antibiotics to bring down her temperature. So these are all the correctable factors. And pathological is definitely clear-cut indications wherein these require immediate intervention and delivery of the baby. So in 2017, there was a meta-analysis which compared all these classification tiers and classifications which were released by FIGO, ACOG, NICE classifications and the recent FIGO classifications, and they have come up that the FIGO is easy to use. At the same time, each of its own classification has its sensitivity and specificity, and it was seen that ACOG was having low sensitivity but high specificity, but NICE has a higher reliability and higher sensitivity, so most of them use it for the intrapartum fetal monitoring. So why should we use and learn this classification? Why should we stick to these classifications? These classifications are followed worldwide, and these classifications are standardized. So once we use them in the standard format, it gives us a good leeway to stand in court whenever in the retrospection there is any legal problem. So it helps us take a good clinical decision, it helps us interpret the mother and the baby better, it helps us and gives us a proof as a document that we acted upon the changes and did the management plans, and this was in accordance to the international guidelines. So as a summary, we should always select our patient correct test, whether we are using to monitor her with intermittent fetal auscultation, or we are using continuous CTG monitoring, or we are just sticking her to ultrasound surveillance. We should also select from which gestational age we are going to monitor her. Is my setup going to allow me to salvage this baby and help the mother after doing a CTG? And we should be well informed about the guidelines and how to interpret the CTG, and then identify the sick fetus, so that by doing a CTG, this will benefit the fetus. So we have also brought with us a labor ward protocol book, in which we have the summation of all our protocols which we use for managing our various conditions, right from medical disorders in pregnancy and common obstetric. So we'll be handing over a copy to the society. So please feel free to contact us, our academics. It is easily, we can book post it to you. So I conclude my talk, and now I call upon Dr. Shanti to move on to the antenatal fetal monitoring. Thank you.
Good morning all. Thank you Dr. Subhashini for introducing us to the basics of electronic fetal monitoring. Now I will be taking you through antepartum fetal surveillance. The joy of or the miracle of childbirth has always been the same, and the joy that a mother experiences when she holds her baby for the first time has always been the same. So for us to make her journey fruitful, for us to take her pregnancy safely, we need to have a battery of interventions or investigations which help us keeping the baby safe and monitoring the well-being of the baby. So why should we go for surveillance? Surveillance is to identify a fetus at risk of intrauterine fetal demise, and to see if the baby is at risk of developing any neurological complications from chronic intrauterine hypoxia, and to intervene at the right time to prevent these adverse pregnancy outcomes. Surveillance is carried for cases for which stillbirth is reported to occur more frequently than 0.8 per 1,000 pregnancies. So the sequence of fetal response to stress is, initially there can be a decrease in the growth pattern of the baby. The secondary adaptive response is decrease in the fetal movements and change in the fetal heart rate patterns, and progressive decompensation leads to decrease in the variability of the baby because it affects the autonomic nervous system of the baby, and also it brings certain changes in the fetal heart rate pattern, and it also affects the renal perfusion of the baby, renal perfusion decreasing the urine output of the baby and leading to oligohydramnios, and if uncorrected may lead to the death of the baby. Some of the conditions in which testing is appropriate are maternal conditions like heart disease, autoimmune disease, chronic renal disease, diabetes type 1 and type 2, hypertensive disorders, and antiphospholipid antibody syndromes. Pregnancy-related conditions which require monitoring are hypertensive disorders of a pregnancy, and pregnancies where the mother complains of reduced fetal movements, extremes of liquor like oligohydramnios or polyhydramnios, a fetus which is growth restricted, in a pregnancy which is carried beyond the date of confinement, pregnancies with Rh isoimmunization, and a mother who had an adverse pregnancy outcome like a stillbirth or intrauterine fetal demise, and a multifetal gestation. So the various fetal assessment techniques are, fetal kick count is the basic one, and it is the oldest way of monitoring the baby, and fetal movement is the first sign of well-being of the baby. Second comes symphysiofundal height, where we measure the mother's tummy every week or according to the antenatal checkups, plot it on a graph and see how the baby is growing. By measuring the symphysiofundal height, we know whether the baby is an average for gestational baby or is there any risk of the baby having growth restriction. Coming to the electronic fetal monitoring techniques, the most commonly used test which we do every day in clinical practice is the non-stress test, and sometimes when it is non-reactive, it is followed by other modalities which require ultrasound like biophysical profile, modified biophysical profile, and Doppler studies. So coming to fetal activity, it serves as an indirect measure of the central nervous system integrity and the function of the CNS. Regular fetal movements are reassuring to us that the baby is doing well. These complex and integrated fetal movements require a certain amount of neuromuscular development and a normal metabolic state of the CNS. Fetal movements and mother's perception of fetal movements are unique to every mother and fetus. So we previously used to use certain counts like Cardiff count, Sadowski method, where we would say a mother should count 10 movements in 12 hours. But now we understand that the movements each mother experiences with her baby may be different. So now we have moved out to mindfulness. So where the mother knows that the pattern of movements, the quality of movements, and the quantity of movements have changed, and then she reports to her healthcare provider. So coming down to non-stress test, it was devised 40 years ago by Hamaker, who founded the concept that when a baby is moving, if the fetal heart rate accelerates, it indicates that the baby is doing absolutely well. It is a sign of fetal wellness rather than a sign of fetal illness. So it's a very simple, non-invasive test which tells us about the well-being of the baby. If the fetus is not acidotic or neurologically depressed, it will temporarily accelerate with a fetal movement. Giving an event marker to the mother lets us know when the baby is moving, and based on that we can correlate the accelerations on the trace. So heart rate reactivity is thought to be a good indicator of fetal autonomic nervous system which is not affected by hypoxia. So loss of reactivity is commonly seen with traces, and these are usually attributed to sleep cycles, as Dr. Subhashini has already mentioned about. But it could be a sign of CNS depression also. This test is basically based on contraction stress test, where it was seen that when there are contractions on when the CTG which is done during the contraction stress test showed 2 significant accelerations, the outcomes of the labor process was good. Absence of accelerations on baseline fetal heart rate was associated with adverse pregnancy outcome. So this is generally carried out for 20 minutes. If we find an acceleration of more than 2 accelerations of more than 15 beats per minute lasting for more than 15 seconds, we label this as a reactive trace. If there are no accelerations, then we continue the trace for another 20 minutes because we do not want to have a cascade of interventions by labeling it as non-reactive. In the next 40 minutes, if at all the baby does not show any evidence of movements or accelerations, then we go ahead with further monitoring. Non-stress test, if carried out between 24 to 28 weeks, it shows a non-reactive pattern in about 50% of cases, and between to 28 to 32 weeks, 15% may show a non-reactive pattern. When we are carrying out this test in a premature baby, we lower the threshold for acceleration because of the immaturity of the autonomic system. So we take a reactive trace as if there are accelerations of more than 10 beats per minute lasting for more than 10 seconds. So whenever we do a CTG, we might find variable decelerations. These variable decelerations are seen about in 50% of cases, and if they are non-repetitive and brief, that is if they are less than 30 seconds and it is an isolated deceleration, there is no need for us to worry. If at all these decelerations are repetitive, that is if we see 3 or more variable decelerations in a 20-minute tracing, then we need to further test this baby, and there is always a possibility of this baby showing non-reassuring pattern of heart rate during labor. If the decelerations, variable decelerations are lasting for more than 1 minute, then we need to take this trace very seriously, and then we need to further carry on investigations to know about the well-being of this baby. Coming to vibroacoustic stimulation test, this is a test which is used when the fetal heart rate does not show accelerations on a routine NST. An artificial larynx is placed close to the mother's tummy, and a stimulus, acoustic stimulus is given. This acoustic stimulus helps us in changing the quiet sleep of the baby to an active sleep state where the baby may show accelerations. We generally give this stimulus for 1 to 2 seconds, and if there is no response to this stimulus, then we carry it on for another 2 episodes of 3-second stimulus. Coming to contraction stress test, fetal response to a transient reduction in fetal oxygenation during contractions is the basis for this stress. So for a contraction stress test to be read, there should be 3 contractions during a 10-minute period, each contraction lasting for about 40 seconds. These could be spontaneous contractions or could be induced with nipple stimulation or by oxytocin administration. These days we are not doing the contraction stress test because we are worried that if at all we subject a fetal growth restricted baby to contractions, the baby may show patterns which may not be good for the well-being of the baby. We need an IV line for carrying out this oxytocin challenge test or contractions test, but it has a very low false negative rate, and a normal test always reassures us of adequate fetal oxygenation. There are certain contraindications for this contraction stress test, which is like preterm labor or where there is premature rupture of membranes, or there is a history of extensive uterine surgery, or if the mother had a classical C-section in earlier pregnancy, then we would not like to do a contraction stress test in these mothers. The advantage of an NST over a contraction stress test is that it does not require an IV line or oxytocin. False negative and false positive rates are higher than CST, contraction stress test in an NST. Coming to biophysical profile. Biophysical profile was devised by Manning in 1980. The fundamental principle of this biophysical profile is that the fetal heart rate, the fetal movements, the fetal tone, and the fetal breathing movements are all coordinated by centers in the brain which are susceptible to hypoxia. Each center has a different susceptibility to hypoxia and metabolic acidemia if the fetus develops. So the loss of these functions would affect the various things like fetal heart rate pattern, fetal tone, fetal movements, and fetal breathing movements. To this, we add amniotic fluid volume as the 5th parameter, which tells us about the long-term well-being of the baby. So when we do a biophysical profile, we have an NST, which is given a score of 2 if it is reactive. Fetal breathing movements, we observe for rhythmic fetal breathing movements which last for 30 seconds over a 20-minute period. gross body movements, that is 3 discrete limb or body movements which happen in a 20-minute period, fetal muscle tone, where we assess by the one episode of extension and return back to flexion, or a single episode of opening and closing of the fist of the baby. And then we measure the amniotic fluid volume. We use the deep vertical pocket method for assessing the amniotic fluid, where if we measure a pocket fluid of 2 centimeters vertically and horizontally, then we take it as adequate and we give a score of 2. So based on these 5 parameters, when we evaluate the baby, the chances of missing out any acidemia or hypoxemia in the baby is very low. So when we get a score of 8 or 10, we consider a biophysical profile as normal. A score of 6 is considered equivocal, and a score of 4 or less is definitely abnormal. If the BPP score is 6, it is equivocal and it should prompt us for further evaluation or delivery based on the gestational age. If the gestational age is more than 37 weeks, then we can consider delivery. But if it is less than 37 weeks, then we can consider repeating biophysical profile in the next 24 hours. If we find a biophysical profile of 4, then the management should be individualized and extended monitoring, if at all, is required, but it is always appropriate to deliver this baby. If delivery is not planned, if we have any constraints for delivering this mother, then the antenatal surveillance should not be performed. So then, following the classical biophysical profile, we have something called the modified biophysical profile, where we look at 2 fetal parameters. One is the non-stress test and other is the amniotic fluid index. This test decreases the shortening the time duration of the investigation, and the results are consistent with the biophysical profile. So when we look at this diagram, we see that the NST becomes non-reactive at a higher pH, then comes the fetal breathing movements, then comes the fetal movements, and the last one to disappear is the fetal tone. So as I have mentioned, the results of the modified biophysical profile are considered normal if the NST is reactive and the amniotic fluid volume is greater than 2 centimeters in the deepest vertical pocket. If either of these are not there, then it is a non-reactive test. So coming to oligohydramnios, we do not use the percentile method of amniotic fluid volume measurement, and it is always good to use the color flow box while measuring the amniotic fluid to not to miss a cord loop if at all it is there. So isolated oligohydramnios without any fetal or maternal risk, we consider delivery if the gestational age is more than 37 weeks. And if it is less than 37 weeks, it is either expectant management and it is based on the maternal and fetal condition. So the most important considerations in deciding when to begin testing, as Dr. Subhashini has mentioned, is when the baby is salvageable. At Fernandez Hospital, we take 26 weeks as the limit of period of viability, and 750 grams of weight of the baby is considered salvageable. So the gestational age at initiation and surveillance frequency are selected based on our own setup. So coming to the choice of test, no method has been evaluated in random controlled trials to be superior. It depends on multiple factors at the gestational age which we are testing, need for biometry, ability to monitor fetal heart rate, and the cost of the investigation, and also the availability of the investigation. So timing, we do starting testing when there is an increased risk of fetal demise is identified, when delivery for perinatal benefit is considered better, Generally, 32 weeks is the threshold for testing according to the international guidelines. The rate of stillbirth increases between 32 to 34 weeks, and that's the reason we start testing at this period of time. How reassuring is a normal antepartum fetal surveillance test? A normal test, it tells us that yes, the baby is doing well. It has a low false negative rate. So what it means when I say it's a false negative rate is the incidence of stillbirth within 1 week of a normal test is very less. It does not predict stillbirth related to acute changes in the maternal or fetal status, like if there is a cord prolapse or if there is an abruption or a scar rupture or scar dehiscence, the antepartum fetal surveillance cannot throw any light on the well-being of the baby. The efficacy, again, there are no randomized control trials. It has been observed that there are lower rates of fetal deaths in pregnancies that underwent fetal testing than without any testing, and even lower deaths in tested pregnancies in high risk compared to low risk untested group. In spite of unproven value, surveillance is widely integrated into clinical practice. Coming to the frequency of testing, it is again dependent on the maternal condition, the fetal condition, its growth pattern, and generally we repeat the investigations at weekly intervals. So the potential benefits and harms of antepartum fetal testings. The benefit is that we identify a fetus in whom we can do a timely intervention to prevent an adverse pregnancy outcome. The harm is that the false positive rates of the tests increase the intervention rates, need for additional tests, and may also predispose to iatrogenic preterm birth. And it also adds to the anxiety of the mother and to the cost of hospitalization. So when we look at the various investigations used for antepartum fetal surveillance, the contraction stress test has a false negative rate of 0.04%, the highest. The NST has the false negative rate of 0.2 to 0.65%. When we see that the possibility of a stillbirth rate within 1 week of a normal test, the least is with the contraction stress test and the highest is with the non-stress test. So the NST as a stand-alone test has a lower predictive accuracy for hypoxemia or acidemia if non-reactive. So when we follow it by modified or a full biophysical profile, it is associated with a stillbirth rate of 0.8 per thousand in the following week, which is attributable again to acute events not reflected in the fetal heart rate or biophysical variables. So the difference between these levels of reassurance becomes increasingly significant for populations with a higher priori risk of stillbirth. The BPP or the biophysical profile provides a more accurate prediction of the current fetal status and the lowest false negative rate for stillbirth in the following week. So at what gestational age do we start testing? In cases with fetal growth restriction, it starts at 32 weeks when there is increased resistance in the umbilical artery, and also in absent and diastolic flow in the umbilical artery. Multifetal gestation, we generally start in 32 weeks in MCDA twins if it is uncomplicated, and if it is a complicated monochorionic gestation, we start it at the diagnosis. In DCDA twins, monitoring generally starts at 36 weeks of pregnancy. In chronic hypertension well controlled with medications, we start testing at 32 weeks. In gestational hypertension or preeclampsia, again it is individualized. From 32 weeks onwards, we generally start testing. In diabetes, when they are controlled well with diet, there may not be any need for testing, but if they are poorly controlled or if they are insulin dependent, we start at 32 weeks. In autoimmune disorders, we start at 32 weeks of pregnancy. And if the maternal age is more than 35 years, then also we start at about 34 weeks of pregnancy. If there has been a previous stillbirth in the previous pregnancy, we start at 32 weeks. And in reduced fetal movements, we start a diagnosis. If the mother is reassured of the fetal movements, then we do not follow up these tests. And in post dates, we start at, we do AFI and NST at 40 weeks and 40 plus 3 weeks. And if the follow-up of a test with a normal test report is, if there is no recurring indication, then we need not repeat the test at all. So follow-up of pregnancies with a normal result and chronic condition as an indication for testing. It depends on the status of the baby and the risk for the mother, and then we follow up them with weekly testing. So whenever there is an abnormal test, we look at the clinical picture. So if there is an acute maternal condition like diabetic ketoacidosis, pneumonia with hypoxia, there can be a high false positive rate. After the correction of the maternal condition, we repeat the testing and follow up the baby. And if the mother is stable, then we follow the systematic approach. The advantage of correcting the maternal condition is that we need not do any unnecessary interventions. If at all, if the mother comes with reduced fetal movements, if the NST is normal, we need not follow up with any additional tests. If at all the mother is still not comfortable with movements, then we go ahead with a modified biophysical profile or a biophysical profile. If the biophysical profile is normal, we keep the mother under follow-up. If it is less than 6, we deliver. If it is less than 4, we consider immediate delivery. This is a case scenario where a mother has come at 28 weeks with preterm premature rupture of membranes. The mother was monitored. Speculum examination showed a clear leak. The mother had no signs of chorioamnionitis. The mother was inpatient for 72 hours. We did a growth scan which showed an average for gestational age baby, and then the plan was made that if everything fine, then she would have a weekly NST and AFI and estimated weight once in 2 to 3 weeks. The aim was to deliver this baby at 34 weeks. So at 32 weeks, when this mother came for a regular antenatal checkup, there was a prolonged deceleration. She was taken for an emergency C-section where she birthed a 1.7 kg baby with an UPGAR of 4 and 5 at 0 and 5 minutes. This is another case where this mother, a primey at 36 weeks of gestational age, was GDM on insulin, had diabetic ketoacidosis. At presentation, this was her NST, which showed decreased beat-to-beat variability and no accelerations. After the correction of the maternal condition, when we repeated the CTG showed a reactive pattern with good variability and accelerations. This is a mother who had come with pain abdomen. This CTG shows decreased variability throughout and with a deceleration here. And she was taken up for an emergency C-section, a birthday, a live healthy baby. This is another case where a primey at 37 weeks, she's an unbooked mother, reported to the labor ward. She had come from another hospital where she had refused a C-section and had a CTG in her hand, which showed this pattern. So when we see this pattern, the baseline is at about 100 beats per minute. If we read this CTG, the variability is good, seems to be having some accelerations, not definitive, but the maternal pulse rate is missing. So whenever we see a CTG with low baseline, we look at the maternal pulse rate. And when the CTG was started in our unit, this was the CTG. So based on the CTG, we would say that there is bradycardia, baseline rate of 100 beats per minute with good variability, accelerations not definitive. But an urgent bedside ultrasound showed an intrauterine fetal demise. So here what we were interpreting was the maternal pulse rate. So the cardinal rule is to differentiate the maternal pulse from the fetal heart rate. So always auscultate with Doppler, localize the fetal heart before putting the probe for the CTG. And whenever the baseline is low, we should always suspect maternal pulse. So the newer machines have this benefit of having the maternal pulse rate recording so that we know that there is a difference between the two. This is another example where there is a low baseline heart rate. Variability is good, but accelerations are not there. This is a mother who at 37 weeks, she was an unbooked mother, came with this trace. This is a trace with a baby having arrhythmia where the baseline fetal heart rate is around 80 beats per minute with somewhere we can see few dots and lines around 150 beats per minute. So this was detected to be a fetal arrhythmia. I would like to share this case, which is a second gravida, para 1 live 1 with previous C-section who comes to emergency room at 35 weeks of gestation with a complaint of reduced fetal movements and tightness of abdomen. CTG was reactive, but the mother was persistently complaining of decreased fetal movements. Scan done the subsequent day showed an average for gestational age baby, and when we did an MCA, middle cerebral artery peak systolic velocity, it showed the wave flow pattern in the anemic zone. And then this was followed up, this was suspected to be fetal anemia, and KB test was done which showed positivity. So she had an emergency C-section and delivered an anemic fetus who required neonatal support and received 2 units of LRBC transfusion. So one significant cause for decreased fetal movements and a non-reactive trace could be feto-maternal hemorrhage. Insignificant hemorrhage of fetal blood into the maternal circulation is usually common and is sometimes unrecognized. Significant hemorrhage can lead to fetal compromise and perinatal death. Massive fetal hemorrhage has been demonstrated in approximately 4% of stillbirths. That's the reason we use KB test for evaluation of stillbirths. And moderate to severe fetal maternal hemorrhage can occur in 0.3% of all live births. So that decreased fetal movements could be the only history suggesting this possibility. So we should be aware of this condition. When we connect an NST for a mother with decreased fetal movements, when we see a sinusoidal pattern or decreased variability with or without tachycardia, we must suspect feto-maternal hemorrhage and follow up her with a MCA Doppler. So NST as a stand-alone test has a high false positive rate. CST has its own limitations and is difficult to perform. So most antenatal testing will use either modified biophysical profile or a biophysical profile. These tests are generally considered equivalent in terms of the test performance. So biophysical profile is usually carried twice weekly or to a maximum of 4 times in a day in the IP setting. And if at all it is non-reactive, it has to be followed by biophysical profile or Doppler ultrasound. The fetus is calling at us. As I am a fetus in the womb, I fear that it may become my tomb. If only I could give a shout to make my obstetrician get me out. So it should be used, the antepartum fetal surveillance tools should be used judiciously, and using them have not definitely demonstrated an improvement in the perinatal outcome. So all indications for antepartum fetal testing should be considered relative. Thank you.
Thank you, Dr. Shantishri. So in the previous 2 talks, we have gone through the basics and classifications of electronic fetal monitoring. In the next talk, we have gone through the antenatal fetal surveillance. We have given you a short preview of when to start antenatal fetal surveillance, how to monitor the mother, and what are the various conditions which have been given in the recent ACOG guidelines. So like time and again, we would like to reiterate this fact that CTG is not a stand-alone parameter which should be dependent upon to take a clinical decision. Please take a holistic view of the whole clinical condition of both the mother and the fetus, and whenever you feel that the CTG is not reassuring or it is creating a doubt of a hypoxic fetus, it is always better to take the help of other modalities like the biophysical profile, all the ultrasound and Doppler, and take a cumulative decision in delivering the mother or pulling out the baby. And always, always when you put a CTG, please be very selective on the cases on which you start. Even today, from all my seniors, all we have learned is even if we sign a CTG trace, we always look back as to why this CTG was started for this mother. What is the indication for which a CTG was started for this mother? And we should be in a position to label the trace correctly, interpreting it correctly, at the same time picking up whatever the changes are, because we have a baby inside who is calling for help. And at the same time, before taking a cumulative decision, always take the help of the clinical condition and the additive modalities which are present. So next talk is on the recent recommendations and modifications protocols of induction of labor. Can we continue with the talk, ma'am, or there is a tea break, I am informed? Yes, questions, actually we have put it at the end of all the talks, but if you have any questions right now of these two talks, we will be glad to answer. Yes, correct, sir. So next remarks, please.
Record which we must keep regarding the tracing?
Shanti.
Only admission test, or though we are continuously monitoring the patients, the tracings, how medico-legally how many tracings at what time should be made?
Ideally, these tracings should be kept for 16 years.
No ma'am, I'm how frequently? We have the monitor going on continuously.
It depends on. After admission, actually, if it is a low-risk mother, we need not do an admission test or an initial NST also. If it's an average for gestational age baby, the mother has no risk factors, she is happy with the fetal movements, she is in early labor, then there is no need for doing an NST.
And sometimes,
Even for unbooked cases.
sometimes
If we have a scan showing that it's an average for gestational age baby, the mother has no medical disorders or no other complications, then there is no role for doing a booking NST or an initial NST also. It is only for our own reassurance we are doing it, but not for them.
Okay.
We do not do an NST for a low-risk mother at Fernandez Hospital also.
ma'am, if it turns out to be distress or decelerations, we are in a hurry to take the patients for sections. So is it mandatory to document all the, abnormal CTGs before we take the patient for
I think definitely the action is more important. In retrospection, we can always document, but in retrospection, documentation is also important.
Thank you.
Because
Documentation is ultimately the thing which saves us, which gives us a leg to stand on.
Because if we have acted upon a CTG, we should be able to substantiate, and that's why we have to follow a clear-cut classification which is worldwide applicable, and there is no contest to it. Like we have definitions for chorioamnitis, and it is worldwide. When we say that my mother had chorioamnitis, this mother, if she birthed at USA also, would have chorioamnitis, right? So the same way, when we have acted upon a pathological CTG, this CTG will be pathological in any part of the country or any part of the world.
If properly interpreted.
Yes.
Ma'am, I want to ask one question. As you said, routine NST monitoring for normal patients who are not in labor, we have to really think very hard before doing for those patients. So there are scenarios when patients are in ICU, they are near term or full term with dengue, platelet count very low, who are at the very high risk of abruption. Such cases, should we not, what should we do? Like medico-legally also we have to be safe in those cases. So how do we document and how frequently we should do it?
See, I think in any mother who is in an acute illness, who is in ICU, who is in a critical level of any particular illness, always the thumb rule is mother is the priority.
Stabilization.
Yes. So first, always focus on the maternal stabilization, because whatever the changes is happening in her physiological state, in her homeomilieu interior, is going to reflect into the CTG. Definitely, maternal stabilization is a priority. After maternal stabilization, hand in glove fetal evaluation is also necessary. So, fetal evaluation, it depends upon how you do it. If you feel that the mother is stable enough, her parameters are all fine. So, connecting a CTG at that period of time, like I said, is definitely one modality. We should always do a second other modality of ultrasound to see how the baby is growing inside. Is there an acute oligohydramnios which is associated with acute dengue fever, or is there any fetal growth restriction because of some acute febrile illness of the mother and suddenly the Doppler compromise has come, the growth lag has come. So definitely fetal evaluation, NST can be done provided you are in a position to interpret it and know the changes of the maternal impact into it. If it is a term mother, it's a dengue mother who is in febrile phase wherein all her parameters, all her endocrine systems, everything is fine. We are treating her with crystalloid therapy. A baseline CTG can be done. But at the same time, you should be in a position to interpret well. At the same time, take the help of other modalities to substantiate. Just in case before putting the CTG, you should be in a state to say that if this CTG comes pathological, arrange things to deliver her. See, there are thumb rules like in acute dengue fever because of maternal complications. We usually wait for the mother to come into the resolution phase. We do not deliver her. So in such cases also, you can take the help of other modalities. But at the same time, a single NST at admission depending upon her period of gestation can be done. So you have to individualize the case. So all said and done, mother is first.
Can I add something to this? Whenever we have a mother with dengue in a critical phase, as you have mentioned, we should know that if at all I'm connecting her to a CTG machine, do I have the resources? If at all the CTG turns out to be non-reactive or non-reassuring, then do I have resources to deliver this baby? So do I have an SDP on the agitator so that if at all needed, if I have to take her for a C-section, I have backup to control the bleeding. So with this background, you can connect her to a CTG. That is, we need to be prepared for the worst also.
Good morning, madam. You have mentioned about the acoustic stimulation, artificial larynx. So my question is, is it possible to use the mobile on vibratory mode, and can it give the same results? Because the artificial larynx may not be available with all of us. So can it possible?
So nowadays we are having and facing questions as if parents, would-be parents are coming and asking that husbands are complaining that my wife is having more mobiles on screen time. So I don't know how much he would be really reassuring if you put the mobile directly on the tummy. So,
No, because
like it's on the lighter side of the question. So vibroacoustic stimulation is one of the methods wherein we are trying to check whether we are falsely interpreting that the baby is not happy inside. So we are giving a simulation to just bring it to an arousal state or an awake state wherein we are happy that okay, we are not misinterpreting the sleep cycle of the baby. Okay, so that has a typical vibration threshold and a frequency which is scientifically determined. Till now I have never seen a vibroacoustic device. So I'm not very sure whether we can really use a vibratory mode of a mobile to such an extent that it will pass to the fetus and it will stimulate the fetus.
Because whenever we are doing ultrasound, and I have seen, that's why I'm asking, when you put a mobile on vibratory mode, definitely on ultrasound mode, the fetal movements will be increasing. So that's why I ask whether instead of artificial larynx, I think this can be used.
We usually give a little, shake to the mother's tummy. That itself awakes the fetus. So I have not seen this practice much, sir.
Ma'am, will you put some light on unprovoked decelerations that we come across? Like
Yes, it is called unprovoked because the mother is not in labor. So whatever different kind of decelerations we have learnt across early, variable, late, pathological decelerations are all in labor. So already the mother is going through labor and this labor contractions can cause this changes because of pooling of blood in the intervillous space which causes this deceleration and the vagal response. So the contraction itself is the stress. So that's how the deceleration happens, and then we interpret whether this stress is okay to keep the baby inside, or the stress is magnanimous, that it is affecting the baby, and we pull out the baby. So that's the basic funda behind. But the unprovoked thing is, this is usually seen in antenatal mothers. Okay, so the unprovoked itself is a definition. It is episodic, it happens it happens sporadically, and it happens in antenatal mothers wherein the mother is not in labor. So it's called unprovoked, and that's why so much of significance to it.
Yeah, that's what it means. It is the thing that you should deliver the baby.
Yes,
So-
depends. Like again I said, just one unprovoked deceleration on the NST, depending upon the gestational age, you have to corroborate. See, I cannot stand in court saying that I did a CTG at 32 weeks of my mother and there was an unprovoked deceleration and that's why I delivered her. You have to say that definitely that is one prong of your statement, but the other prong is I did an ultrasound, I saw that the BPP was very less, I did an ultrasound, MCA PSV was very bad. So all that adds, I did an ultrasound, I found out that it was a severely fetal growth restrictors, or maybe you find an REDF on a Doppler. And that adds up that, okay, this CTG also showed an unprovoked deceleration. That's how it gathered my attention. Otherwise, I would not have done a scan to that baby. So this accumulates and gives a whole to your clinical decision that whether I go ahead and pull
So
out.
if it is unprovoked deceleration, then you should go for BPP. But that unprovoked deceleration of 80 will, shoot
Yes,
my
but,
BP.
but it recovers back, right? If it is an unprovoked deceleration and it has come back in a specified time, and even the deceleration that we drop is having good beat to beat variability, is coming back to baseline in a shorter time, it gives you time. I'm not talking about unprovoked decelerations which are go into acute bradycardia. Like Dr. Shanti has showed you a PPRM case which was followed up with us, acute at 32 weeks. They just came for antenatal checkup. We connected the CTG just like every other week. She used to come after 28 weeks, and that went on. She was not in labor. That went on into acute bradycardia. It didn't pick up. We had to really do a crash cesarean section on her, and intra-op there was abruption. So those things, no dilemma.
Thank you, ma'am.
No, whenever
Madam,
we are talking,
all my scans I do myself. Of course, the sonologist come to me every week. Most of the, many times I see when I'm just putting the probe, fetal heart all of a sudden becomes slow. Again, will be in an anxious state. Within few seconds or sometimes with less than a minute time, they pick up normally and go well. I don't think we need to attach much significance for that unless the decelerations are persistent. That's what I feel.
Yes, correct, sir. So maybe on ultrasound, we are looking at a variable deceleration which would have mapped on a CTG machine at that point of time, which was very short period and has regained in a very short period. So that you have seen on an ultrasound and it has recovered on its own. So definitely what you say is absolutely correct. Short span of decelerations or short drop of fetal heart rate which are not prolonged, which are coming back to the normal, is definitely not clinically significant.
can I add
excuse
something
me,
to it?
madam.
When we are seeing a CTG, if the variability is good, if there are good accelerations, and there is an episodic unprovoked diesel which recovers on its own, going to the baseline with good variability in that short span of deceleration, then we need not worry about that deceleration. If we have repetitive unprovoked decelerations, like 3 or more unprovoked decelerations in a 20-minute period, then it has to be followed up with an ultrasound evaluation of the fetus. If the variable deceleration which we have seen is lasting for more than 1 minute, then it needs evaluation. These are from the ACOG 2017 guidelines, which give us clear guidance about interpreting an antepartum CTG. So if it is less than 30 seconds, if it is a single unprovoked deceleration, the preceding trace showing good variability with accelerations, the trace coming back to the same baseline after the deceleration, then we need not worry about that deceleration. Otherwise, we will get worried, we will make the mother anxious, we will start the intervention, we will end up in doing a C-section.
Madam, what is the protocol you follow for inducing contractions for a contraction challenge test?
We don't do the CST test, sir. Even now also it is not recommended because CST needs an IV line. It is an interventional because you add oxytocin without any indication on an antenatal mother just to see whether the baby is having Mother is getting contractions, and then we see how the baby is. It has been seen in international literature review also, we miss out the reactions of a baby. Maybe we miss out FGR baby also when you are putting a contraction stress onto her. So that is already a stressed out baby inside, and we are adding an additional stress outside. So it's obsolete. It is not practiced now, sir. We don't do a CST at Fernandez. So can we move on to induction labor, the recent developments and the updates, sir? Any other questions? You can please write it down. We will take it at the end of the talk. So now I invite upon Dr. Siri to take the talk on induction of labor.
Very good morning to everyone. After that extensive discussion on basics and antepartum surveillance of the baby, let's move on to the next topic, induction of labor, which is the most common, important, and an effort from the obstetrician side to avoid a cesarean section when it is not safe to continue the pregnancy, both from mother side and the fetus side. But also, do we do it at right time? Are we doing an unnecessary intervention and increasing the cesarean section rate? Is what we need to look at. So today I will be going through you to all these objectives to define induction of labor, what are the indications, contraindications, what is the optimal time for induction, what are the methods, recent guidelines on which method is better, and the complications associated with induction of labor. Induction of labor is iatrogenic stimulation of contractions, which should be done when the benefits of delivery to either mother or fetus outweigh the risks of pregnancy continuation. The incidence of induction of labor worldwide is quoted to be 10%, with the least being in African countries, and in US and UK it is around 20%. In a high-risk unit, the induction of labor incidence can be as high as 32%, the most common indication for induction being diabetes, followed by hypertension, pre-labor rupture of membranes, and fetal growth restriction. A list of indications for induction of labor. The most common is a prolonged pregnancy, pre-labor rupture of membranes. Coming to medical disorders, hypertensive disorders, diabetes, renal diseases, connective tissue disorders, and obstetric cholestasis are most common which we see. And the fetal indications would be fetal growth restrictions, oligohydramnios, non-reactive NST, isoimmunization, and fetal demise. What is the optimal time for induction of labor? This depends on what kind of indication we are looking at, and what is the indication and what is the best time, we will go through it. For prolonged pregnancy, which is uncomplicated, singleton, offer induction of labor at 41 weeks. Beyond 41 weeks, it is seen that the risk of cesarean section and assisted vaginal birth are increased risk of NICU admissions, and also stillbirth and neonatal death. When we are crossing 40 weeks, it is always better to call the woman for biweekly monitoring, ask her for fetal movements, check per abdomen, look for symphysofungal height, look clinically for oligohydramnios, check her BP, do a modified biophysical profile, that is AFI-NST, twice a week, do a stretch and sweep, and if everything is well and still she doesn't progress, induce her at 41 weeks. Studies have shown that induction at 41 weeks versus 42 weeks, induction at 41 weeks has shown a reduced perinatal mortality rate. The number needed to treat to prevent one case of perinatal mortality was 175 only, and the rates of NICU admission and macrosomia have reduced, and they have found that there is no difference in cesarean section, assisted vaginal birth, and obstetric anal sphincter injury between 41 and 42 weeks. Hence, an uncomplicated singleton pregnancy offer induction at 41 weeks. Looking at term pre-labor rupture of membrane, whether to do active management or wait for her to set into labor within 24 hours. It was found that active management, that is immediate induction, reduced the time from rupture of membranes to birth, reducing the maternal infection rate and NICU care, without increasing the cesarean section or assisted vaginal birth incidence. Induction of labor was also viewed as a positive experience by the mother. Induction of labor can be done either with prostaglandin E2 or oxytocin, which are usually effective, but prostaglandin E2 was associated with higher rates of chorioamnionitis, and mechanical method is not indicated when there are rupture of membranes. Pre-labor rupture of membranes, when it happens at different gestational ages, if it is term, as I already told, proceed to delivery immediately or wait for expectant management for 24 hours after taking the woman's consent. If it is a late preterm, that is between 34 to 36 plus 6 weeks, offer her about expectant management or proceed to deliver if the woman requests for immediate delivery. If it is a preterm, that is between 24 to 34 weeks, offer expectant management, give a steroid cover, magnesium sulfate for neuroprotection if you are expecting that she will deliver before 32 weeks, and if it is less than 24 weeks, it is always expectant management versus induction with antibiotics. If it is less than 24 weeks, there is no role for steroids or tocolysis or magnesium sulfate for neuroprotection. Moving on to hypertension in pregnancy, the timing for delivery, if it is gestational hypertension, is 37 weeks, and for preeclampsia without severe features is also at 37 weeks. If she has preeclampsia with severe features, deliver her at 34 weeks. For chronic hypertension, which is well controlled, not on medication, we can take her up to 38 to 39 weeks. With hypertension on medication, well controlled, we can induce her at 37 weeks, but uncontrolled hypertension, better to deliver between 36 to 37 weeks. Irrespective of gestational age, the indications for delivery in hypertensive disorders are intrauterine fetal demise, eclampsia, HELP, pulmonary edema, acute kidney injury or metabolic acidosis, abruption, or severe uncontrolled hypertension. Moving on to the next indication, diabetes in pregnancy. If it is a gestational diabetes, well-controlled sugars only on diet and exercise, offer induction of labor at 39 to 40 weeks. If it is very well controlled and with the women's compliance, we can take her up to 41 weeks also. With well-controlled sugars on medication, better to induce between 39 to 40 weeks. If it is poorly controlled, we need to individualize the case and offer induction between 38 to 39 weeks. For pre-gestational diabetes mellitus, with well-controlled sugars, induce at 39 weeks, but when there is any vascular compromise, poor control or previous stillbirth, better to induce her at 37 to 38 weeks. For obstetric cholestasis, there is a recent guideline in June 2022, the Green Top guideline, which says they have classified the obstetric cholestasis into 3 grades, mild, moderate, severe, based on the bile acid level. It says that there is no test that can predict the increased risk of fetal demise. But at the 19 to 39 micromoles of liter of bile acids, they have seen that there is no difference in the risk of stillbirth up to 40 weeks. In moderate disease, the risk of stillbirth increases after 38 weeks, whereas in severe disease that is more than 100, the risk of stillbirth is high after 36 weeks. Hence, we need to offer induction at 36 weeks for a severe disease. For a previous cesarean section, when we are offering her trial of labor after cesarean section, we should always remember that there is a increased risk of emergency cesarean section and uterine rupture, and the induction of agent that is preferable and the methods that are not suitable, and also counsel the woman and ask her for her choice. Induction of labor after a previous cesarean section is always mechanical. We need to keep this uterine rupture in mind, but if we induce, the risk of uterine rupture compared to spontaneous labor is low. If it is a favorable cervix, do an artificial rupture of membranes and oxytocin. If it is an unfavorable cervix, go for a mechanical method. The guidelines on induction for previous cesarean section say that pharmacological methods should not be used, and ACOG says that there is lack of data on induction of labor for previous cesarean section, but balloon catheter can be used as an option. But overall, all guidelines says not to use prostaglandins as a method of induction. Oligohydramnios can be taken as an AFI of less than 5 centimeters or a single vertical pool of less than 2 centimeters. But when AFI is taken as a cutoff, the induction rates were seen to be higher. Isolated oligohydramnios is never an indication for a preterm delivery. Always follow up the woman with a biweekly monitoring when there is oligohydramnios in preterm period. But when there is isolated oligohydramnios at term, we need to consider delivery. For fetal growth restriction, we follow this Gratakos classification. It's always wait up to 37 weeks if it is stage 1 FGR and induce the woman at 37 weeks. What are the parameters that we take? If the estimated fetal weight is less than 3rd centile or CP ratio is less than 5th centile, MCA pulsatility index is less than 5th centile, or mean uterine artery pulsatility index more than 95th centile. If these are not there, then we can go up to 40 weeks considering it as SGA. But in presence of any of these, the baby comes into stage 1 FGR and we need to deliver at 37 weeks. Before 37 weeks, any time the baby has absent end-diastolic flow, it is not an indication for induction of labor. It is a contraindication for vaginal birth and we need to plan a cesarean section immediately. Moving on to multiple gestation. If it is an uncomplicated multiple gestation with the dichorionic twins, it is 38 to 39 weeks. Monochorionic diamniotic, it is 35 to 37 weeks. And monochorionic monoamniotic, it is 32 to 34 weeks. For a complicated multiple gestation, that is a DCDA twin with an isolated FGR, it is always induction between 36 to 37 weeks. And an MCDA with isolated FGR, it is between 32 to 34 weeks. Coming to advanced maternal age, it was seen that a woman at less than 35 years had no difference in the incidence of stillbirth at 37 to 38, 39 to 40 or 41 weeks. But when her age goes beyond 35 years, the risk of stillbirth is 1 in 1,000 here, but it increases to 1 in 700 and after 39 to 40 and 41 weeks. If she crosses 40 years, the risk of stillbirth is much more higher even at 37 to 38 weeks. Hence, it is always better to offer induction of labor at 39 weeks if a woman is advanced maternal age, that is about 35 years. It is always better to take a consent, give her informed consent, discuss the plan in the antenatal period, offer her induction at 39 weeks, and if she wishes to wait beyond that, it is always better to take a consent from her and continue the monitoring. What are the contraindications? A non-reactive NST, a transverse lie, umbilical cord prolapse, a prior classical cesarean section incision, and prior uterine rupture, active genital herpes, and placenta previa are absolute contraindications for induction of labor. Before starting induction of labor, counseling is very important. We need to talk to women about what is the indication, why we are planning to deliver her before she sets into labor, when we are going to do, what is the optimal time according to her indication, where we are going to do, does she require admission or not, and what kind of induction she will require. We need to arrange and explain her about pain relief, support, and also definitely inform her that she will take time to deliver. It is not that the day she admits for induction is not the day she delivers, because most of the times we see that women are very disappointed that they have to wait for 2 to 3 days for her to deliver. So informing her that it takes time for her to progress into labor is very important. What are the alternate options that are available other than induction of labor, and what we need to do if the induction fails also should be discussed with the woman. What do we have to assess before starting induction? Is she a primary or multiparous? What are the maternal risk factors? Because if she is a high BMI, there are high chances for a failed induction, which we should keep in our mind and also inform her prior. Are there any other risk factors for the impact of choice of induction, like FGR with Doppler compromise, or are we looking at the correct gestational age? Did we do the dating correctly? And the choice of induction also depends upon the gestational age. If it is preterm, we would try to avoid few induction agents, which I would like to tell later. Are there any maternal risk factors for uterine rupture and the impact of the choice of induction agent, like previous cesarean section, previous surgeries? And on clinical examination, are the membranes intact or they are ruptured? Is there any uterine activity? Is the cervix ripe? And look for the Bishop score before starting induction. The methods that are available are membrane sweeping, amniotomy with oxytocin, pharmacological methods, that is prostaglandins, and mechanical methods, cervical ripening balloon or a Foley's catheter. Always offer membrane sweeping at 39 weeks with digital separation. This has shown to increase the rate of spontaneous vaginal delivery and shorten the duration for induction to delivery interval, and this has no harmful effects. We need to inform the woman that she might have some discomfort and some vaginal bleeding after the membrane sweeping. We always need to take a verbal consent, and we can do a repeat sweep if she doesn't progress in the next visit. Studies have shown that membrane sweeping versus no treatment and prostaglandin or amniotomy, women were more likely to experience spontaneous onset of labor, less likely to experience the formal induction, and there was no difference in vaginal delivery, cesarean section or adverse outcomes when the woman was subjected to membrane sweeping. Moving on to the pharmacological and mechanical methods. The most common pharmacological methods, prostaglandins, are PGE1 and PGE2. PGE1 is used as a low dose, that is 25 micrograms. PGE2 is available either as a tablet, gel, control release vaginal delivery system. But with us, we have only gel and the vaginal delivery system. The mechanical methods that can be used are Foley's and Cook's cervical balloon. The methods that are not to be used are oral dinoprostone, IV dinoprostone, hyaluronidase, steroids, estrogen or relaxin. And non-pharmacological methods that are not to be used are osmotic cervical dilators, herbal supplements, acupuncture, homeopathy, castor oil, hot baths and proctoclysis. A small note on prostaglandin E2. This increases the chance of vaginal delivery in 24 hours, but there are chances of uterine hyperstimulation with FHR changes, but this doesn't affect the cesarean section rates. The likelihood of cervical changes with no increase in assisted vaginal delivery was found with prostaglandin E2. This is available either as gel or the pessary, and there was no difference between the effectiveness of both the delivery systems. Comparing the sustained versus intravaginal gel, increased rate of vaginal delivery was found with pessary within 24 hours, but with sustained release avoids the need for repeat vaginal examinations also, which is much more comfortable for the women. Comparing the different preparations of dinoprostone, the sustained release comes as Propes, which contains 10 milligrams of dinoprostone in a time release formulation, and this releases the medication at the rate of 0.3 milligrams per hour, which is kept for 24 hours. This should be removed if the woman sets into active labor or she ruptures her membrane or we find a uterine hyperstimulation. We can always start oxytocin after 30 minutes of removal of the insert. When we come to dinoprostone gel, it comes as a 0.5 milligrams gel per 3 grams syringe, which is intended for intracervical administration. The dose can be repeated every 6 hours interval to a maximum of 3 doses, and we should not exceed 1.5 milligrams within 24 hours. And oxytocin should be started only after 6 hours of last dose. Comparing these two, the other advantages of Propes are, if there is any hyperstimulation, this can be removed immediately and the effect of the medicine comes down immediately. But with gel, once it is inserted, it is difficult to retrieve it. This is a Propes pessary which is inserted between the index and middle finger. It comes with a thread which is left in the vagina. Once inserted, it should be rotated to 90 degrees so that it is at the transverse position in the posterior fornix. Moving on to misoprostol, this is inexpensive, which can be given through different routes and different doses, stable at room temperature and easy to store and transport. Studies comparing oral versus vaginal misoprostol have shown that oral route has less likelihood chances of a vaginal birth within 24 hours, but it comes with a reduced rate of uterine hyperstimulation with the FHR changes, and there is no difference in cesarean section rates between oral and vaginal formulation. Comparing oral PGE1 versus vaginal PGE2, again the oral PGE1 has lesser chance of vaginal birth and fewer cesarean section rates. Oral PGE1 versus Foley's showed that Foley's had lesser chances of vaginal births. Comparing prostaglandin E1 and E2, more likelihood to have a vaginal birth, 32% less likelihood chances of requiring oxytocin augmentation, but there is no difference in hyperstimulation or cesarean section. So when compared to dinoprost, misoprostol was found to have a better chances of having a vaginal birth. Summarizing all of these studies, it was found that both vaginal and oral misoprostol are effective. Misoprostol low dose oral had fewer cesarean section rates compared to dinoprost. Vaginal misoprostol had more vaginal births than oral, but may result in adverse events. The contraindications for induction with pharmacological agents are hypersensitivity to the drug, prior uterine surgery, pre-existing uterine activity, or a concern for fetal status. Moving on to oxytocin. When oxytocin was compared with expectant management, there was lower incidence of vaginal delivery within 24 hours when we waited for expectant management. Oxytocin versus prostaglandin has shown that higher incidence of vaginal delivery was not achieved within 24 hours with oxytocin, reflecting in the guidelines that prostaglandin is the first line approach. Comparing the mechanical methods, transcervical balloon catheter, the action of the balloon catheters is that they release prostaglandin F2 alpha from the decidua and membranes or PGE2 from the cervix. The advantage of mechanical methods are they come in the low cost, low risk of tachysystole and fewer systemic side effects. The disadvantages are they have the risk of infection, disruption of a low-lying placenta and discomfort upon manipulation. Comparing the balloon versus vaginal prostaglandins, balloon was associated with a reduced risk of hyperstimulation with FHR changes, but there was no difference in the vaginal delivery not achieved within 24 hours or cesarean section rates. These are the two methods of balloon catheters that are available. One is Foley's, which comes with a single balloon, and a Cook's, which comes with a double balloon. The Foley's has a single balloon which is directly inserted intracervical, but Cook's comes with two balloons, one is intracervical and one is in the vagina. The Cook's has two balloons which are inflated with 80 cc normal saline. Comparing the double versus single balloon, there was no significant difference in the cesarean section rates, vaginal delivery, mean time to delivery or Bishop score improvement, and they had similar rate of pyrexia or postpartum hemorrhage. Both had similar effectiveness and safety, but compared to Cook's, Foley's is cheaper, widely available, accessible, and longer storage and logical choice. Moving on to single agent methods for cervical ripening, the parameters that are compared for amongst all these agents were to look for effectiveness, mode of delivery, adverse effects, and the preference that was given was the effectiveness of each method on achieving a vaginal birth, minimizing tachysystole and avoiding cesarean delivery. When all the methods were compared, it was found that no method is superior in every parameter. The most effective agent for achieving a vaginal birth was misoprostol. Most likely to achieve vaginal birth was misoprostol oral. Both vaginal and buccal had highest rates of hyperstimulation, and Foley's came with the least adverse effects. Comparing sequential versus concurrent induction, concurrent balloon with oxytocin versus sequential showed concurrent induction with balloon and oxytocin had higher chance of vaginal birth, and the same was found with balloon and prostaglandin or oxytocin. There is a choice of inpatient versus outpatient induction. If the woman stays close to hospital and she is low risk and we know that she is compliant, we can give a choice of outpatient induction, either with mechanical or prostaglandin, and this is more cost effective, but this is not practiced universally. The various guidelines on induction of labor also suggest the same. As we discussed till now, the WHO recommends oral prostaglandin 25 micrograms every 2 hours, vaginal prostaglandin 25 micrograms every 6 hours, and prostaglandin E2, oxytocin, and misoprostol for IUFT. For non-pharmacological methods, WHO recommends membrane sweeping and balloon catheter, whereas in Indian guidelines, misoprostol has not been approved. Comparing the NICE and ACOG, the guidelines say almost the same things, that is prostaglandin E1, vaginal 25 micrograms can be used, and E2 0.5 micrograms to a maximum of 1.5, and a pessary can be safe even for pre-labor rupture of membranes. Oxytocin, either high dose or low dose, can be used for induction of labor according to ACOG. What are the practice points that we can see for induction of for an induction agent? The first line agent should be for cervical priming and induction, which can be either prostaglandin E2 or E1. We need to always balance the risk of hyperstimulation because there is limited data on morbidity and mortality with these agents. PGE2 tablets, gel, and pessaries appear to be as effective as each other, and both in effectiveness and safety. In mechanical methods, balloon only should be used, and oxytocin would be an optimal choice for prolonged rupture of membranes. Before starting induction of labor, what do we need to assess? After starting induction of labor, what we have to assess? Once we give her PGE2 gel, reassess the woman after 6 hours. If it is mechanical or a PG2 insert, always assess her after 12 to 24 hours. How to select a second method? Depending upon the Bishop score, after induction with one agent, what is her Bishop score? Is the cervix closed, and what kind of uterine activity does she have? If the cervix is closed and there is uterine activity, always consider a balloon catheter, as in the presence of uterine activity, if we go for pharmacological agents, the chances of hyperstimulation will be high. If there is cervical change but no uterine activity, it is always better to go for a prostaglandin gel, because the cervix, when it is open, it cannot hold the balloon. What are the complications of induction of labor? One is tachysystole, or it can fail, it can lead to cord prolapse, uterine rupture, or antepartum hemorrhage. Once we induce mother, it is always a good practice to continue monitoring immediately, assess the maternal and fetal condition, look for uterine activity and the Bishop score. As soon as we induce her, contractions are seen in first hour and they exhibit a peak activity in the first 4 hours. Hence, immediately after induction, we need to monitor her continuously with a CTG at least for 30 minutes to 2 hours after administration. Uterine activity after induction is said to be normal when there are 5 or less contractions in 10 minutes over a 30 minutes period. When the number of contractions cross 5 in 10 minutes period, or they are lasting longer, or there is coupling, it is called as tachysystole. When the tachysystole leads to changes in fetal heart rate, then it is called hyperstimulation. It is always a good practice to have an acute tocolytic agent when we are starting induction, because hyperstimulation is always expected after induction of labor. We used to use terbutaline for acute tocolysis, but because of non-availability, we have resorted to injection nitroglycerin, which comes as 1 ampule containing 5 milligrams in 1 ml solution. This is dilated into 100 ml NS. We need to draw 20 ml into a syringe and then give 1 ml, which contains 50 micrograms per cc. Either we can give it as a 1 ml or 2 ml bolus, depending upon condition. As nitroglycerin causes hypotension immediately, it is always better to check her BP before and after administering nitroglycerin. The onset of action of nitroglycerin is within 60 seconds and it lasts only for 1 to 2 minutes. If the hyperstimulation is not resolved after 1 to 2 minutes and the hyperstimulation continues and the bradycardia continues, it is better to take a decision for cesarean section. The side effects of nitroglycerin are it causes maternal hypotension and tachycardia. This is a CTG showing difference before and after tocolysis. Once here the woman had hyperstimulation, here injection terbutaline was given, then later this has resolved. When can we predict the success of induction? Even before induction of labor, this depends on the Bishop score, her parity, BMI, maternal age, and her medical comorbidities. Coming to the fetus, the gestational age, high chances of failure if it is a preterm, and the estimated fetal weight. It also depends upon the hospital practice, the amount of monitoring, the trial which the doctor is ready to give. When do we say as a failed induction? The goal of induction is a vaginal delivery. Hence, we need to give an adequate time for her to enter into and progress in labor, provided both mother and fetus are normal. So, there exists no universal standards for what constitutes a failed induction. But we can diagnose that the induction has failed when she had not achieved regular contractions or any cervical changes, or did not set into active labor even after 24 hours of oxytocin administration with artificial rupture of membranes. Last but not the least, how to induce for termination of pregnancy when the fetus is not alive. Induction of labor for termination of pregnancy is when the live birth is not anticipated. That is, the fetal death has already occurred, or we are expecting that the fetal death can occur during labor, or natural death is expected once the infant is born. Mifepristone is a progesterone receptor modulator with anti-progestational effect. Mifepristone induces prostaglandin sensitization in the uterus, and the time of expulsion was decreased by a mean of 2 to 10 hours with similar rate of expulsion and complications when mifepristone was used before misoprostol. Before misoprostol based induction of termination of pregnancy at or before 28 weeks or at any gestational age with live fetus inside, use mifepristone 200 milligrams orally at least 24 to 48 hours prior to starting misoprostol. Misoprostol for termination of pregnancy, vaginal misoprostol is as effective as dinoprost and it is less costly. Pre-induction mifepristone shortens the time needed for induction, and for scarred uterus, always be cautious and careful before increasing the dose of misoprostol as it can cause uterine rupture. This is the FIGOS guideline which we have taken, and we follow the same for induction of labor for termination of pregnancy. PGE1 dose at 13 to 17 weeks is 200 micrograms every 6 to 12 hours to a maximum of 4 doses. Once after instilling 200 micrograms, if it doesn't cause any contractions, it is better to increase to 400 micrograms up to a maximum of 1600 micrograms. At 18 to 26 weeks, start the induction with 800 micrograms every 6 to 12 hours to a maximum of 4 doses. Double the dose if there are no adequate contractions to a maximum of 800 micrograms. Beyond 26 weeks, limit the dosage to 25 to 50 micrograms every 4 hours to a maximum of 6 doses. For a scarred uterus, balance the risk between the repeat cesarean section and uterine rupture. Always give mifepristone oral 3 days prior. Mechanical dilators can be used in 3rd trimester, that is balloon catheter can be used. Misoprostol for preterm till 30 weeks dose should be 200 to 400 micrograms vaginally until 24 hours. What are the checklists that you check for before induction of labor? Is there a valid reason that we are inducing? Is the gestational age correct? Are there any contraindications for induction or vaginal birth? Discuss the options available, decide the mode of induction and take consent from the woman, and explain the procedure, assess the maternal and fetal well-being before starting the procedure, and assess the pre-induction cervical score. It is always good practice to give her an informed consent, give her some time to read what are the complications, what we expect, the time taken, and there are chances that she might land up in cesarean section also based on the fetal well-being during the monitoring or induction process. I would like to conclude by saying it is always start induction only when the benefits outweigh the risks. Assess and score, take an informed consent, counseling, careful monitoring, consider combination methods. If one fails, go for the another one based on the Bishop score. Give her good pain relief, as induction of labor always causes more pain than natural labors. Have tocolytics in hand and give her adequate time to go set into labor. Thank you.
Thank you, Dr. Siri. So, we will be able to take questions on induction of labor. Any questions from the audience, please? If you won't ask questions, then I will ask questions.
Madam, I have a question. Hello.
Yeah, please, ma'am.
Madam, I find it very difficult for previous cesarean section I find it very difficult to induce them. If I induce with PGE2 gel, if I am medico-legally incorrect because one slide says that PGE2 is not recommended. Only mechanical methods are recommended.
PGE2 is recommended is what I mentioned for termination of pregnancy with a dead baby inside.
For previous cesarean section, I find live baby.
With a live baby, it is always a mechanical method only, ma'am. Never we use the PGE2.
For previous cesarean section, it is not medically legally correct if we use PGE2 gel?
No.
We are also worried about what you are worried about. We are also worried about scar rupture. We are also worried about that we will have uterine rupture and lose. So we usually, in our protocol,
yes, that was what I was
setup,
asking.
Because once you put a medicine inside her body, the rate of absorption is not in our control, especially with the scarred uterus. So we go very slow. So mostly we use a mechanical dilator. We have induced even mothers who have had twins who are wanting for a trial of labor after cesarean section. But we have been able to give our evidence and our experience with the mechanical dilator only. We have had certain cases where we have been referred with mothers with IUFD, scarred uterus for termination. In that case, if a mechanical dilator has not given the cervical priming to the mother or has not produced adequate contractions, then we have put a gel.
And it is always, even though it is not a live baby inside, we always go very slowly, doctor. Like first we give the mechanical induction. If there is no response, we talk to her, we explain her, we take her opinion also, we tell the advantages and disadvantages. Most of them will agree to wait. It is also very traumatic for her with the dead baby inside to wait, but we have mothers who listen to us and who understood why we are trying to say what we are trying to say and her future, the implications of cesarean section on her future pregnancies. We had a mother who waited for 4 days with a dead baby and we could finally deliver her vaginally.
Even in, like we don't know what has happened in the last cesarean section. All the time it is not mentioned in the discharge card. So even if she goes into spontaneous labor, we are scared to let it.
This is again during the antenatal period. We definitely ask for her summary. If she says it is not available, or if we check the notes and there is no mention of her surgery, we inform her that we are okay to give her a trial with good monitoring, but always give her the clause that we don't know what happened in the last. If possible, talk to the doctor. If no information is available, we will inform her that we will take an early decision if there is any doubt.
There are always cases wherein we have called, they have the previous discharge summaries. If it's a very recent 1 year, 2 year back cesarean section, and we have a mother who is very keen on a trial of labor after cesarean section, there are instances where we have asked for a summary, and even we have spoken to the consultant where she had a surgery. Most of the mothers will say that they are our family doctors, they know us very well. तो आप उनसे बात करोगे तो आपको पता चल जाएगा कि आपका क्या क्या doubt है. So we have spoken and we have got the major information from them. But definitely trial of labor is of cesarean section. We give it with very close monitoring. There are very strict criteria, and medico-legally also we have a formatted consent form which we give it to the mother at 7th month after a growth scan is done, and give her enough time to think about it, think the family about it, take consent, and that's how we proceed. And definitely it's a known fact that trial of labor after cesarean section has maximum success rates with spontaneous labor. It's never with induced labor. So definitely that clause is always explained to the mother. Okay, whatever little success rate of 50-60%, it has to be very clearly explained to the couple that don't be in a rosy dream that it is 100% success rate. You have to put your hospital statistics that even in my hospital with so close monitoring, if in a month I try for 10 mothers, we are able to successfully deliver mothers having successful VBAC in 50-60% cases. There are cases of 4 other cases wherein I had to do a repeat cesarean section for this indications. So when you are truthful from your side, I think at some stage they are also understand, and they also are open to for both.
Apart from all the counseling and other things, we should have a backup where there is an obstetrician is available 24 hours, an anesthetist and a pediatric colleague is also there along with us to take care of the baby. In those conditions, we can try for a TOLAC, and we can induce them and start them on oxytocin drip and wait and with simultaneous monitoring. Without this backup, where in a place where we do not have an anesthetist, where there is a pediatric colleague not available, then trying for a TOLAC would be a little difficult.
Yes.
I would like to add something here from my hospital and our experience. The question here is, which patient we should give trial, which woman we should not give trial. If the lower segment is thinned out for a prolonged labor, whatever the cause it is in previous labor, this thinning out damage will not go, it will stay forever. And when the next time when the woman go for labor, it will go for rupture, whether it's a trivial contraction or with an induced contraction. For every case we do C-section, we record the information that the lower segment is thinned out or not. These thinned out cases, we don't give for trial of labor. This is the most important information. If you are not convinced, we can observe these and find out in the days to come. Thank you.
Yes. Thank you, sir.
In your hospital, Fernandez Hospital, which prostaglandin do you prefer for induction at term? Like around when you want to
It is dinoprostanol, PGE2.
Anything special reason for other using than PGE1?
Previously, around 6-7 years back, we used to use misoprostol, but it was discontinued because it was found to be associated with more rates of hyperstimulation, MSL, failure. It was very difficult for the women also because the dosage is every 4 hours once, need for monitoring. So actually when this Propes is introduced, this was found more comfortable, less monitoring. The woman easily accepts 24 hours we are not going to do a vaginal examination. We will only monitor her with the CTG every 3 hours once. So with a good outcome also, good vaginal delivery rates with the prostaglandin E2 pessary, we have shifted to this. Pessary.
No, our first agent is the pessary, madam. It's not that we have completely knocked out the prostaglandin gels. Our first agent is pessary.
So when there are contraindications for pessary, because pessary is also sometimes associated with hyperstimulation, it has its own contraindications that we cannot use it before 34 weeks, and always for more than parity 3, Propes is not indicated. So when there are these contraindications for Propes, according to Bishop's score, if the os is completely closed and it comes as 0/13, then we give her Foley's or Cook's catheter. If Foley's has opened up the cervix to around 2 to 3 centimeters and she is not getting contractions, then we go to the second agent as prostaglandin E2. Or when there are few contractions, we know that this woman is going to set into labor. She is 1 to 2 centimeters at admission. A primary gravida is 1 to 2 centimeters at admission. She is getting 1 or 2 contractions. First thing we do is the membrane sweeping. we tell her there are the chances that you can set into labor. If membrane sweeping failed, then we will go directly to the prostaglandin E2 gel instead of pessary, because that is more likely to bring about a change.
One more question, ma'am. Do you have any comparative study of mifepristone versus gel when in an unripe cervix? I mean,
Mifepristone as an agent for induction, you're asking, ma'am?
yes, yes.
Not really. We are using
You're not
mifepristone only for termination as of now in our institute.
Induction you are not using?
No, not
Okay,
yet.
thank you.
Pain relief in?
What is the
Pain relief
choice?
depends upon
choice pain
her
relief
pain
agent?
score, doctor.
What is the agent you prefer and how the dose
We
adjustment
first
is?
offer pethidine or tramadol. Non-pharmacological, first we ask her to do breathing exercises, ball exercises, give her support. We have hydrotherapy in our hospital. And then Entonox gas. If first, once she comes into labor, we offer her all this non-pharmacological, then gas, and still if she is not able to tolerate, then for epidural.
I have one question for the crowd. Is induced labor more painful than natural labor? Yes? Yes, the quality of contractions is more painful than spontaneous labor contractions? So most common agent which we use here for induction is misoprostol. Prostaglandin, PGE2. Either it is dinoproston or prostaglandin gel. Gel we put it intracervically or posterior fornix? Intracervically? Not posterior fornix? The
No,
correct
ma'am,
method
for,
is
pre-induction ripening maybe intracervically. Pre-induction ripening of cervix intracervically.
But pre-induction ripening os is close, no ma'am?
Yeah, but the little bit.
Little bit will go inside.
Yeah.
Okay. Okay.
Usually you put around 30% in the after the external os and the remaining 60 to 70% in the posterior fornix and either side.
So we here also we tend to give 3 doses of prostaglandin or more than that? 3 doses. 3 doses, not progressed, failure of induction.
Oxytocin.
Okay.
I start with oxytocin.
Which cases do we prefer Foley's here? We do not prefer Foley's here at all?
No. Yes, we will do.
We will do?
Primary with uneffaced cervix, we do Foley's previous night and the morning we'll start induction.
Okay. So which is in your personal experience a most satisfactory agent for induction of labor?
Gel.
Gel. Period. No controversies. Yes. 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 Are mothers open for induction here or you really have to counsel a lot for induction?
This is a very important question what you said about, and especially in the cases of intrauterine fetal demise. You know, what we have noticed over years, there are so many actually the centers, the obstetricians sometimes land up in doing cesarean section even for the cases of IUFD only because of the pressure from the relatives. And for that it's a very important message for all of us that counseling is the key actually factor in that. Quite often they are worried about that IUFD and they feel now baby has gone and mother should not land up with any complication, but we need to give a lot of assurance. We need to have so many good induction of labor agents available nowadays. And suppose we go systematically, I think that majority of the women, rather all those women can deliver vaginally. And this need to be, message need to be given to the entire society, especially the OBGYN group, that no section per se in the IUFD cases, unless it is something very, the thing like low-lying placenta and all other things. But otherwise, majority of them they deliver vaginally.
Yes, ma'am. Sorry, we are, okay. एक माइक देंगे हमको please. Yes, the VBAC consent form is there in our protocol book. Yes. There are a lot of forms, other forms also.
Madam, how frequently you induce a multiple pregnancy?
How
Under
frequently
reasons.
we need to see multiple pregnancy?
Induction is multiple pregnancy.
Yes, induction, it's an individualized decision completely in multiple pregnancy. Uncomplicated DCDA twins, we take it up to 37 weeks. Complicated DCDA twins, 36 weeks. Momo twins, we do not induce, first of all.
Actually, if they are ready for a vaginal birth, we offer them for induction.
Yeah.
If both
Yeah.
are AGA babies, cephalic presentations.
No, twins are nowadays, especially in mothers who are second gravidas and carrying twins with a previous vaginal birth, those are the perfect candidates for induction, and they are also open for induction. Otherwise, it has to be there from the mother's side that, okay, I could push one, I can push two. That also should be there.
Do you practice internal version, the second baby of twin?
Yes, we do, ma'am. We do. Provided there is good fetal heart rate and the CTG is fine, we do continuous monitoring once the first twin is delivered. And the second twin, if there is not much of clinical contractions and we are able to manage and do a podalic version or a cephalic version, we try. We try. But we also manage to do a vaginal breech deliveries.
If it is a second twin coming as breech, we are managing to
Yes.
do vaginal breech.
Because twins is something mostly, I think most of the mothers, second twin, if it is coming down per se as breech and it is progressing well, I think it is better to deliver her as a vaginal breech rather than really manipulating the baby and turning here and there and ending up the baby stuck as transverse. So I think it's time now to practice our skills more and more for vaginal breech deliveries. And that chance comes mostly with twins.
And the consent also which we take when we are trying for a twin delivery is always double delivery. There's always chances of second twin having a cesarean section. And we keep our EOT ready once the first twin delivers. So she will be prepared for anything.
You know, one of the interesting facts, suddenly there was a surge of the cases which were in the literature as well as on the various media with the interval between the delivery of first twin and second twin. So what is the protocol of Fernandez? What they do?
Sir, there was a recent query which was raised in the clinical practice guidelines. So initially the consensus was 30 minutes inter-delivery interval of twin A and twin B. But if the current scenario says that there is, recent articles have said that there is no such predetermined time, provided the second twin, the fetal heart rate and everything is fine. So if you have the facility to document and really monitor the second twin closely, then you can wait for the second twin to progress. Let the second twin descend down, there is an advancement in the cervical dilatation and then augment labor. So this particular thing which they have said that the cutoff of 30 minutes is not applicable provided the second twin is monitored enough.
Yeah, but given a scenario, how long you will wait max? Because there were certain sporadic cases which we read, they waited for days. And then it was really something very surprising. So just wanted to learn about it, that suppose we see that we can go beyond 30 minutes, how long maximum Fernandez thinks that yes, we can wait?
So luckily, touchwood, all our twins have progressed well. But we have used oxytocin for augmentation for the second twin, sir. Once there is advancement of cervical dilatation and the presenting part really settles down, we do an ARM and we kind of augment the labor. So with the oxytocin in all good faith has helped us. So it hasn't really come into a phase wherein we had to really wait for a day.
It is more or less, it is a cervical dilatation which decides for second twin delivery. And I also landed in trouble sometimes. And if the cervix is not responding well, you have to wait. And the question is, how long to wait? If the liquor is plenty, and if you don't rupture the membrane, it will be staying like that. It may go for abruption or IUD inside. Other problem is, if you do in ARM, when the liquor coming down, it may go for a transverse position. When it go for transverse position, it will be hell. That if you have a full setting with anesthetist, everything, you can manage the show. Within few minutes, you can take the baby. Suppose if the anesthetist is not there, patient came just like that with labor pains, it will be a serious problem. I had a problem. What I did know, the anesthetist was not able to come to my place. I gave the spinal myself and I delivered the second baby. I put the case in the Foxy, this Bobigain discussion. A lot of discussion went in that. Thank you.
Okay. Sir, please give it.
Do you follow daycare obstetric as an induction method? Number one. And what is your rate of failure of induction in your setup?
Daycare induction is what we are asked us, sir.
OP basis we are not doing, sir.
Okay. So you are not regularly doing
No, OP
it.
basis only stretch sweep is done, sir.
Well,
If we are considering that as a method of induction, so at 39 weeks we offer all our mothers sweep and stretch.
Few years back there was a daycare obstetric kind of a thing, means morning induce karo, दोपहर शाम तक नहीं हुआ तो सीजर कर दो. So that in that context I am asking this.
We have not used pharmacological methods as daycare, sir.
Okay. And what about the failure of induction? And when you call it as a failure of induction according to your criteria?
Here again, it's the mother's choice. When they are very keen on induction and want to have a vaginal birth, most of the mothers are ready for 3 induction agents. Also, there are many times where we followed Propes, followed by Cooks, and 3 doses of gel, followed by
Amniotomy and oxytocin.
amniotomy and oxytocin, finally ending up in a vaginal birth. At most, few population will be there where they would like to end here, or what are the risk factors depending on that. If it is FGR, if she is not responding with a single agent, we ourselves will tell her, we will offer her that would she like to go ahead with cesarean section or not. Coming to the success, if she is a low risk mother, the success of vaginal birth is around 60 to 70%. The rate of induction are different in our different units because one unit manages low risk mothers, one unit manages high risk mothers. In our high risk unit, the rate of induction is between 35 to 40%.
Failure of induction rates. Sir, the failure of induction, the definition is standard, sir. If despite using a pharmacological agent, the Bishop's is less than 3/13, that's when we declare it as failure of induction. So it's the Bishop's which tells us failure of induction. Others, if the maternal request, they don't want to go through the standard protocol of 3 inductions, amniotomy and oxytocin, then that goes into a maternal request.
One is Bishop's score, but there are many things that can go wrong. That is secondary arrest of dilatation or no further descent. Many things can be unanticipated and can happen during obstetrics. In that context, I said, when you say, okay, enough is enough now.
Yeah, if you are asking about intrapartum second stage events or during active stage of labor, sir, that we usually use we don't, failure of induction is we have been mostly using for this before going into the labor room and the active stage of labor wherein we give oxytocin. Even after going into the labor room, once she is like around 2 to 3 centimeters, that's when we do an amniotomy and we start oxytocin. In our institute, we give a maximum hours of around 16 hours of the oxytocin trial. And if there is not much of cervical dilatation, that's when we say it's failure of induction or non-progress of labor.
One more additional question, sorry. In mild cases, you said that failure of induction is 30 to 40%, right? So still comparatively this rate resulting into cesarean section in normal cases.
No, she said rates of induction, sir. 30 to 40%?
No, failure I said. I asked, the question was regarding failure. So I took it as an answer as a failure.
Yeah, what she mentioned was the rates of induction at different branches of our research.
So she divided into 2 categories, mild and severely low risk and high risk, we can say that. In low risk, it is 30 to 40%. So do you have any audit of such cases? That's the question.
Low risk induction rates. Any audit of cases?
Success.
Group success. Sir, you are asking what is the vaginal delivery success rates in different groups of Robsons? Is that what I understand? If I am talking success, then the other portion is the failure.
No, this is question regarding post-analysis, post-event analysis.
Post-induction, that's what you are asking. You are
why
asking.
the things have failed and where the reasons for that.
Yes, sir. Every month we do an audit about our Robson's classification, wherein we have both primigravida induced labor and multigravida induced labor, and how many of them had a cesarean section, how many of them had an assisted vaginal delivery and vaginal delivery. So we do this audit every month, and it is surprising that it doesn't have a constant percentage, sir. So it depends on every month and depends upon the loads of the cases, and that is why we do an audit of each branch, because each branch of ours has a different clientele of patients which come. Like the second branch, we mostly deal with high-risk mothers. So when the maternal condition itself is being stabilized using so many pharmacological agents, in such cases we really don't stretch and use multiple agents. So in them, definitely our threshold of declaring it for having a cesarean section is relatively low for a mother who is low risk. Definitely the choices of the family are the prime concern, and the mother's consent is more. There are mothers who have chosen or completely disagreed to have induction of labor. So this maternal request cesarean sections are definitely a percentage which is growing in our setup also.
Thank you.
So again, adding to your point, sir, what you are asking is if your induction rates have increased and if they have failed and you are then increasing the cesarean section rate. That is actually correct. That is the reason we need to keep on updating ourselves and questioning ourselves. Is this induction really necessary? Do I have to intervene? Am I going in a correct way? Or if there is any chance to avoid induction, always try to make her set into spontaneous labor and then go ahead.
What is your cesarean section rate overall, not for induction?
Overall cesarean section rates.
40%. Sir.
Okay.
Excuse me, can we take the questions after the session?
Yes.
We can continue.
Yes. So the next session, I invite Dr. Shanti ma'am. So this is one of the dreadest complication, the postpartum hemorrhage. So we'll be going through the various methods to control postpartum hemorrhage and the recent updates.
Thank you, Subhashini. So now after the sessions on electronic fetal monitoring and induction of labor, now we go ahead with postpartum hemorrhage. What makes obstetric hemorrhage dreaded? So we all know that it is often sudden, unexpected, and associated early with coagulopathy. The blood loss is difficult to quantify and is often underestimated, can exsanguinate the mother in 6 to 8 minutes. We know that the blood flow to the uterus in a non-pregnant uterus is 60 ml per minute, whereas in pregnant state it is 600 ml per minute. So the amount of blood she loses with each passing minute is high. The physiological changes of pregnancy may mask the signs of hypovolemia. So what is the definition of PPH? Traditionally, PPH has been defined as a blood loss of more than 500 ml after a vaginal birth or 1000 ml after a cesarean birth within the first 24 hours. There has been no uniformity in the definition of postpartum hemorrhage, making it difficult to know the prevalence of PPH. So ACOG has come up with a definition which says that any blood loss more than 1000 ml, irrespective of the route of birth, to be considered as postpartum hemorrhage, or any blood loss that causes a change in the hemodynamic status of the mother, leads the mother to a hypovolemic shock, should be defined as postpartum hemorrhage. The RCOG defines PPH as minor and major. Minor PPH is a blood loss of more than 500 ml and a major PPH as a blood loss of more than 1000 milliliters. So the incidence of PPH is about 4 to 6% of deliveries, and a major PPH occurs in about 1 in 1000 births. Worldwide, 8% of maternal deaths are attributed to postpartum hemorrhage in the developed countries, whereas in the developing countries, 1/4 of maternal deaths are attributed to postpartum hemorrhage. It continues to be the leading preventable cause of maternal illness and death globally. We should be ready, recognize, respond, and report the cases of PPH. So why are we dreaded about PPH? Because we know the consequences of PPH. It may lead to hypovolemic shock, coagulopathy, anemia, need for blood transfusion, and its associated complications. There is a good possibility of hysterectomy, lactation difficulties. Morbidity and sequelae include organ failure, thrombosis, adult respiratory distress syndrome, sepsis, need for ICU care, disseminated intravascular coagulation, loss of fertility, and a possibility of Sheehan syndrome. If left alone, a possibility of death. Apart from the physical morbidities, there can be post-traumatic stress disorder, which is seen in about 9% of mothers who survive a major postpartum hemorrhage, and also postpartum depression. So, do we really know the risk factors for PPH? We consider these antenatal and intrapartum events as a risk factor. Antenatal, like any case which is associated with APH, like abruption and placenta previa; multifetal gestation; preeclampsia, because there is inadequate expansion of the intravascular volume; and a history of PPH. A history of PPH in previous pregnancy predisposes to PPH in this pregnancy in 20% of cases. BMI, extremes of BMI like low BMI and high BMI also predispose the mother to PPH. Anemia, where the hemoglobin is less than 9 grams per deciliter, and advanced maternal age, more than 40 years, predisposes a mother to PPH. Intrapartum risk factors are a C-section, induction of labor, retained placenta, episiotomy, instrumental birth, prolonged labor more than 12 hours, macrosomia, and pyrexia in labor. Most cases may not have a risk factor at all. So, the most important thing is to recognize that there is a PPH. So, we need to know how to quantify the blood loss. There are various methods of assessment of blood loss. The most commonly what we do is a visual estimation. The problem with visual estimation is that we overestimate a lesser blood loss and underestimate a major blood loss. So, we use the quantitative method for estimating PPH. So, how do we do that? We use calibrated under buttock drapes, weighing scales, and use all the pads and the pads and bed sheets whichever are used while the woman is birthing. Subtract the weight of the dry ones from the wet ones and estimate that the specific gravity of blood is 1 and take the difference as ml of blood lost during childbirth. So, this is visual estimation which is quite inadequate for estimating the actual blood loss. Then this is the quantitative method where we weigh all the dry and wet and find out the difference. So, the measurable blood loss is, as I have told, under buttocks receptacle, the canister which collects the fluid, the blood loss in the kidney tray, and the spills on the sheets. So, we collect all these things, weigh these and put them on a sheet and calculate the blood loss during a C-section, and similar method is used during a vaginal birth also. So, what is massive hemorrhage? Massive hemorrhage, if there is a loss of 50% of blood volume in less than 3 hours, and if the mother loses 1 blood volume within the first 24 hours, or if it is 70 milliliters per kg within 24 hours, or their blood loss is more than 5 liters. How do we clinically define a massive hemorrhage? When the systolic blood pressure is less than 80 millimeters of mercury, or when the pulse rate is more than 120 per minute. So, we all know the 4 T's, the etiological factors for PPH: tone, trauma, tissue, and thrombin. The most common cause is tone. 70% of cases, it could be because of atonicity of the uterus which causes this excessive blood loss. And we should also remember that an empty, contracted, intact uterus will not bleed in the absence of coagulopathy. So we need to have a stepwise approach for the management of this life-threatening emergency. So control of hemorrhage and judicious resuscitation are the initial steps in managing PPH. So what are the critical elements of early resuscitation? The first and foremost thing is call for help. Call for extra help, an obstetrician, a midwife, a nurse, alert the consultant, call the anesthetist, alert the clinical hematologist, alert the lab from where we procure the blood, call porters for delivery of specimens and blood, alert one member to note down all the events, to record the events, the maternal parameters, the fluids we are giving, the drugs we are giving, and the vital signs. So resuscitation for PPH starts as not as ABC but as CAB. So first we maintain the circulation, then the airway and breathing. So we assess the circulation and then airway and breathing. We supplement oxygen by mask at 10 to 15 liters per minute. We have an IV access with two 14-gauge cannulas. Put the mother flat and keep the woman warm using appropriate blankets. Transfuse blood as soon as possible and start with the IV fluids. So when we are giving fluid resuscitation, we need to know why, which, when, and how much. So because resuscitation depletes the circulatory volume. So why we give fluids is to restore the end organ perfusion, maintain the adequate intravascular volume, improve oxygen delivery, and improve the clotting function, and to maintain the electrolyte balance. And also to maintain normothermia, as these mothers are more prone to hypothermia. So IV fluids, the mainstay are crystalloids, ringer lactate, normal saline, and plasma light. Once we have given 2 to 3 liters of crystalloids, then comes the role of colloids. Colloids are HES, which we commonly give. And before we give colloids, we should be sure that we draw the samples for labs and for blood cross-matching. Then comes blood and blood components. So blood is given when the hemoglobin is less than 6 gram%. If the blood loss is less than 15%, then we replace with IV fluids, RL and NS. When it is 15 to 30%, we add the colloids, and when it is severe, we start with the blood transfusion. So why do we give component blood rather than whole blood? To avoid overload, for better patient management, and because the components have a greater shelf life. So blood components, generally we start with packed RBCs. So transfusion triggers, as I have mentioned, hemoglobin less than 6 grams per deciliter needs a transfusion. When the hematocrit is less than 16%, when the PT and APTT are more than 1.5 times, and the platelet count is less than 50,000, or the fibrinogen value is less than 150 milligrams per deciliter. The transfusion goals are to improve all these parameters. So here, whenever a mother has a PPH, at the foot end of the mother, there is a call for help. Simultaneously, there is massage going on, coordination with the helpers. We catheterize the bladder. Catheterization of the bladder helps in uterine retraction and also help us about the renal perfusion. And we review the causes of PPH, again to go with the four T's, tone, trauma, tissue, and thrombin. Then at the arm end, we have two people who are taking bloods for cross-matching and for investigation. One person starts with the IV fluids, giving crystalloids and starting on drugs, uterotonic drugs. At the head end, we have a anesthetic colleague who helps us in maintaining the airway, checking the breathing, administering the oxygen, and sometimes giving sublingual misoprostol and reassure the mother simultaneously. During the whole process, we have an attender with her who is sitting with the mother who is so anxious and worried looking at the blood loss. We need to communicate with her and reassure her too. So coming to the golden hour of resuscitation. Golden hour is the time by which resuscitation must be initiated to ensure better survival. We need to know the rule of 30. Rule of 30 is when the systolic blood pressure falls less than 30 millimeters of mercury, or when the hematocrit falls then less than 30%, or when there is an increase in the respiratory rate about 30 per minute, or when the pulse rate increases by 30 per minute, we know that the mother has lost 30% of her blood volume. And another indicator to know how much blood loss has happened is by calculating the shock index. Shock index is calculated by dividing the heart rate by the systolic blood pressure. It is used to detect the hemodynamic stability or instability of the mother with hypovolemia. The normal value of shock index is 0.5 to 0.7. When the value exceeds 1, it indicates that there has been a blood loss of 20 to 30%. So coming to achieve hemostasis, we have the medical and surgical managements. We need to know that we have to use a combination of these methods, and the methods used should be towards the causative factor. WHO recommendations of uterotonics is the first line of uterotonic which the WHO recommends is oxytocin. And the other drugs which like carbetocin, misoprostol, methyl ergometrin can be used if oxytocin is not readily available. So starting with bimanual uterine compression, we need to compress the uterus, keeping it acutely anteverted, or stretching the uterus so that there is decreased blood flow in the uterine artery. Continuously apply massage so as to help us in decreasing the blood loss. The other method is compression of the abdominal aorta. We apply downward pressure on the abdomen just above the umbilicus so as to apply pressure over the aorta, and this pressure should be sufficient to obliterate the pulsations of the femoral artery to be effective. Then medical management, we have all these drugs like oxytocin, methergine, PGF2 alpha, misoprostol, carbetocin, and tranexamic acid. Carbetocin is the second line uterotonic drug which is long acting, which has a rapid onset of action. It has the convenience of a single dose. Efficacy is equal to oxytocin. It is devoid of receptor desensitization or tachyphylaxis, which we generally see with oxytocin. It has been added to the essential list of medications by WHO for the prevention of PPH. It has a longer half-life than oxytocin and stable at room temperature. We know that oxytocin, when kept at room temperature, is less effective and the half-life decreases to 30 days. The dosage is 100 micrograms given IM or slow intravenously. At Fernandez, we follow the active management of third stage of labor, which has a three-pronged approach. The most important prong of the AMTSL is administration of uterotonic after the delivery of the baby within 1 minute. Delayed cord clamping and controlled cord traction help us in averting major hemorrhage. So this is active management, administration of a uterotonic agent within 1 minute after the baby is born, preferably oxytocin, controlled cord traction while supporting and stabilizing the uterus, which is called the Brand's maneuver, and uterine massage after the delivery of the placenta. We have an obstetric hemorrhage checklist which tells us about the delivery time, the call for help, all the help that we get, the resuscitative measures, the drugs we give, and the procedures which are carried out. Coming to the choice of procedure, it depends on the age and parity, the gravity of the situation, the underlying cause, the experience of the surgeon, and also the degree of radiological support. It could be a tamponade. Tamponade could be uterine packing or a tourniquet and uterine compression sutures, stepwise devascularization, arterial embolization or catheterization, and as a last resort, sometimes a hysterectomy is required. Surgical management, coming to uterine tamponade. Classically, uterine roller gauze was used to pack the uterine cavity, but the discomfort with roller gauze is that we could not know whether the bleeding was concealed or not, and the risk of infection and also the difficulty in packing. These days we use a Bakri balloon. Bakri balloon is very easy to insert. It takes very little time. It causes compression, it causes pressure from inward to outward direction on the uterus, decreasing the blood flow or ooze from the capillaries and the veins. It is effective in about 80% of cases. In case we are in a place where a bakri is not available, we should all remember condom tamponade, where we take 2 condoms, insert one on each other, and then inflate it with insert it into the uterine cavity and inflate it with 300 to 350 ml of normal saline and look for control of bleeding. Then coming to compression sutures. Compression sutures, we know B-Lynch has advocated B-Lynch compression sutures, which is very easy and less time consuming. They say that it takes less than 2 minutes to apply a B-Lynch suture. Easy to learn and practice on a simulator, does not require special equipment or supplies. The suture material used is catgut 2 or monocryl. We should not use vicryl because the absorption time is longer. If at all there is herniation of bowel, there can be strangulation. So we should use monocryl, which is absorbed in less than 90 days. We use a 70 mm half centimeter curved Ethigard blunt needle. It does not have any impact on the future fertility. Effectiveness is generally about 75 to 90%. These continuous sutures maintain even and adequate tension on the uterus. They prevent uterine trauma and shouldering. Because we open the uterine cavity, there is no collection of, we are very sure that there are no cotyledons or any clots left inside. It allows free drainage of blood and debris. Transverse suture can sometimes be applied at the cervico-isthmic junction to control the bleeding. Coming to the Heyman suture, which is a modification of B-Lynch suture, the lower uterine segment is not open and the cavity is not explored. That is a disadvantage with this. It is probably quicker to apply, but there is a possibility of segmental ischemia and shoulder suture slipping. Then comes the uterine compression suture and intrauterine hemostatic balloon. It's a combination of B-Lynch suture and the Bakri balloon. The former used to stop the bleeding from the upper uterine body, and the later, that is the Bakri balloon, compressing the lower uterine segment and stopping the bleeding. This represents the concept of role sharing for hemostasis. Then comes the Pereira sutures, where we put 2 longitudinal sutures and 3 transverse sutures around the uterus. Here we have to take measures not to injure the uterine vessels and the ureters which lie adjacent to the uterus. Multiple U sutures can be applied, which go by the name of Heckel sutures. Cho sutures are multiple square sutures which are applied at the point of bleeding. The risk associated with Cho sutures is production of multiple uterine synechia. Then coming to stepwise devascularization. Stepwise devascularization, the first vessel of choice will be uterine artery, because 90% of the blood flow to the uterus comes from the uterine artery. There are 2 ways of ligating the uterine artery. One is the high ligation, the other one is the low ligation. High ligation is done just 3 centimeters below the lower uterine segment, so before the uterine vessel branches. We take a bite through the broad ligament, include thickness of the myometrium so as to avoid vascular damage and also to prevent bleeding from the ascending myometrial vessels. Whereas low ligation, we push the bladder down and take a little 3 centimeters below the previous ligation so that we control the bleeding from the ascending branch of the cervicovaginal artery and from the descending branches of the uterine artery which supply the lower uterine segment. Ovarian artery ligation is done medial to the ovary so as to retain the function of the ovary, and the last resort will be internal iliac artery ligation. Kelly, who devised, this is about the stepwise devascularization. Here is the place where we do the high uterine artery ligation. This is the low uterine artery ligation. This is the place where we do a ligation at the anastomosis of the ovarian and the uterine arteries. This is the place where we do the ligation for the ovarian artery. Coming to internal iliac artery ligation, it was devised by Michael Kelly. He called it as the boldest procedure to check hemorrhage. It reduces the pulse pressure so that the pelvic arterial system is converted into a venous system which causes sluggish blood flow, so that there is thrombosis in the blood vessels and there is a decrease in the blood flow to the pelvic vasculature. In severe obstetric hemorrhage, it is a life-saving procedure when other conservative measures fail, but waiting too long to perform it is its biggest pitfall. Then comes uterine artery embolization or catheterization. These are done in centers where we have adequate radiological support. Last option is hysterectomy, and we need to decide for a hysterectomy before it's too late. And again, we have to tackle with the post-hysterectomy bleeding, which could be in the form of abdominal plaquing or a mushroom pack, and sometimes may require embolization or recombinant factor 7A. So coming to peripartum hysterectomy, it is a definitive procedure, but the loss of fertility can be devastating for the mother. It is a complex procedure because of ongoing blood loss, distortion of pelvic anatomy, possibility of developing hematomas. Sometimes may require an additional procedure, and there is always a risk of relaparotomy. It depends on the time lapse between the delivery and successful surgery, which helps in the outcome of the mother. In severely shocked mother with a life-threatening hemorrhage, it must be the first line of treatment. So whenever we know that trauma is cause for PPH, we need to shift her into the OT with adequate lighting. We need to explore and proceed with the required procedure. One thing we always have to remember is after the delivery of the placenta, we need to check for the intactness of the placenta and membranes. We should not miss a cotyledon within the uterus, which is a potential cause for bleeding and deterioration of the mother's condition. A rare cause of hemorrhage could be uterine inversion. Sometimes there could be bleeding disorders, which could be because of consumptive coagulopathy and or overzealous of administration of fluids leading to dilutional coagulopathy. Some obstetric disorders which cause DIC are abruption, acute fatty liver of pregnancy, and amniotic fluid embolism, which may contribute to massive obstetric hemorrhage. And there are also inherited and acquired bleeding disorders which are unrelated to pregnancy, like von Willebrand's disease, hemophilia, and other disorders. So every maternal unit should have a multidisciplinary protocol for management of PPH. We at Fernandez carry on PPH drills along with the midwives to manage any PPH. All cases with blood loss of more than 1500 ml should have a formal clinical incident review. Documentation and debriefing is very essential to protect ourselves. Staff in attendance, the time of arrival, the sequence of events, administration of drugs, timing, and the sequence of doing all these things should be noted down. Timing of surgical intervention, time of blood products transfused should be marked, and the condition of the mother should be charted on an early warning chart system. Preventive techniques for PPH are identifying high-risk patients before delivery. Identifying high-risk patients before delivery, it is one of the most important factors in preventing morbidity and mortality. Planning appropriate route and time of delivering is also required. Patients with previous C-section should have an ultrasound evaluation so as to not to miss a morbidly adherent placenta. Treatment of patients in the antepartum period to improve their hemoglobin is very essential. Coming to mothers with Jehovah's Witness, for a woman who has stated a wish not to receive any blood products, we should ensure that these wishes are documented on the clinical form and refusal or consent with restrictions to be documented. We offer screening and treatment for iron deficiency in the antenatal period and correct the anemia. We consider erythropoietin, and we also take an informed consent for intraoperative cell salvage. So we follow this hemostasis algorithm where H is for help, assess the vitals, establish the etiology, massage the uterus, oxytocin infusion and administration of uterotonics, shifting to OT, bimanual compression, ruling out the presence of tissue or trauma, applying compression sutures, systematic pelvic devascularization or stepwise pelvic devascularization, interventional radiology as required and available, subtotal hysterectomy as a last resort. Take-home message of this talk would be early control of bleeding is the most effective measure for control of PPH. Aggressive and rapid intervention are required. Correlation between the time elapsed to control the bleeding and case fatality is noted. avoid the lethal triad. Rather, I would say the lethal quad of hypothermia, acidosis, coagulopathy, and hypocalcemia. We need to remember that for each mother who dies, there is a family that suffers, a community that becomes weaker, and a country that becomes poorer. Thank you.
Yes, we look forward to any doubts, ma'am, before going on to the next portion of our talks. Postpartum hemorrhage. Any queries, please?
We have been using carbetocin. We still are, the audit is ongoing. It is found to be effective so far, not requiring any additional drug. We are still auditing the carbetocin.
Okay. What about the Panikar cannula?
We have not been using Paniker's cannula as of now. We use a balloon tamponade as the first method.
I will tell about the Panikar cannula, SR cannula. I am the person who developed this suction cannula. Of course, Panikar story I don't want to narrate here. And it's a wonderful device. If the system is made ready, it takes just less than a minute time for insertion. And if you apply negative pressure, bleeding stops within 3 minutes time. Cannula fails only when it is not properly applied. If you are not properly applying, only it fails. Otherwise, the success rate of cessation of bleeding is almost every case. That's what I would like to say. People are not using much in Tamil Nadu. I have not conducted much workshops there. In NHM, Tamil Nadu has introduced this device throughout Tamil Nadu. And recently they placed an order for 423 sets of cannulas to supply these cannulas to every PHC and CHC in Tamil Nadu. And PHC nurses are getting trained in medical colleges. I have given hands-on training workshops to covering 63 medical colleges in Tamil Nadu. Every Kerala, everywhere it's being used. Andhra Pradesh, more than 70% have covered and they are using. And this is a story of suction cannula or SR cannula for postpartum hemorrhage. You should use it, then only you will realize the value of it. There's no point skipping. And everywhere, even a talks are going on PPH in US, they are mentioning SR cannula. You should have mentioned. Sorry.
As spoken to you earlier in the day, sir, you said you have not yet entered Telangana. Looking forward for you to enter Telangana and teach about SR cannula so that it can be used, it can be kept in you. Right, sir. Thank you, sir. Thank you.
Next talk. So our next talk would be by Dr. Siri, shoulder dystocia and management.
We keep the office.
So moving on to our next topic, shoulder dystocia, the most dreadful one. We need to be alert, aware, practice about managing shoulder dystocia. We'll go through what are the implications, what kind of maneuvers we can do in a stepwise manner. The objectives of this talk are how to identify the risk factors for shoulder dystocia, how to have a systemic approach, and I would be elaborating on the mnemonic helper which we commonly use in our institute. Failure of shoulders to deliver spontaneously or with gentle downward traction of fetal head is to be identified as shoulder dystocia. This occurs when either anterior or less commonly posterior fetal shoulder impacts on the maternal pelvis or sacral promontory respectively. The Green Top guideline has defined shoulder dystocia as a delivery that requires additional obstetric maneuvers to deliver the fetus after the head has been delivered and gentle traction has failed. But there are comments on this kind of definition, as this indicates that we need to give a gentle traction when the shoulders did not deliver after the head, but which is actually wrong. So, a more objective definition, that is, an interval of more than 60 seconds between the delivery of head and body, should be considered as a shoulder dystocia. It is diagnosed when there is difficulty in delivery of face and chin, or when the head is tightly fit over the vulva, or it is seen retracting, or failure of restitution of the fetal head, or failure of shoulders to descend. This is a picture showing the difference between the normal baby coming out and a baby with anterior shoulder dystocia. The dangers can be entrapment of cord, inability of the child's chest to expand properly, and severe brain damage or death if the baby is not delivered on time. Studies of large number of vaginal deliveries have shown that the incidence of shoulder dystocia is between around 0.6 to 0.7%. In our institute, the incidence is between 0.3 to 1.8%. As we can see, the incidence of Erb's palsy because of shoulder dystocia is around 4% in the last year. The risk factors that are associated with shoulder dystocia can be pre-labor, intrapartum, or associated with the fetus. The pre-labor risk factors can be previous history of shoulder dystocia, macrosomia, diabetes, maternal BMI more than 30, induction of labor, or multigravidae. Intrapartum can be prolonged first and second stage, augmentation of labor, assistant vaginal delivery, and for the fetus, it is suspected large for gestational age. The risk factors are only for us and the team to be prepared to anticipate shoulder dystocia and keep our team prepared that we can have a shoulder dystocia for this mother. But as such, none of these risk factors have a good positive predictive value. Even the strongest of the risk factors have a positive predictive value of only 16%. Hence, all these risk factors should be kept in mind, but are not reliable in pointing out towards 100% shoulder dystocia can happen. It is difficult to predict shoulder dystocia, as when we look for estimated fetal weight as 3.9 or 4 kgs, which may not be accurate, that is given on scan. And all the studies which we do that shoulder dystocia happened is always dependent upon the post-delivery actual baby birth weight. Hence, it is always good to be aware of risk factors and be alert. And it is to be noted that almost 50% of cases of shoulder dystocia happen when the estimated fetal weight is less than 4 kgs. And the diabetic mothers, it is always a risk factor, and the risk factor is about 2 to 4-fold increase. When there are a combination of assisted vaginal birth with diabetes and macrosomia, the risk of shoulder dystocia increases exponentially with every 250 grams increase in the weight of the baby. The likelihood of shoulder dystocia is higher among diabetics and also higher when there is operative vaginal delivery compared to spontaneous vaginal delivery. Can we prevent shoulder dystocia? When we counsel the mother saying that the estimated fetal weight is above 3.5 and there are chances that the baby can gain more weight, and keep her prepared for cesarean section or anticipate shoulder dystocia, the mother usually asks, can we deliver right now, so that we can prevent further weight gain of the baby. The studies have shown that induction of labor in non-diabetic mothers with anticipated macrosomic fetus does not prevent shoulder dystocia. But in diabetic mothers, it definitely reduces the incidence of shoulder dystocia at term. Can we do a cesarean section to prevent shoulder dystocia? No. Cesarean section is not recommended because the studies have shown that we need to do 3,700 cesarean sections to prevent one brachial plexus injury when the baby's weight is around 4,500 grams, and 2,345 cesarean sections to prevent one permanent brachial injury, plexus injury in a 4 kg baby. Hence, it is not recommended to offer a cesarean section when you are anticipating shoulder dystocia, because not all estimated fetal weights above 3.5 or 4 kgs go on to have a shoulder dystocia. And also, if we do have shoulder dystocia, the further complications like permanent damage to the baby, the incidence is very less. What can we tell mother to prevent shoulder dystocia is to decrease her pre-pregnancy weight and maternal weight gain in pregnancy, which was found to be associated with less incidence of shoulder dystocia, along with many other advantages of not getting diabetes or hypertension in pregnancy. Coming to complications due to shoulder dystocia, they can be neonatal or maternal. In neonatal complications, the brachial plexus injury incidence is found to be around 4 to 40%, and the risk factors associated with brachial plexus injury are macrosomia, diabetes, arrest of second stage of labor, obesity, excessive weight gain, prolonged second stage, operative delivery, and very less breech extraction of a small baby. And only 10% of or less of brachial plexus injuries go on to have a permanent damage. The other complications for the baby are clavicular or humerus fractures, which are around 5 to 6%, and most of these are because of the manipulations that are done to relieve a shoulder dystocia, but not as such because of shoulder dystocia. The other most important complication that the baby can have is hypoxic ischemic encephalopathy, which can be as high as 23%, and it is related, the risk is increased with more than 5 minutes interval delivery between the head and the body. Moving on to the maternal risk factors, they can be PPH, third and fourth degree tears. Both these are related to the weight of the baby, cervical tears, vaginal lacerations, symphyseal separation, and uterine rupture. This is a picture depicting how we can cause a brachial plexus injury by applying traction to deliver the shoulder. Brachial plexus injuries can be avulsion, rupture, or a stretched nerve. Neonatal brachial plexus palsy that is lasting more than 12 months is considered as permanent damage, which is seen as a muscle imbalance, subluxed or dislocated joints, internal rotation and adduction contractures above the shoulder, and inability to externally rotate and abduct the shoulder. This affects the overall health and psychosocial condition of both the children and parents. And this can be the most common cause of litigation in shoulder dystocia. Brachial plexus injury, most of them can be mild with no permanent damage, and permanent damage is less than 10%. In UK and US, it was found to be around 0.1 per thousand live births. 46% of brachial plexus injuries happen because of substandard care, and rest are due to maternal propulsive forces when the women did not understand what to do when there was a shoulder dystocia. When they conducted a study on reducing the incidence of brachial plexus injury in a team before training and after training for management of shoulder dystocia, they found that there was a drastic difference in the reduction in incidence, which was 7.4% in pre-training period, which reduced to 2.3% after the team was trained properly in managing a shoulder dystocia. Asphyxia occurs when the time interval is more than 6 minutes for head-to-body delivery. Are we prepared to manage a shoulder dystocia? We always need to have a stepwise approach, keep our team ready, and keep on practicing, having regular drills at every 6 months once. Is it only the doctor who needs to be trained in this? No, the whole team who works along with you in the labor ward, the midwives, the nurses, and your junior most doctor, everyone should be aware what is their role when there is a shoulder dystocia. Even the DAI in the labor room should be understanding what a shoulder dystocia means. Hence, everyone in the team should be having this drill every 6 months once, which we do in our institute through a mom's workshop where we train all the midwives, nurses, and ayas and junior most doctors about what they have to do when they see a shoulder dystocia case. This is a flow chart. Once we identify shoulder dystocia, we ask the mother to stop pushing and we call for help, assess where the shoulder is, whether it is on the left side or right side. Accordingly, give instructions to your assistant which side she should be. Give Macrobot suprapubic pressure, give an episiotomy, and then go to second line step, which is removal of posterior arms, enter maneuvers and rollovers. The third line steps would be symphysiotomy, replace the head, cledotomy, and abdominal rescue. There are various acronyms to drill ourselves in managing shoulder dystocia. We need to train ourselves in any one of these and follow the same thing, because all of them have the same steps one after the other, but only one of them should be trained to all the teamwork. In Be Calm, it is breathe, elevate the legs to macrobuds position, call for help, apply suprapubic pressure, enlarge the vaginal opening by giving the episiotomy, and maneuvers to deliver the posterior arm. This mnemonic is given by ACOG in Managing Shoulder Dystocia in 2013. Helper mnemonic is given by also, this is one which we follow at Fernandez Hospital. H stands for call for help, E stands for evaluate episiotomy, L stands for keeping the legs in macrobuds maneuver, P stands for giving suprapubic pressure, E stands for start doing enter maneuvers, that is rotational maneuvers, R is for remove the posterior arm, and another R is for roll the patient to all fours position. Another mnemonic is alarmer, which also follows the same steps, that is ask for help, lift the legs, anterior displacement, rotate to oblique and give suprapubic pressure, rotate the posterior shoulder with Wood's maneuver, manual removal of posterior arm, E for episiotomy and R for rollover. Pale sister is another mnemonic where there is P stands for prepare and have a plan, call for assistance, legs in macrobuds maneuver, give episiotomy, suprapubic pressure, internal rotation, Wood's screw method, try recovering the posterior arm, extreme measures, repair, record and relax. This mnemonic includes documentation in its steps. Explaining to you briefly about the helper mnemonic which we usually use, H stands for call for help, wherein the person who is conducting the delivery calls out shoulder dystocia to alert the whole team, and the same situation is shared with everyone. Then a consultant on call, the other help, and the anesthetist, everyone who is related to labor room will be present. Evaluate for episiotomy. Check if there is any need for episiotomy, or if the episiotomy is already given, see for the length of the episiotomy if it will be adequate to further proceed with the maneuvers. L stands for legs in macrobuds maneuver. Macrobuds maneuver helps in flexing and abducting the hips. As we see in this pics, before giving macrobuds position, the diagonal orientation of symphysis pubis makes the shoulders difficult to deliver. Once the pelvis tilts and the orientation changes, the symphysis pubis becomes more horizontal and it facilitates the shoulder delivery. It straightens the lumbar lordosis of the mother, increases the relative anterior posterior diameter of the pelvis, flexes the fetal spine, and the success rate of this is found to be 90%. The next step is suprapubic pressure. Before going on to this step, it is very important that the person who is taking over the delivery instructs the helper to stay on right side or left side of the mother, keep ready, be ready at an elevated position, ask him or her to get onto the steps, as giving this maneuver at a height would help in relieving the shoulder impaction. Both suprapubic pressure and macrobuds maneuver have a success rate of 80%. The remaining 20% of mothers only require the next methods, which I am going to tell, that are entry maneuvers. Entry maneuvers can be Rubens 2 plus foot screw, or reverse foot screw. In Rubens 2, the anterior shoulder is rotated gently by approaching with the hand posterior to the anterior shoulder and rotating it in anti-clockwise direction to bring the bisacromial diameter into the oblique diameters of the pelvis. This is a wood screw maneuver where, along with the Rubin maneuver, the posterior shoulder is rotated anti-clockwise direction by putting the hand in the anterior aspect of the posterior shoulder. In reverse wood screw method, the hand which was kept on the anterior shoulder is gently brought onto the back posterior aspect of the posterior shoulder, and the baby is turned clockwise direction in a reverse manner than which we did in the previous step. The next step is to remove the posterior arm, wherein the hand is gently kept inside posterior to the posterior shoulder, reaching up to the elbow, flexing the elbow gently and bringing the arm over the chest and face of the baby to deliver the posterior arm. Follow the posterior arm down to the elbow, flex the arm and sweep the forearm across the fetal chest instead of pulling it directly. It should always go around the fetal chest. The last maneuver is the rollover or gaskin maneuver, wherein the woman is kept in all fours position. This increases the pelvic diameters, dislodges the post-impaction of the shoulder, and in this maneuver, we first deliver the posterior shoulder. Rollover maneuver has a success rate of 83%. The other methods to deliver the posterior shoulder, other than the one which I explained now, are the posterior sling maneuver, where the index finger and the thumb finger are made as a sling and the posterior shoulder is held in the axilla and brought out. Not like a rope, instead of this, actually the fingers are kept in the axilla and the posterior shoulder is pulled out. This is another method which is shrug maneuver, where the posterior shoulder is shrugged towards the fetal head in order to increase the flexion and disimpact the posterior shoulder. The last resorts are Zavanelli method, where the head is replaced followed by cesarean section. The other methods are symphysiotomy and cleidotomy. Shoulder dystocia is always a nightmare for us, which causes a permanent damage to the baby. Always be prepared to face this situation, and a stepwise approach, proper drilling, keeping the team prepared would reduce the incidence of brachial plexus injuries. Last but not the least, documentation of shoulder dystocia is very important. We have the shoulder dystocia form, wherein we write it retrospectively after the delivery, the name, date, was it a spontaneous delivery or assisted vaginal delivery, who was the doctor that was present, when the doctor was called, was the senior consultant present, when did the pediatrician arrive, what kind of maneuvers were given, and with what maneuver the baby delivered, what was the time that was given. In McRoberts position, we always mention the person who was on the right side of the mother and left side of the mother, and the name is mentioned, who has given the maneuver, and at what time, how much time it took for the baby to deliver, the time of the head delivery and time of the body delivery, was the baby facing mother's right or left. This is important to see which shoulder, later documentation, which shoulder was actually affected, and the fetal condition, the weight, and cord pH. It is a good practice to have this kind of flow chart. Whatever maneuver, mnemonic you are following, we follow helper maneuver, and we have this flow chart stuck in our labor room, made as posters, so that even a new doctor who enters will read this and learn how to be prepared in a stepwise manner. In summary, risk factors can be categorized as to antepartum, intrapartum, and fetus related, but it is very difficult to predict based on the risk factors. Always have an anticipation, be prepared, have a protocol in place, and use the mnemonic. Thank you. I would like to play a video now, so for us an easy understanding of these steps. Video. So Dr. Anisha is our academics head who made.
I'm Dr. Anisha, consultant at Fernandez Hospital, Hyderabad, and today I'm going to show you how to manage shoulder dystocia. With me.
She's Dr. Anisha, our academic heads, and these two are our midwives. They made this wonderful video for a shoulder dystocia drill, and I would like to show this.
Hello everyone, I'm Dr. Anisha, consultant at Fernandez Hospital, Hyderabad, and today I'm going to show you how to manage shoulder dystocia. With me are our midwives, Anita and Kalavati. We all know that shoulder dystocia is a life-threatening obstetric emergency. Almost in 50% of cases, it occurs in the mothers who have no risk factors, and that is why we should be prepared for this situation during all vaginal births. Although there are many mnemonics that may guide us through the steps to manage this emergency, it is important that the accoucheur does the steps that he or she is familiar with. So as soon as we recognize that there is a problem, the first thing to do is call for help. It is important that we spell out the correct trigger word, that is shoulder dystocia, so that the concerned personnel arrive at the scene in time. As the help arrives, we must encourage the woman to put her thighs onto her abdomen. The two assistants on both the sides should help her do that. With putting the thighs on abdomen, there will be hyperflexion of the hip joint, and this will ensure that the pelvis gets tilted and aligns with the axis of the uterus. Also, there is increase in the anteroposterior diameter of the pelvis. This may relieve shoulder dystocia. In case this doesn't work, then we should go on to the next step, that is give suprapubic pressure. For this, the assistant who is on the baby's back, that side assistant, should help us give suprapubic pressure. So sometimes the assistant may have to step on the stool to aid ergonomics. The hands should be fisted like we do for CPR, and the heel of the palm should be placed on the suprapubic area, and lateral and downwards pressure should be given either continuously or by rocking movements. With suprapubic pressure, there is decrease in the bisacromial diameter because of the adduction of the shoulders. Also, the shoulders get aligned into one of the oblique diameters of the pelvic inlet. For 90 to 92% of cases, McRoberts maneuver and suprapubic pressure will work. For the rest of the 8 to 10% of cases, we may have to go on to second line maneuvers. Before that, we have to ensure that we have good episiotomy. We all know that shoulder dystocia is a bony problem, and episiotomy is not going to relieve it. With episiotomy, we will get good room in the maternal perineum to perform various maneuvers. So the second line maneuvers that have been described are enter maneuvers, removal of posterior arm, and roll the patient over, or roll the mother onto the all fours. In entry maneuvers, there are three maneuvers that are described: Rubin's 2 plus wood screw, and reverse wood screw. The aim of all three maneuvers is to ensure that the shoulders get aligned into one of the oblique diameters of the pelvic inlet, and there is adduction of shoulders and reduction of this acromial diameter. With this, the dystocia may get relieved. To perform Rubin's 2 maneuver, we must guide the two fingers of the hand that is there on the side of the baby's back onto the posterior aspect of anterior shoulder, and try and get the shoulders into one of the oblique diameters. If this doesn't work, then we move on to Rubin's 2 plus Wood's screw maneuver or Wood's corkscrew maneuver. For that, this hand remains as it is, and the other hand goes from the ventral aspect of the baby onto the anterior aspect of posterior shoulder, and we try and do the tilting of the shoulders into one of the oblique diameters of the pelvic inlet. If this doesn't work, then the second hand comes out, and to perform reverse wood screw maneuver, we guide the two fingers of this hand, which was there on the posterior aspect of anterior shoulder, through the baby's back onto the posterior aspect of posterior shoulder, and try and tilt the shoulders into one of the oblique diameters of the pelvic inlet. With either of these, the dystocia should be relieved. If it doesn't, then the next maneuver to perform is removal of posterior arm. The next two maneuvers are described to remove the posterior arm. In the first maneuver, we must guide our hand from the ventral aspect of the baby and into the pelvis, and try and flex the elbow and grab the posterior hand of the baby and try to sweep the hand across the chest and the baby's face. The other maneuver that is described is called as posterior sling. In that the two lateral fingers, they abut over the maternal perineum, and our longest fingers, they are the middle fingers, make a sling out of it and hook it on the posterior axilla and get the hand out of the perineum. The next maneuver that is described is to roll the patient over or put the woman in all fours. Putting the woman in all fours itself is going to relieve dystocia. So we must give gentle traction and see if the dystocia is relieved. If it hasn't, then it is easy to remove the posterior arm because there is a lot of space in the sacral hollow. If it doesn't get relieved, then all the intermaneuvers that have been described must be done in this position. If it doesn't relieve, then we must encourage the woman to go back on her normal position, and then we may do all the maneuvers again. The third line maneuvers that have been described are symphysiotomy, cleidotomy, and Zavanelli maneuver. Another technique that has been described to relieve shoulder dystocia is called shrug technique or shrug maneuver. Here, the posterior axilla that is lower into the pelvis is grasped in the pincer grasp and the shoulder is shrugged towards the head, and with the left hand we hold the entire shoulder and head unit together and tilt it by 180 degree. The lower posterior axilla thus just slides out of the pubic symphysis and this aids delivery. So with the pincer grasp, we grasp the posterior shoulder and hold the head and shoulder unit together and turn it into 180 degree. And you can see that the posterior shoulder, which has now become anterior, has slid below the symphysis pubis.
All these maneuvers were shown in a period of 8 minutes, but when it actually happens in real life, it should be done within 5 minutes, and it is very difficult for us to manage ourselves, the mother, the team, the panic that the parents are going through, explaining the mother what is happening to her baby. We will be busy in delivering the baby, but we should always think what she might be going through with all this. Talk to her again after delivery because she will be in real shock. We need to meet her again. If her perineum is damaged, she had an OASI in this process, or the baby's damaged, baby's admitted in NICU, we need to keep on debrief, talk to the family, explain them what happens. All these things can keep us in safe place. I am open to any questions or doubts regarding shoulder dystocia. Okay.
Excuse me, I have one announcement. All PG delegates who have not presented their papers yet, kindly assemble in YO Hall post-lunch.
Slides. Yeah, so we have reached the last talk of our workshop. So in this, in the next few minutes, we'll be addressing one of the most dreaded nightmares or whatever we can call it, maternal collapse. It can happen both in pregnancy and also in puerperium. So maternal collapse is defined by the RCOG as an acute event involving the cardiorespiratory systems or the central nervous systems which reduce the present conscious level and potentially give a cardiac arrest-like situation and sometimes death at any stage of pregnancy, and it can happen up to 6 weeks post-delivery. So time and again, maternal mortality reviews have come up and proved it beyond doubt that whenever there is any maternal morbidity or the onset of a critical illness, it so happens that severe vital signs abnormalities are being missed, and that's how we end up having that maternal morbidity and go on to have a mortality. In the Surviving Sepsis campaign, which was recently published in year 2021, the guidelines and other international guidelines have reiterated the fact and given importance for the use of the modified obstetric early warning systems, which is a scoring chart that should be used for all such mothers who are undergoing observation so as to allow early recognition of the woman who is going to become critically ill. So this is the modified early warning chart which we use in our hospital. In this, the nurse who is monitoring a high-risk mother in the HDU or the ICU or in the wards as a step-down system monitors the mother according to the periodic interval which we suggest, and any time when there is a 2 yellow marks or any 1 red mark or 1 purple mark, she initiates a trigger and warns and calls for a doctor. So this is our maternal assessment protocol. In this, any 2 triggers or any 1 severe trigger gives a call for the doctor's assessment, and we use these 4 pathways as a point of care which helps us to enhance our action towards the medical emergency and help the mother not go into a morbidity. So this is the cardiopulmonary pathway system, the hypertensive system, the obstetric hemorrhage pathway system, and the sepsis pathway. So we go through a case scenario. We had a mother who was primary gravida, advanced maternal age. She was an IVF conception with DCDA twins with a high BMI. She was a known hypothyroid and type 2 diabetes and also a chronic hypertensive. So she was following her antenatal care and she was admitted with high hypertension at 32 weeks of pregnancy. So we kept her inpatient, we evaluated her, we started antihypertensives, her blood pressure seemed to be under control, and after 72 hours when her periodic lab tests and everything was normal, she was advised OP basis follow-up of hypertension, and on 2 antihypertensives, her blood pressure being under control and her sugar being under control, she was discharged with an OP basis plan of management. So in our OP basis plan of management, depending upon the severity of the hypertension and the number of drugs the mother is being discharged and the antenatal risk factors, we sometimes call her bi-weekly, weekly, or sometimes more than bi-weekly also. So this mother, we received the news after 3 days and she was brought to the emergency room completely non-responsive. She gave a history, the family gave a history of sudden collapse at home. There was no other positive history. A code blue was activated in the hospital, but we could not revive this mother. So the most probable cause of maternal collapse in her case was pulmonary thromboembolism secondary to preeclampsia. So we have all gone through this COVID pandemic. In this pandemic, there was complete shutdown of medical service system, global lockdowns, so much fear which was inculcated in the mother because of the rapid spending pandemic that they did not even come to the healthcare system with the afraid of being infected with this deadly virus. So definitely coming to the healthcare systems came down, and that's how there was an upsurge in the increased risk of having maternal mortality by almost 1/3%. Even today, almost every minute 10 mothers die. We have 44,000 of maternal deaths every year. What goes wrong? Why do they die? What can we do? We should do something to prevent this maternal mortality. And do we have data? Do we look into the causes? Time and again, many international organizations like the MBRAC UK, WHO, and even the NCHS and the CDC bring out their own internal audits as to why mothers die and give us clear-cut lessons which should be followed. In India also, we have two states like Kerala and other Tamil Nadu who come up with their souvenirs of their audits as to why mothers die. So as to we learn from our own mistakes, from each other's clinical mistakes, and set in a proper system of stiffening the monitoring of such mothers so as we break this morbidity chain and prevent the maternal mortality. So it is important for us to be geared up to first identify the cause of the maternal collapse. So the most important causes are 5 H's and 5 T's. 5 H's, first is hypovolemia, hypoxia, acidosis, hypo or hyperkalemia, and hypothermia. The 5 T's which should be remembered is toxins, tamponade, may it be a cardiac tamponade which is causing a cardiac arrest, any tension pneumothorax, thrombosis, both arterial venous thrombosis, or any massive pulmonary embolism. The most common causes of cardiac arrest in pregnancy can be remembered with this mnemonic of Buchops, wherein obstetric hemorrhage is the leading cause of maternal deaths. E stands for embolism, A stands for anaphylaxis, any anesthesia-related events, U stands for uterine atony, C stands for cardiac disease in pregnancy or any cardiac events, H stands for preeclampsia, HELP and hypertensive disorders, P stands for placenta previa abruption and that again leading to massive hemorrhage, and last not the least is sepsis. So all these causes are the main cause of pushing these mothers into maternal morbidity and end up into maternal mortality. How do we break this chain of passing on from this morbidity to mortality? It is only by apt recognition of the causes, timely effective response, and obstetric triage so as to be differentiate which is a high risk mother, which is a low risk mother, which mothers needs to be transferred to a tertiary referral center, which mother can be managed in a district hospital, triage as to how many hours of monitoring, how many hours the plotting of the early warning charts have to be done. Only by stiffening the monitoring and differentiating an obstetric triage, we as doctors can help us identify and reduce the maternal morbidity and pass on of this life-threatening condition into morbidities. So it is very important for us to identify first that the maternal collapse is happening and a stiff response, a timely response which help us prevent her from collapsing. So this timely response indicates the first step is identification. So this is the first and the foremost important step as to immediate identification and early activation of the emergency service system or the call for help. So in the next few minutes, I will be going through the details of the cardiopulmonary resuscitation. How is it different in pregnancy? First of all, a mother requiring CPR in pregnancy is relatively rare. And even if the mother is quite young, how much ever her reserves are, the survival rates once she is there are relatively poor. So it is different because 2 lives are at stake and there is lot of maternal physiological changes in pregnancy which happens, which demands this modification of our cardiopulmonary resuscitation. So as soon as a parturient collapse, first call for help, call to that mother, check for responsive, put a ear near her, see whether she is breathing. C stands for check for circulation, put your 2 hands near her carotid, check whether the pulse is there or not. Immediately call ACT, ask for a wedge and put a left uterine displacement. Start CPR. Do not wait for anyone else to arrive. It is very important to start CPR immediately once we have identified that there is no pulse and there is no BP and the mother has collapsed. Every second of CPR is precious. As soon as you have called for help and you have started chest compressions, open the airway, and whatever airway you have, may it be a bag and mask, ask help of your sisters to give 2 breaths. As soon as the 2 breaths is given, that completes 1 cycle of 2 rescuer CPR, and we continue to give uninterrupted CPR till further help arrives or she responds. It is very important for us to initiate this CPR as soon as possible, give it uninterrupted and good quality CPR, and we should all have a AED in our workplace. So this is the basic life support algorithm, which involves, once you get an unresponsive mother, immediately activate the emergency responsive system, get the defibrillator. Most of the defibrillator are automated and helps once you connect it to the mother. They will tell you what rhythm the heart is breathing in, start CPR, and then we check the rhythm intermittently. So this is the most important part of the CPR, which is the effective chest compressions. It is very important to push hard and deep, which is more than 2 inches or 5 centimeters. Push fast. At least you should be pushing at a rate of 100 per minute. That is 3 cycles of CPR in 1 minute. Allow the chest to recoil and push with minimal interruptions. It is also important to see that the arm, the forearm and your wrist should be in a right angle position, and the effort should be directly perpendicular to the effort which we are giving to that impulse to the heart for it to breathe. So the correct position to give the chest compressions is ideally mid-sternum at the second intercostal space. This is the thing which is very, very different from the adult CPR and the maternal CPR. This left uterine displacement is something which we should never forget. You can use a wedge, which we usually routinely use during our cesarean section, or even any assistant. You can immediately ask them to stand beside the mother when you are starting a CPR and to displace the maternal uterus as it is more than 20 weeks to the other side, and you can start the CPR, and that makes a gratifying difference. So this wedge, as we have seen, and once we start the CPR, most of the research has proved that with even a minimum wedge of 30 degrees, the resuscitative force which has been applied becomes almost 80% of then if you are giving the mother in a supine position. Also, the chest compression which the rescuer is giving is almost increased by 36%. Is 36% in a completely lateral position, but increases to 67% once a wedge is applied. So this is the algorithm of the cardiac arrest. We are here, started CPR, given oxygen. We have asked someone to bring the defibrillator. We have started the CPR and we have attached the defibs and check rhythm. So once we attach the defibrillator and we check rhythm, this is the algorithm of a 2 rescuer CPR in which 30 compressions is to 2 breaths. The 1 rescue CPR is also called as the compression only lifesaver systems, which is there in which if you don't have help to give breathing, or if you are in a place wherein you are present alone, it has been suggested and proven beyond doubt that only chest compressions can also help the mother. So give chest compressions, call for help, and as soon as the helps arrive, trigger the 2 rescuer system. So the 1 cycle of CPR for any mother is 2 breaths and 30 compressions. The defibrillation is the next step. These are the pictures of the automated defibrillator device, which is mandatory in most of the big hospitals. So the monophasic gives 360 joules. The biphasic machine gives around 120 to 200 joules. And once you stick the pads, it automatically reads and tells us further instructions. It is very important for us to understand that these joules are not different in pregnancy. So it is advisable to give 300 joules, 360 joules in monophasic machine and around 180 to 200 joules in the shock, which is given in a biphasic machine. So next we go on to the rhythms. So these are the shockable rhythms. This is the ventricular tachycardia and this is ventricular fibrillation. So These are called the shockable rhythms. Mostly all the defibrillators, once we attach the pads to the mother, read out these rhythms. So if we are, as obstetricians, may not be very pertinent in interpreting the ECG, but we have defibs who will reflect and read out that there is a ventricular tachycardia, there is a ventricular fibrillation. And all we need to know is these are shockable rhythms, and you should be able to charge the defib and give the shock. So the other rhythms are non-shockable rhythms, which is the pulseless electrical activity and complete asystole. In these two rhythms, there is no role of the shock, so you have to continue CPR. The drugs which you all of us need to know, the most important drug, the first line, second line, third line is adrenaline now. It has been proven beyond doubt that any branch person should be in a position to give adrenaline to as a rescue attempt to the mother. So the dosages, adrenaline is available as 1 milligram ampules, so you just have to break it and push it to the mother as the first rescuer drug, and you can repeat this drug for almost 3 to 5 minutes. Amiodarone is the second antiarrhythmic drug, which is usually given in the third step when almost 2 to 3 doses of adrenaline has brought and there is refractory ventricular tachycardia or ventricular fibrillation. So the amiodarone is given as 300 milligrams IV, and which is the starting dose, and as a second dose is given as 150 milligrams IV, which is the second dose. So in cases of local anesthesia systemic toxicity, especially in epidurals, so the rescue drug is the lipid rescue. We have more and more mothers and complications of hypertensive complicating pregnancy. So definitely there is a chance of magnesium toxicity. So the drug of choice is calcium gluconate. 10% calcium gluconate, it is given as a push and need not be diluted. So whenever the mother is going into prolonged magnesium sulfate infusions, we at our hospital look into the levels of magnesium, whether they are still in the therapeutic range or not. And definitely we have a monitoring system for all mothers who are on magnesium sulfate. We look into the urine output, whether the knee jerks are still intact, if there is any respiratory depression, is there any delirium of the mother, which help us keep on monitoring and keep us track whether the mother is slipping into magnesium toxicity. So this CPR helps us in increasing the end tidal CO2 pressure. So whenever there is a high quality chest compression, ideally the end tidal CO2 should rise above 10 millimeters Hg. And upon continuous good quality CPR, whenever there is abrupt rise go on increasing and there is an abrupt rise of EtCO2 by about 40 millimeter of mercury, that's when there is a reversal of spontaneous circulation. So to remember, our CPR is called good quality CPR whenever there is an EtCO2 rise of more than 10 millimeters of mercury, and in the invasive, once the mother has been intubated and there is an invasive line, the arterial blood pressure rise should be more than 20 and the central venous oxygen saturation should be 30%. That's when we know that we are on quality CPR. So this is the further algorithm. Mostly by this we have some of our anesthetic colleagues or someone who is coming to our aid. If there is no such scenario also, like we have gone through the drugs, always look into the correctable, identify the cause which has caused the maternal collapse, correct the correctable conditions, and if it is asystole or pulseless electrical activity, since it is non-shockable, give the first dose of adrenaline, again start CPR. Start CPR for 2 minutes, recheck the rhythm. Once you recheck the rhythm, if it is again asystole and pulseless electrical activity, give second dose of adrenaline, again start CPR. It is very important to continue good quality CPR and exchange the people who are giving CPR in every 2 minutes. That is very important, and we should practice all this as a drill in our hospital. And the drill doesn't happen with doctors alone. It happens if we train our nurses, our paraclinical staff, our ward boys who are actually at that point of response help us in the predetermined way. So any drill which is practiced overall again helps us in the current situation and helps us to be more prepared to bring that mother going into the brink of death. So in the shockable rhythms, after we have given first shock and after 2 minutes of CPR, if we recheck the rhythm and if it is ventricular fibrillation or ventricular tachycardia, so since it is a shockable rhythm, we give a shock again. A shock of around 180 if it is biphasic and 360 if it is monophasic. And again we start CPR. If the second time again there is, once the rhythm is read by the AED machine, it comes as ventricular fibrillation or ventricular tachycardia, we give a second shock and second drug of adrenaline, second dose of adrenaline. So adrenaline can be given in repeated doses every 3 to 5 minutes, almost up to 3 doses. And this helps us tide over the crisis. And mostly in such case scenarios, we have seen mother returning her to the normal sinus rhythm and being resuscitated. But all this has to be done within 4 minutes. So this needs lot of practice and understanding and training and retraining so that we don't forget the steps and go in a very machine-like fashion so that we can take a decision if the mother is not able to return back to her spontaneous circulation within 4 minutes. So as obstetricians, if the return to spontaneous circulations has not come within 4 minutes, it is time to take a decision for perimortem cesarean section. So what gestational age is it indicated? If the mother is carrying a baby of less than 20 weeks, then we can move on to advanced cardiac life systems. If she is between 20 to 26 weeks, still go ahead and perform the perimortem cesarean section. Here the indication is not for the baby, it is for the survival of the mother. If the salvageable rate in your institute is more than 26 weeks, then definitely after doing a perimortem cesarean section, we see that this perimortem cesarean section has a lot of implication in improving the preload. In previous slides also we have seen that just a left uterine displacement gives such a improvement in the aortocaval compressions. In the similar way, this perimortem cesarean section has been seen to improve the preload and thereby improve the cardiac output to the mother. So knowing CPR in pregnancy is very important. It has been repeatedly identified that the most contributory factor to maternal mortality and morbidity is not knowing how to give CPR in pregnancy and poor resuscitation skills. So in our hospital, time and again we have followed and formulated a code blue policy by which every floor of our hospital has this number impregnated on phones wherein 1111, any particular mother who is found unresponsive, may it be a dia or the ward boy or the nurse, just picks up the phone and calls 1111 and says code blue room number 301. Code blue room number 301, and that's how our code blue gets activated. We are a team of anesthetists, of nurses, of obstetricians, specific names which are trained and retrained, and we form a team who responds to this call and move to the floor immediately as soon as possible. So to always remember, difference in this obstetric CPR is primary important. Do not forget to give left uterine displacement. IV access should be above the diaphragm. Quality chest compressions, it should be 2 to 3 centimeters higher on the sternum, ideally at the second intercostal space, and be ready to do a perimortem cesarean section if within the next 4 minutes the mother doesn't return to spontaneous circulation. So the best hope of fetal survival is maternal survival. So this is the documentation which we use once we have the maternal resuscitation is done. We do it retrospectively, and sometimes during the code we also have a scribe who helps us document and make a point of declaring the time that we have finished 1 minute of CPR, we have finished 2 minutes of CPR, 3rd minute of CPR, so that the person who is giving CPR and changing hands, the obstetrician who is taking the lead and taking the code, knows that it is almost 4 minutes and we have to act fast. So despite all attempts, sometimes it so happens that we are not able to revive the mother. So maternal mortality is a great tragic loss both for the family and also for the clinician to face and come out of it. especially to the team who has faced the maternal collapse, the code, and have completely gone on trying and have not been able to resuscitate her. So in the next few slides, I will deal about how to deal with such a situation of maternal mortality. First thing is to document, because if you have not documented, you have not done. So it is a very important key to safety. Always document the sequence of events, may it be the history as and it is given by the relatives or the patient. Be truthful to the time and date, especially the sentinel events. What are the personals who were there with you during the code? Who were the personals involved? Write the name of every small and big person who was there. Family persons. Resuscitation measures which were taken, whether there was a code involved, was it announced, was the standard practice which is usually set up into small centers or big centers was followed, and if it was not followed, what was the reason for which it was not followed. Second, whenever we go to counsel and break this news of maternal death to the attenders, please show empathy. Discuss all the possible causes. Discuss all the sequence of events. It might sometimes happen that they may demand multiple meetings. Allow questions. Hear out to them and then answer to them carefully. Discuss post-mortem and autopsy of the mother and document all the questions and answers which were even uttered during such a session. It can so happen, always anticipate an angry mob. But even in this situation, it is important for you as a practicing obstetrician, self-safety first. So please call the local police for help or call your senior colleagues for help, and then identify amongst yourself a leader for talks to the family. It is very difficult situation, but try to empathize, stay calm, and be patient irrespective of repeated prodding by the anxious and aggrieved attenders. When it comes to handing over of the maternal body, it's important to remove all the disposals, seal all the IV lines and intervention signs which you have put on her, clean the body of all the secretions, put a name tag, wrap respectfully in a very clean sheet, and hand over respectively. The death summary, which is very important and needed for the last rites of the mother also, hand over a detailed final copy, hand over all the investigations which have been done on the mother, and the death certificate stating the most cause which you feel is closest for the cause of the death. Baby, if you have performed a perimortem cesarean section, if it is alive, offer nursery care till they finish the mother's last rites. If the baby is also dead, unfortunately, give a separate summary and a separate death certificate to the baby other than the mother. Notify. You have to notify the local FOXY board or the review board, in-house organizations within 24 hours of a maternal death. Reveal all correct events in the sequence correctly and save one copy for yourself. It has been suggested to do such summarization in 3 duplicate copies, to keep one and send 2 to the notifying authorities. After the maternal death, keep an in-house meeting with all your seniors, with the admin staff involved within 24 hours. Document the minutes, which were the avoidable causes, what were unavoidable. Introspection is very important. So with certain meetings and following such protocols, there are time and again changes have been suggested, and each change helps us improve our clinical practice. This helps us to fill gaps in our practice. Discuss one-to-one under closed door with the team members. Disseminate the minutes to your practicing team so that tomorrow when they come across such a situation, they learn from our mistakes too. Take suggestions and if possible, frame a code blue policy. So to end with, no mother should die when she is giving birth. It is very important for all of us to gear up for maternal cardiopulmonary resuscitation, to practice the drills, and most of the times it may be an actual real life scenario when you face it alone. You may not have your anesthetist colleagues with you. You may not have anyone a separate doctor with you. All you have is your own staff members, your own ward boys and nurses, and it is important for us to learn the code, practice BCLS, ACLS, know the drugs, and keep a crash track always ready, and always be prepared for the unprepared. Thank you.
We can take 1 or 2 questions. I think she has done it very well, so nobody has questions.
Thank you.
Yes, thank you. Actually, I missed the first part of your talk and I came little late. That's why I wanted to comment. Yes, this is a very important message of the perimortem cesarean section, because all guidelines do say that if the gravid uterus is of more than 22 weeks, unless and until you empty the uterus, it's difficult to get success in the resuscitation. And that's what one need to do. And that's why probably many of you who were there in the 2011 in the obstetric emergency conference, we had organized Bengaluru. We delivered a joint oration by a OBGYN and anesthesiologist about the perimortem cesarean section, what care we need to take. Especially this is very, very important in the scenario of private practice, because in the institute, of course, you get a lot of personnel. But in the private nursing home, where the women come to us with a lot of faith and confidence to get a better outcome for her childbirth, suppose such a scenario happens, one need to get the confidence, expertise about these things as well while managing the crisis. Because obstetric is always that way. We get such type of incidences happening one or other time in any nursing home. And suppose we get ourselves updated with all these BLS and ACLS guidelines and get the certification every year. It's possible. You know that in our city, every year we conduct such courses in various hospitals, not only to one, like last time we did it in Yashodhara Hospital. I'm requesting you all to please certify yourself so that you will get updated with all these newer things which are important. Thank you very much. Thank you. Wonderful it was.
Thank you, sir.
I would like to add something here. As the maternal mortality and perinatal mortality is coming down very significantly down, the problems for doctors are increasing tremendously. Previously, mothers were dying here, there, everywhere. If mothers dies, if a wife dies during delivery, the husband and family thinks, everywhere mothers are dying. My wife also died. It is my fate. Today it's a different thing. No mother is dying. Why should my wife die? Because of this thing, only aggressive postures are taking place in the population. Even for a fetal death, intrauterine death, I had a problem. Yesterday only I had a problem. I have to avoid my journey here. So I had a hell of a problem. Even they came there, by the time they came, the baby was dead inside. And it was a serious problem for me. The police has to come investigate, make an inquest and all. So your coverage of the problem is really excellent. Thank you very much. We need such sessions once again and again.
Thank you, sir.
Any more questions? So we conclude this with, as we all know, Fernandez Hospital is very famous for its treating high-risk pregnancy and complicated pregnancies. Thank you, ma'am, for all the esteemed speakers for delivering this lucid and wonderful talk. Especially firstly, Dr. Subhashini madam, you have very nicely highlighted the importance of CTG, how to read, interpret and act, and the emergency steps, what we have to take in case of ominous findings with CTG. And at the same time, we have to confirm that along with the Dopplers and sonography in case of omnious CTG.
No, not in omnious, in non-reassuring CTGs. Omnious CTGs you have to act.
Okay. Non-issuing.
Yes.
Okay. And in with sudden maternal collapse, the code blue policy and how to do CPR with adrenaline and defibrillation, and the aspect of 5H and 5TS, and especially preventing this maternal collapse by obstetric triaging in the antenatal period and referring to the tertiary care center so that all the necessary antenatal care will be taken. Then Dr. Shanti Shri, she nicely elaborated the antenatal surveillance like NST, VAST, and NST more superior to CST, and especially more important with modified biophysical profile. And then her talk on PPH, that is objective method of assessing the PPH is more predictive to detect the PPH, and importance of golden hour in the active management of the PPH, that is early and aggressive management before the patient collapses. And about importance of PPH drills. And thirdly, Dr. Siri ma'am, you are very nicely given talk on induction of labor around, about various inducing agents, PGE2, E1, and mechanical barriers and oxytocin. And finally, the advantage of prostaglandin pessary over the gel form, and for the favorable induction and outcome. And in case of shoulder dystocia, that is prediction is more important with especially with higher incidence in macrozymic babies along with diabetes mellitus and excessive maternal weight gain during antenatal period. Then you have pointed out very nicely on training program and protocols in shoulder dystocia with video presentation.
Thank you.
So much thank you, madam. And we would like to thank all you esteemed speakers from Fernandez Hospital for accepting our invitation and for being here with us today by sharing your valuable experiences and knowledge. Thank you.
Thank you. Thank you so much, Solapur, for this opportunity. Thank you.
Thank you, madam. Thank you for conducting such a wonderful session. Thank you, team of Fernandez. Thank you. I request Dr. Magai, madam, to felicitate Fernandez team. Please. Madam. I request Magai, madam, to felicitate Dr. Subhashini, madam. I request Jaikar madam to felicitate Dr. Siri ma'am. I request Dr. Rakhochi madam to felicitate Dr. Shanti ma'am. I request Milin Shah sir and Jamma madam to come on the stage. And Gurum sir, please. Sir Desai madam.
I request all the three organizing chairpersons to felicitate the chairpersons for the session. request the MOCs to please join in for the photograph also. After this session, we break for lunch and we will start exactly at 2:45 p.m. for the next lectures. These are also very interesting and we would also have an interesting panel discussion following the same. I would request all the postgraduate students who have not yet presented their papers or posters to please assemble in Vayu Hall after the lunch. And all those who have presented in the morning, please collect your certificates at the same time. Thank you.
I would like to present some of such scenarios. Dilemma 1. On the first day of antenatal booking, a woman was given expected date of delivery. The woman and the obstetrician were waiting for that date, but this woman developed labor pains at 35 weeks itself. Birth weight was 2.3 kg, but this baby was fully functionally mature and did not develop RDS. On the other hand, another woman, post-cesarean pregnancy and expected date of delivery, full 40 weeks, elective C-section was done, birth weight was 3.3 kg, but this baby was functionally premature and developed severe RDS requiring ventilator support. This is the baby. We don't know why this baby was fully functionally mature at 35 weeks. Also, we don't know why this baby was functionally premature even at 40 weeks gestation with 3.3 kg birth weight. DCD in twin pregnancy at 31 weeks gestation, elective C-section was done. Both the babies had birth weight of 1.4 kg, but one baby was functionally premature and developed RDS, another baby was functionally mature and did not develop RDS. This is the baby.
A40 value 0.23, baby is having mild RDS. Twin B, A40 value is 1.55 and baby is fully functionally mature and not having RDS.
Though both babies born same date, same gestational age, both have same gestational birth weight, but one baby is functionally mature, another baby is functionally premature. Labor induction was done on expected date of delivery with cerviprime gel. No uterine action. Gel was repeated once, twice, thrice. No uterine action. Labeled as no progress in labor. Caesarean section was done. Another woman, labor induction was done on the same expected date of delivery with cerviprime gel, but this woman responded with hyperstimulation, severe fetal bradycardia, emergency C-section was done, low ABGA scores. Later, the baby developed cerebral palsy. We don't know why this woman did not respond for labor induction with cerviprime gel at 40 weeks gestation. Also, we do not know why this woman responded with hyperstimulation for the same dose of prostaglandin on expected date of delivery. ACOG, RCOG guidelines on antenatal steroids. The cutoff gestational age for antenatal steroids started from 34 weeks, and slowly it went on increasing to the current 38 completed weeks of gestation. We don't know the reason why these recommendations are being changed even by the standard guidelines. Let us see whether my scientific presentation today can answer these dilemmas. We obstetricians regularly doing ARM and observing the color and turbidity of amniotic fluid. Sometimes liquor is watery, milky, buttermilk-like or curd-like. We don't know that this color and turbidity of amniotic fluid is having correlation with the fetal functional maturity and onset of spontaneous labor. This our published article titled Amniotic Fluid Optical Density and its correlation with fetal functional maturity and onset of spontaneous labor, and this paper was awarded Dr. C.S. Dunn Prize at ASUOG Varanasi. The basic information from the study includes prematurity was associated with a less turbid watery liquor. Optimally mature babies are associated with a milky buttermilk-like liquor. Post-maturity and sometimes dysmaturity is associated with turbid liquor. Brief account of the study. Observation study involving 360 uncomplicated singleton pregnant women who were on first trimester scan, who underwent first trimester scan for CRL gestational age estimation and who are on spontaneous labor. At spontaneous labor, the gestational ages of all these patients are very correct because they underwent CRL gestational age estimation. Amniotic fluid samples were collected while doing amniotomy and while doing cesarean section. Color and turbidity of fresh uncentrifuged amniotic fluid samples were measured in terms of optical density at 650 nanometers wavelength with a simple laboratory colorimeter. This is what we call as amniotic fluid optical density or AFOD. This is a simple colorimeter, costs less than 10,000 rupees. Coming to the results, 300 spontaneous labors were spread widely from 35 weeks to 41 weeks. Red rings represent functionally mature babies delivered at different gestational ages with optical density around 0.98. All these babies were functionally mature and none of them developed RDS. On the other hand, blue rings represent functionally premature babies delivered at different gestational ages. Their optical densities were less than 0.40. All of them were functionally premature and developed RDS. The mean gestational age at the onset of spontaneous labor was found to be 38 weeks 3 days plus or minus 7 days. It is not 40 weeks for us defined by Negley's rule. It is 38 weeks 3 days plus or minus 7 days. 82% of the babies delivered between 37 to 40 weeks. Less than 7% of the babies delivered less than 37 weeks. And 11% of the delivered after 40 weeks. Only 3.38% of the babies delivered on 280th day as per the Negley's rule. Coming to the optical density amniotic fluid, the mean AFOD at the onset of spontaneous labor was found to be 0.98 plus or minus 27. At this AFOD value, all the babies were fully functionally mature and none of them developed respiratory distress. But this AFOD 0.98 and completion of fetal functional maturity and onset of spontaneous labor, which all go together, occurred at any time from 35 weeks to 42 weeks. In other words, babies can attain completion of functional maturity and go in for spontaneous labor at any time from 35 weeks to 42 weeks, indicating individual term for each fetus. In other words, there are early maturing fetuses, there are late maturing fetuses. This is the most important thing we have to know. Here, I would like to show a batch of babies delivered at different gestational ages, but their optical densities were around 0.98. If you see the AF samples here, they are turbid, milky, buttermilk like a curd like. I would like to play these video clippings one by one, and I would like you to observe the Apgar scores of each baby. This baby delivered at 35 weeks, 36 weeks, 36 weeks, 37 weeks, 38 weeks, 39 weeks, 40 weeks, 41 weeks, 42 weeks. What I would like to impress on you here is, if the AFOD values are around 0.98, babies are fully functionally mature and going for spontaneous labor irrespective of the gestational age and birth weight. On the other hand, babies born with the AFOD less than 0.40 were functionally premature and developed varying degrees of respiratory distress irrespective of the gestational age and birth weight. Here, I would like to show another batch of babies delivered at different gestational ages, but their optical densities were less than 0.40. This baby delivered at 33 weeks.
Baby of Manju.
37 weeks. 38 weeks. 38 weeks. 39 weeks. 40 weeks. What I would like to impress on you here is, if the AFOD value is less than 0.40, babies are functionally premature and develop varying degrees of RDS irrespective of the gestational age and birth weight. This baby 3.3 kg having RDS, this baby 40 kg, this baby 4 kg, 3.3 kg, it is having, both of them are having RDS because AFOD value is less than 0.40. To sum up these observations, a baby can be functionally mature even at 35 weeks gestation if the AFOD value is around 0.98. On the other hand, a baby can be functionally premature even at 40 weeks gestation if the AFOD value is less than 0.40. In terms of functional maturity and postnatal survival, a baby at 35 weeks gestation is as good as a baby at 40 weeks gestation if the AFOD value is around 0.98. When we observe the skin surface in functionally mature babies, the skin was mature pale brown in color, practically no vernix caseosa adherent on the skin surface. On the other hand, in functionally premature babies, the skin was premature, thin, shiny red in color with plenty of vernix caseosa adherent on their skin surface. When these functionally premature babies become functionally mature in due course of time, this vernix caseosa will get detached and get mixed with the amniotic fluid. You can see here the vernix clumps are floating because it is detached vernix from fetal skin surface and getting mixed with the amniotic fluid. The color and turbidity of AF is due to the shedding of vernix from fetal skin surface into amniotic fluid. This vernix shedding and color change in liquor starts about 8 to 10 days before the onset of spontaneous labor. Different authors reported surge-like rise in many biologically active substances which participate in the process of spontaneous labor. There is surge in hyaluronic acid, the surge in amniotic fluid lecithin, surge in LS ratio, and surge-like rise in relaxin, oxytocin, and fetal cortisol was reported in animal studies also. Again, this is my published article titled Individualized Term for Each Fetus from Surge in Amniotic Fluid Optical Density. We found there is a slow and prolonged rise in the AFOD till a value of 0.40 is reached. After this 0.40 value is attained, the AFOD rises just like a surge coinciding the onset of spontaneous labor. The duration of surge was found to be about 8 to 10 days. Here I am showing here Narendran V. et al. Reported lung-skin interaction. The surge-like rise in amniotic fluid lecithin induces vernix detachment from fetal skin surface, which will get mixed with the amniotic fluid, resulting in surge-like rise in amniotic fluid optical density, which coincides with the onset of spontaneous labor. The duration of surge was found to be 8 to 10 days. Majuk Chile et al. Reported human amniotic fluid cells can produce pro-labor cytokines like IL-6, IL-8, IL-1 beta, and EGF. The exact mechanism of onset of spontaneous labor, which results due to the pro-labor cytokine-rich vernix detachment into amniotic fluid, has to be further explored. This concept of individual term for each fetus is having a major impact on clinical obstetrics. An early maturing baby which attained completion of maturity at 35 plus weeks itself, and for some reason if the labor is not starting, by 38 weeks this baby becomes post-mature, dysmature, and sometimes IUFD can take place. On the other hand, a delayed maturer who is destined to mature by 42 weeks, if delivered at 40 weeks, it is functionally premature and develop varying degrees of respiratory distress and also have the problems of adaptation. If labor induction is done on women whose parturient system is not ready for labor, labor do not respond well. These women require multiple doses of prostaglandins. They land up with prolonged labor, induction failure, cesarean section, and atonic PPH. In what way this prematurity, post-maturity, and dysmaturity and IUFD can be prevented? By delivering the babies at optimal maturity, that is AFOD 0.98, it is possible to prevent prematurity, post-maturity, and IUFD. Then the question is, how to pick up the woman at AFOD 0.98? To avoid invasive amniocentesis for AFOD estimation, we came out with a 4-water scanning by transvaginal sonography to assess the preparedness of the woman for the onset of labor. If you see this video here, you can see the vernix clumps are floating in the amniotic fluid. This video I have taken while doing cesarean section. If you see here, you can see here, see the vernix floaters are floating here. Same picture you can see by transvaginal sonography, because when you put a transvaginal probe, the Leica amniotic fluid is very close to the probe, so you will get a very nice picture. You can see, you can compare this floating vernix clumps and the floating vernix clumps in the amniotic fluid in the transvaginal sonography also. We have divided this vernix floater densities into 3 grades. This is grade 1 amniotic fluid optical density. This is by transvaginal sonography. Practically no floaters here. If there is no or very minimal floaters, if this picture is seen in transvaginal sonography, we should not induce labor. Even at 39 weeks, we should not induce labor. These are the patients really troublesome for us. They require multiple doses of prostaglandins and they go for prolonged labor, and finally they land up with PPH. This is grade 2 floaters densities. This picture is in between grade 1 and grade 2, moderate amount of vernix floaters. And if this picture is seen, we should defer induction, and we can repeat a TV scan after 4 or 5 days. If there is an urgency, you can give a course of antenatal steroids. By giving antenatal steroids, this vernix density increases. Within 4 days, 5 days, you can see the grade 3 vernix floater densities in transvaginal sonography. You can see here, this is the classical grade 3 floater densities. You can see big clumps of vernix floaters are floating in the amniotic fluid. If this picture is there, it is baby is fully mature and it is ready for induction of labor or cesarean section. With this picture, no baby develops respiratory distress irrespective of the gestational age and birth weight. The way I do programming of every labor at my hospital, we do 4-water scanning by TV sonography around 38 weeks. If grade 1 sonography picture is seen, no induction, review scan after 10 days. If grade 2 sonography picture is seen, defer induction, review scan after 4 to 5 days. A course of antenatal steroids can be given. If grade 3 sonography picture is seen, we admit the patient at the same evening. We don't do anything for the patient at that night. Next morning at 6 a.m., we trigger labor by inserting 22F Foley's catheter through cervix. The bulb of the Foley's should be above the level of internal os. Bulb should be inflated with 70 ml of distilled water. Also, we insert tablet misoprostol 25 or 50 micrograms vaginally. By 11 to 12 a.m., in the sense just 4 to 5 hours, we do PV, and we can observe that the bulb is already got expelled into the vagina and producing a dilatation of 4 to 5 centimeters, and she is in active phase of labor. This happens to almost every woman. We do ARM and exclude meconium and Leica. Further management depends on the obstetric findings. This guided induction fails only when there is a malpresentation and positions or unfavorable cervix due to cicatrization. Otherwise, induction of failure do not occur. No failures of inductions. Advantages. We can conduct labor at convenient hour, avoiding deliveries during night time. This is the most important interesting thing for all the obstetricians. Helps to monitor the labor from 0 hour, that is from the very beginning of labor. This helps to pick up the fetuses that develop distress and die at the beginning of the labor. Very significant reduction in the duration of labor process itself. We have observed about 2 to 2.5 hours reduction in the entire duration of process itself is observed. Our fetal monitoring time is also very much reduced. We have to monitor only 3 to 4 hours only. Within that, once you do an ARM, if meconium is there, you can take the woman for C-section. Labor is less painful. There was a comment here, how to reduce labor pain and all. If you select the woman with this optical density or 4-water scanning, the labor itself is less painful. The woman feels significant pain only while crowning or at the time of delivery of the head. We can give saddle block anesthesia at 8 to 10 centimeter dilatation, and we can avoid long hours of epidural labor analgesia. This programming of labor can also be used to bring down MMR in difficult terrain areas like Assam. We are going to introduce this technique in Assam to bring down MMR, because MMR in Assam is very high. Along with UNICEF and NHM, we are planning this. We can shift the woman to a well-equipped obstetric unit few hours before triggering labor. We can conduct safe delivery and prevent maternal deaths. Another most important observation we have made, when we are doing transvaginal sonography, you could see the cord presentation like this. These mothers, when you did ARM, the cord has come out, resulting in a cord prolapse. So the strategy what we are making, if you see this type of cord presentation, we simply take for elective section, avoid disastrous cord prolapse. On conclusion, 4-water scanning for every woman at around 38 weeks of gestation helps to assess the woman for preparedness for labor and also helps to detect the cord presentation. This makes obstetrics safe, comfortable for both the mother and obstetrician. Thank you, thank you, thank you.
Any question from audience?
Please, welcome. Put your mic.
If at 36, 37 weeks, if we see these densities on abdominal ultrasound, is it an indication to do the 4-water transvaginal scanning? And if it is positive, should we induce?
But one thing, regularly what we do here now, abdominal recording, scanning, it will not give very correct picture. We have seen false positives, false negatives. But we have to confirm by transvaginal sonography. But roughly when the patient come, if I am using my ultrasound in my OP and I put my pro for every patient, 35, 36, whatever it is, I have to confirm myself that my patient baby is fine. So we can see you can constantly go on observing floaters when you are doing a regular scanning. And if you see a prominent floaters, usually these floaters will not be in the top of the amniotic fluid pocket. It will be in the ground down levels. So because the particles are heavy, and if you see dense floaters in the ground of the AFI pocket, then you can do a transvaginal sonography. Otherwise, the patient is complaining pain, back pain and all, you do a transvaginal sonography. And once you do a transvaginal sonography, you are very sure where you are. And once it is grade 3 maturity, you can do it. Grade 2 also you can induce, but safe, you can give a course of anti-steroids and take. Because as I told you, there is an individual term for each fetus. It is not 40 standard weeks for every baby. Every baby has got its own date. It is not every baby is having same date, same gestational age. Even in twin pregnancy, the concept of individual term for each fetus is working. And at 33 weeks, even 37, whatever it is, when you do a twin delivery, one baby may be premature, another baby mature. And some babies, in the same twin pregnancies, we have seen patients were put on oxygen. For one baby, another baby is fine.
But sir, are we medically safe to induce when patient is asymptomatic at 38 weeks?
Pardon?
Are we medically safe for induction if patient is asymptomatic at 38 weeks, that only finding on transvaginal we see the opacities or this density?
I'll tell you one thing. During this COVID period, one of my friend doctor is having more large number of deliveries. We were all afraid if the woman develop labor pains with COVID, we may lose the mother. So what he started, standard way 38 weeks he started inducing for every patient. Ultimately results is, as I have shown here, 82% of the babies are mature by 38 weeks, 3 days. So if you pick up all women and induce labor at 38 weeks, 3 days, your 80% patients respond. And 11 to 12% patients only do not respond. In fact, by 38 weeks, around 7% of the babies are post-mature, dysmature.
Sir, I have a question. If there are other indications, for example, they have FGR or PIH, in any case, whatever may be the amniotic fluid density, we need to induct according to the norms.
See, you can't hasten the PIH, you can't delay the PH. No, that's a different course of action.
This is low risk, all other patients
it is not low risk or high risk. Some patient may be there 36. What I am telling you, 36 weeks also baby can be mature. Individual term for each fetus, 37, 38. And it is, I suggest you, it is mandatory you should do a transvaginal sonograph. If it is a mature floater density is seen, you are safe. You need not give antenatal steroids. Otherwise, there is an indication you give antenatal steroids, get ready for the premature baby with RDS and pediatrician, everything ready. That is the best way.
Moreover, our patients do not agree to the induction if there is no high risk factor at 38 weeks, though we want a program labor.
I am telling you, I am practicing this 2003.
Oh.
All my patients are very happy.
Probably
See,
all the patients are tuned up to
I tell you one thing, more than 3,000 deliveries we have conducted. What we do we'll ask them to come slow, will be every 3, 4 days, every week we do TB scan. I know when the woman is ready for labor. See, morning if I do a TB scan and find out the grade 3 maturity, I ask them, you go home and come evening and admit there. Okay. Next morning 6 o'clock we trigger labor. Within 4 hours, bulb will come out. And see, other thing, most of the mothers with mature optical density reading, you will have a favorable Bishop scores. Okay. Other thing, even if it is Bishop score is not very much, they respond well to the labor.
Thank you, sir.
Do you have same criteria for floating head as well as engaged head?
Pardon, sir?
When you do the sonography in a floating head patient and engaged head patient, do you apply the same criteria?
I tell you, there is no difference in criteria. When vernix get detached and get mixed with amniotic fluid, you will have the same density in the amniotic fluid, whether the floating head or non-floating head. Problem is, when the scanty liquor is there, it is something difficult to trace because you will not have a good pocket of fore water.
No, the point here that I wanted to bring to your notice is that once the head is engaged, the fore water gets locked. It may not be in touch with the hind water.
See, I tell you, sometimes you may not get a correct picture in some patients. What I do,
how you differentiate in such
no difference in the amniotic. First of all, you should see the amniotic fluid in the fore pocket, decide whether it is a mature or premature. If you can't see the fore water at all, you cannot do it, no. So, in such cases, what we do, we give a fluid challenge and improve liquor, then you do a transvaginal sonography.
Sir, I think this is a very new concept in the induction of labor.
Sure.
And did you correlate the optical density with ultrasound guided?
Yes, in fact, I tell you.
So that means now you are not going for the optical density.
You see here. You see the picture here.
Yeah.
This grade 3 picture I have put we have correlated.
So now you are not going for optical density, only on the transvaginal ultrasound?
Mostly. Achha. Sometimes I may prick the needle and confirm my results. But another problem is actually amniotic fluid taking sample is a gold standard. more than 8 to 10%, 11% of the babies have meconium strained liquor before the onset of labor. These people just come to my OP. I took this sample, of course, previously for maturity reasons, but it is meconium strained liquor. Knowingly there is a meconium, because she is not in labor, you cannot send her home. We have taken, all of them, more than 200-300 cases. Every month we have 3 cases. Meconium strained liquor before the onset of labor. If those babies or mothers go home and come back, probably they will end up with IUD. Actually, this is what is happening inside. That's why we have so much confusion. So much, because with mature optical density readings, you are getting all the women at a particular sensitivity level, and they don't require different dose of induction. When you are inducing labor, one patient needs 4 doses, one woman needs 3 doses, one woman just putting 1 dose, they will go for hypostimulation. That will not be there.
Sir, I think you can do further by adding elastography in transvaginal sonography. You can get more information.
Pardon?
This is elastography. While doing ultrasonography, if you start using elastography, that will tell you the solid content and liquid content separately.
I don't know.
You can use that as a further step.
Thank you, nice of your suggestion. But one thing, elastography itself, I don't know. I don't have any mission like that. Anybody can do that. Because this, you know, how much time it took place for me. It's more than quarter century I took. It is quarter century work I have presented to you within 15 minutes time. Because sample taking, how many videos I have taken, there's so much time we spent on this.
Very nice, sir. Thank you very much, sir, for very nice and informative lecture. Definitely it will go for induction. It will help for the induction of labor, sir. Thanks a lot.
Thank you. Somebody can come. Hello. Laptop. Give me that. My talk is over. I'll give. Yes. Right. Number 1. Thank you very much.
Now the next speaker is Dr. Rashmi Khar. She is from Amravati. She is a consultant obstetrician and gynecologist. She is chairperson of AMAO's High Risk Pregnancy Committee, organizing secretary of AMAO's 2020, secretary Amravati Obstetric and Gynecology Society in 2019 and 20. She is a joint secretary ISOBUG of Vidarbha, West Zone coordinator of Foxy Breast Disease Committee. She has presented many research papers. She edited books, contributed chapters. Her areas of interest is emergency obstetrics, social awareness, adolescent health, and preventive oncology. She is a recipient of many awards like Wonder Foxy Award, Shailaja Chaudhary Award, Chitre Trophy for the Best Society Award.
Thank you very much, sir.
Shah Trophy Award, Foxy Juventus Award. Madam, over to you.
Thank you very much, sir. Thank you for all the kind words.
Our topic of presentation is amniotic fluid embolism.
Thank you, sir. Heartiest congratulations to Team Solapur OBGYN for such a successful magnanimous conference. It's a great honor to stand here in front of all of you and present my talk. Respected chairpersons, please allow me to present my case on amniotic fluid embolism. I would like to present the case to the House. It is a story of Mrs. XYZ, who was admitted to the OBGYN unit of a multi-speciality hospital with facilities of HDU and ICU. Mrs. XYZ, 30 years old, G2P1L1A0, with history of amenorrhea 9 months, very regular in her ANC checkups, detected mild GDM, managed on MNT. She complains of leaking PV of duration 2 hours and reported to labor room. On examination, Mrs. XYZ was afebrile. Her BP was 140/90. Respiratory system was normal, CVS normal. Per abdominally, uterus was full term, fetal heart regular. She had mild uterine contractions. On perspective examination, she had clear leaking PV. On PV examination, she was 50% effaced, 2 centimeter dilated. Membranes were absent, head was at -3, and her pelvis was adequate. And the course of events was like, because of history of 2 hours of leaking, she was started on antibiotics and was augmented with 1.5 units of oxytocin in 500 ml of normal saline. After 2 hours, the consultant obstetrician, she received a call from labor room. And the house officer on duty informed her that the patient, Mrs. XYZ, is agitated, restless, she is having convulsions and has collapsed. As soon as the consultant reached to the labor room, the scene was the patient's peripheries were cold and clammy, pulse was feeble and thready, her BP was 60 systolic, her oxygen saturation was 70%. On RS examination, there were bilateral clefts and bronchi, and the patient had started to develop cyanosis. The obstetrician immediately sent code blue alarm and asked for help. When she did the PV examination, the patient was fully dilated, fully effaced. She applied forceps and a deeply asphyxiated fetus was delivered and handed over to the pediatrician. The consultant immediately started CPR. Intubation for the patient was done. It was noticed that the uterus was atonic, PV bleeding was profuse, and when cervix was examined, it was intact. When the investigations of this patient were sent later, the reports were hemoglobin 7.1 gram %, platelets were 75,000, PT was 46 seconds, APTT was 128 seconds, D-dimer 5400, fibrinogen 30 milligram %. Bedside ECG showed sinus tachycardia, bedside echo showed right ventricular dilatation, and chest X-ray showed pulmonary infiltrates. When ABG was done, it showed metabolic acidosis. And the first diagnosis which came to the mind of the obstetrician was amniotic fluid embolism. And what could be the other diagnosis which we think about? It could be a case of uterine rupture, she could be placental abruption. This could be the case of uterine inversion, air embolism, maybe pulmonary embolism, or even anaphylactic shock. But the first diagnosis was amniotic fluid embolism, and that was 100% correct. Why? Because it completely agreed to the diagnostic criteria for amniotic fluid embolism, and it involves 4 important points. And the first point is sudden onset of cardiopulmonary arrest or both, and hypotension, and respiratory compromise, which will be seen in the form of dyspnea, cyanosis, or hypoxia. The second important point present will be disseminated intravascular coagulopathy, which will be followed after the initial symptoms. The third most important factor will be the onset of symptoms during labor or within 30 minutes of delivery. And the fourth important factor is there should be no history of fever more than 38 degrees Celsius during the labor. Our patient, she completed all the 4 criteria, and she was diagnosed to be a case of pulmonary embolism, acute pulmonary embolism, amniotic fluid embolism, sorry. And in our patient, there was 100% presence of hypotension. There was 100% presence of fetal distress. Patient was in pulmonary edema or ARDS. She had cardiopulmonary arrest. Cyanosis was developed. She was in coagulopathy. There was dyspnea. And sometimes some atypical cases might even have seizures, uterine atony, bronchospasm, etc. So what is the pathophysiology of this dreadful amniotic fluid embolism? So we can completely and 100% put the fetus responsible for amniotic fluid embolism. Because when there is exposure of amniotic fluid or fetal antigens to maternal circulation, basically what it does is immunological mediators are released. And the complement system gets activated. Because of the release of immunological mediators and activation of complement system, it acts on the circulation and cardiopulmonary effects are seen in the form of acute pulmonary hypertension, hypoxia, and right ventricular failure. There can even be a mechanical obstruction due to exposure of amniotic fluid or fetal antigen. This will also lead to acute pulmonary hypertension, hypoxia, and right ventricular failure. When the patient is in right ventricular failure, it will automatically, after a time, will lead to left ventricular failure. And the patient will develop later on neurological problems like coma, seizures, residual deficits, ARDS, and other organ dysfunctions. Exposure to amniotic fluid or fetal antigens also activates coagulation system. This is the consumption type of coagulopathy that leads to thromboembolic phenomenon, cardiopulmonary collapse, and eventually death of patient. Is there any diagnostic criteria? I mean, is there any availability of investigation so we can confirm the diagnosis of amniotic fluid embolism? Absolutely no. Amniotic fluid embolism is a pure 100% clinical diagnosis. Basically, it is a diagnosis of exclusion. So there are some risk factors. We say advanced maternal age, multiparity, meconium sustained like a cervical laceration, IUD, even placenta accreta, or even a procedure of DNC or second trimester MTP can lead to amniotic fluid embolism. But all the experts agree that the condition is not preventable and there are no demonstrable risk factors of amniotic fluid embolism. It can occur in any given patient. So when we talk about the management of the amniotic fluid embolism, we all know that we are going to be in need of a multidisciplinary team for management of amniotic fluid embolism. And amniotic fluid embolism has to be managed at 4 levels. The first team doing the cardiopulmonary resuscitation. A second team managing the disseminated intravascular coagulation, which is going to follow. Third team taking care of resuscitative LSCS or hysterotomy. And fourth team which consists of intensivists and cardiologists, they will take care of cardiovascular system. So we have to start giving advanced cardiac life support to the patient, and we have to take care of airway, breathing, and circulation. So the CPR of any patient is same to the CPR of a pregnant patient or a patient who has just delivered. It basically consists of, first, as soon as we diagnose a patient of cardiopulmonary arrest, give a call for help and immediately start doing CPR. So whosoever is examining the patient, and if the patient has given a call to the senior for help, please do not wait for the senior to arrive. Just start giving the CPR. Start giving chest compressions at the level of sternum, and the chest compression should be minimum of 5 centimeter depth. Third important factor is, when we are giving chest compressions, we have to make sure that the patient's bed is at the lower side than the doctor, or the doctor has to stand on a stool to raise the height. The elbows while giving the CPR should not be bent. And the most important point is, there is only one difference in a patient where we give CPR, and that is the left uterine displacement. If the patient is gravid, if she is pregnant, if she is more than 24 weeks pregnant, no amount of CPR or chest compression is going to help that patient. So the assistant, if he is standing on the right side of the patient, has to push the uterus towards the, if the assistant is standing on the right side of the patient, he has to push the uterus. And if the assistant is standing on the left hand of the patient, he has to pull the uterus, so that inferior vena cava pressure is reduced and the effective CPR is given and the help is received by the patient. Another important point of CPR is the position of hands, like a C position. This will fix the mask for ventilation, and the E position with the 3 finger, that will do the extension of jaw. This will cause effective CPR. And another important point in the CPR is resuscitation hysterotomy. If the patient is more than 24 weeks of gestation and she is in cardiopulmonary arrest, we have to do resuscitative LSCS on the spot. Mind well, as we all know, the scene is not good. The patient has come for delivery. She is on a table, she is on the labor table, or she might be in the corridor of the hospital. And she is in shock. The pulse is not palpable, the BP is not recordable, and the relatives are crowding around the patient. The house officer on the duty has given a call to the consultant obstetrician and started CPR. A code blue alarm has been set, and the help has started to come. And in that situation, we know if we do resuscitative hysterotomy or LSCS, within 4 minutes of arrest, we can revive the patient. And what are the instruments or the preparations needed? No instruments or preparation needed. Just pour the antiseptic saline on the abdomen of the patient, give incision with the scalpel, take out the baby immediately, and hand over the baby to the pediatrician, clamp the cord, drape the patient, and ship the patient to the OT for closure. Because we know, when we talk about resuscitative hysterotomy, every second is going to count. We are not saying that we are going to save the patient with this, but we are definitely saying that with this, we are increasing the chances of survival of patient of amniotic fluid embolism. So we have to take care of IV access. We have to use wide bore IV lines. We have to give a call, emergency call to blood bank, because the patient will go into DIC and we will have to start massive transfusion protocol. We have to give oxytocin to the patient, and in all the hospitals, as there should be a massive transfusion protocol, there should be phone numbers of O negative blood donors should be stored and saved. Amniotic fluid embolism, there is checklist for initial management. We have to manage pulmonary hypertension and right ventricular failure. This will be taken care of anesthesiologist, critical care, and cardiologist. We have to consider echocardiography. We have to avoid fluid overload. We have to use vasopressors if needed, like norepinephrine and inotropes like dobutamine. Pulmonary vasodilators, like inhaled nitric oxide, may also be needed to treat the patient. These are some pharmacological agents used to treat the acute right ventricular failure. And as we know, when we suspect amniotic fluid embolism, in a nutshell, we have to start immediate high-quality CPR and shout for help. We have to immediately notify to the neonatology, maternal fetal medicine, and obstetric care provider, along with anesthesiologist and intensivist. We have to consider immediate delivery in viable pregnancies, either by operative vaginal delivery or emergent cesarean section. The early phase, which is characterized by right ventricular failure, it can be confirmed with thoracic echocardiography. In this case, we have to avoid excessive fluid. We have to consider norepinephrine to maintain blood pressure. And the second phase, which is characterized by left ventricular failure and cardiogenic pulmonary edema, we have to maintain hemodynamics with the use of norepinephrine and inotropes. This will, if lead further to coagulopathy, we have to deal and treat the coagulopathy. We may have immediate or delayed onset following cardiovascular collapse of coagulopathy. And then we have to activate massive transfusion protocols which are available, and we have to aggressively treat uterine atony. In our case, in our patient, when we sent the investigations, the reports were platelets 75,000, PT was 46, APTT was 128 second, D dimer was 5400, and fibrinogen was 30 mg/cent. So she was a clear-cut diagnosed case of DIC. In the next lecture by Dr. Ameya sir, he will be talking on DIC, so I won't go much into the deep of management of DIC. I will forward all these slides. So say for example, We treat a patient of amniotic fluid embolism. We did all the protocols, we gave massive transfusion protocol, we did a very high quality CPR, and we could revive the patient. But still there is something which further awaits our management, and this is a deadly squad. This is the deadly squad of coagulation failure. It consists of acidemia, hypothermia, and electrolyte imbalance. So whenever we think that a patient is revived and she is coming out and she is getting settled, these three factors, acidemia, hypothermia, and electrolyte imbalance, may even further worsen the case. So we have to take care of these factors. So we know that the prognosis of our patient of amniotic fluid embolism is not very good. There is more than 85% of mortality and morbidity. Even we are able to discuss long-term complications in a patient who has been revived. It's a great achievement because we have been able to save that patient. But this will be a very rare occurrence. We know the mortality is very high. It may happen that we may not be able to save the patient. But then will we be able to save ourselves? Yes, there is something that will save us, and that is medical records. A very clear documentation and sequential writing of all the evidences, blood transfusion, anaphylactic reactions to any drugs given, in a proper sequential manner and from time to time, that is the only thing which is going to save a doctor from this catastrophic event. Documenting the patient's clinical records, the time each unit was started and completed, an indication of whether or not the transfusion achieved the desired effect. Details of any reactions of the transfusion should be recorded. Like 10 वाजून 1 minute seen by doctor, obstetrician and gynecologist. 10 वाजून 3 minutes seen by intensivist. 10 वाजून 5 minute seen by the senior gynecologist. 10 वाजून 10 minute seen by, again, intensivist. That is the only thing which is going to save a doctor from this catastrophic event. And the last point, which is the most important, so please take consent of autopsy in a case of amniotic fluid embolism. This is the crash cart. This is the crash cart, and this stresses the another point, that there is something else which also will help us to deal with this condition, and it is frequent drills we undertake in our hospital and train our sisters in how to give quality CPR and how to manage the patient. So this is the crash cart, and it does have labeled compartments, and on each compartment there are instruments which will be very helpful in reviving the patient, like the defibrillators, even an emergency LSCS tray which consists of a scalpel and artery forceps and a drape, and an antiseptic solution should be present in the crash cart. It is basically a movable unit which can be moved from its place to the labor room, to the corridor, or to the operation theater, wherever the patient is in shock. And whenever a patient of amniotic fluid embolism will be managed by a multidisciplinary team, the anesthetists, the cardiologists, the pulmonologists, they will come and they will ask you the drugs they require, and at that time all the required drugs should be present on our crash cart. So this is the situation of a code blue in hospital, and we should do frequent drills and train our sisters what to do when it's code blue. So 27th March is a day when the children of the mothers who die of amniotic fluid embolism, they have started a movement. They have started to lighten a candle in the memory of their mothers, the children who survived and the mothers died. It's the 27th March, and this is celebrated or observed all over the world as Amniotic Fluid Embolism Awareness Day. And it has a slogan that take heart, take action. Thank you very much.
Amniotic fluid embolism is a dying emergency. Ma'am, you elaborated very nicely. Thank you for your excellent presentation. Any questions from the audience?
Thank you very much.
Thank you, madam.
Good afternoon, everyone. Next topic is on DIC. It will be taken by Dr. Amay C. Purandare. As sir is met with an accident, he will be taking this lecture online. I take this privilege to introduce him. He is MD, DNB, FCRS, DGO, DFP, MNAMS, FICMCH, FICOG, and Fellowship in Gynec Endoscopy. He is a consultant obstetrics and gynecologist at Purandare Hospital, KJ Somaiya Medical College, Sir HN Reliance, Bhatia, Mansina, Mumbai Police Hospital. He is the second vice president at AMOX 2022 to 24, joint secretary FOXY 2019, chairperson Food, Drugs, Medical Surgical Equipment Committee FOXY 2015 to 17, assistant administrator FOXY Manyata project on quality care in safe childbirth, member managing committee and mentor Youth Council MOGS, secretary at AMOX 2014 to 15, zonal coordinator 2015 to 19 and state coordinator 2020 to 22. He is the peer reviewer of Journal of Obstetrics and Gynecology of India. He has many awards tagged to his name like Dr. A. Dastar.
I think we can go
Over
ahead.
to you,
Thank
sir.
so much for that wonderful introduction. Hope my slides are visible and I am audible.
Yes, sir.
Am I visible and are the slides audible?
Yes, sir.
Okay. First of all, thank you so much for accommodating me. With all your blessings and support, I have been able to fight the difficult time that I have had in the last week. So thank you, Monica, for bearing with me. Special greetings to Dr. Suman Sardesai. I have seen her in the audience. Dr. Rohini Deshpande, Dr. Anjali Chitnis, and my pranam to in the memory of late Dr. Manjiri Chitale. All of these have been pillars of AMOX. Special mention to my seniors and friends in Solapur, Dr. Baldava, Dr. Kumthekar, and Dr. Manik Guram, as well as Dr. and Mrs. Dabde. So I will be talking about DIC today, and I'm not going to be talking about the conventional DIC, but the challenges as an obstetrician that we face, both in terms of diagnosis and management. Mohammad Fatala said that women have a right to go safely through the risky journey of pregnancy and childbirth, a right that should be respected, protected, and implemented. And as obstetricians, for us, the key is maternal and fetal outcome, and the most sensitive marker of this is a maternal mortality. And therefore, we must make every attempt to prevent a maternal mortality, and we know that DIC is one such catastrophe which, if not managed properly, usually ends up in a mortality. So let us look at the pathogenesis, diagnosis, and the management, and let us understand as obstetricians where we are going right and where we are going wrong. Workov described the triad of hemostasis, and when this hemostasis gets disrupted from a protective response, the coagulation process ends up to become a maladaptive process with pathological consequences, and this makes DIC life-threatening. As obstetricians, we often know what is the initiating factor. The initiating factor is various critical obstetric conditions ranging from eclampsia to severe preeclampsia, PPH, sepsis, abruption, septic abortion, rupture uterus, hypovolemic shock, massive blood transfusion, amniotic fluid embolism, and an IUF. These result in the activation of the coagulation system, and this results in DIC. DIC has two important pathogenetic arms. One, on one side, you have the consumption of the coagulation factors, and this leads to deficiency of them, leading to hemorrhagic diastasis. On the other hand, exactly diametrically opposite, there is activation of coagulation and fibrin deposition. This leads to microvascular obstruction and organ ischemia. And therefore, on one side, the woman is bleeding at the macro level as well as the micro level. On the other hand, her organs are failing because of the lack of proper circulation. And this causes the severe morbidity and the often mortality of DIC. Now let's look at each of these conditions and how we can understand to tackle DIC specifically. As Rashmi said, in amniotic fluid embolism, it is so abrupt that we really don't have time. It's not predictable nor preventable, and there are no standard investigations or protocols in that short critical period for confirmation. But one rule of thumb is that if abnormal coagulation tests are noted in relationship to symptoms and signs of acute hypotension, hypoxia within half an hour of delivery, what we classically call as postpartum severe collapse, the diagnosis of DIC may be considered as possibly secondary to amniotic fluid embolism. Whenever there is an IUFD, both from our side as well as the patient side, there is anxiety that this remnant fetus will cause severe consequences to the maternal coagulation system. But if spontaneous delivery occurs within the first 2 weeks, while marked coagulation disturbances are known to occur usually after 15 days or a month of fetal demise. If the fetus is retained longer, about 1/4 of them develop coagulopathy by the release of thromboplastin-like material from the dead POCs. The defects may in fact correct spontaneously before evacuation, but this takes place slowly. Pregnancy complicated by the death of one fetus and the survival of another is often a dilemma because dearrangements are thought to occur in coagulation, but strangely these are rare, and what we should be worried about is the release of thromboplastin affecting the surviving fetus from the dead fetus, especially if they are sharing a common vasculature or a common placenta. Abruptio placentae, often called as accidental hemorrhage, occurs because of placental apoplexy. That means there is a rupture in the maternal decidual artery, resulting in the formation of a retroplacental hematoma at the deciduoplacental interface. It sets in what D. Lee first described as a state of temporary hemophilia, though the precise pathophysiology is unknown and is usually accidental as thought of, but it may be due to impaired placentation, placental insufficiency, and uteroplacental hypoperfusion. When there is PPH, we all know that there is excessive blood loss, and this blood loss finally causes consumption of the coagulation factors, and further effects of massive transfusion also result into the setting of acidosis and hypothermia. So one of the T's in PPF, that is thrombosis, is affected, and that causes DIC. Septic apportion or even intrauterine fetal infection may cause DIC with mechanisms similar to sepsis, where the inflammatory processes dysregulate coagulation in the wrong way. HELP syndrome is associated with endothelial dysfunction, platelet and complement activation with the release of inflammatory mediators causing DIC, and acute fatty liver, as the name says, it's an acute process which causes marked hepatic dysfunction, antithrombin deficiency, and this drives a procoagulant change to DIC. But the pivotal role, friends, is of that of thrombin, because thrombin is the one who changes sides. Okay, on one side, he is procoagulant, on the other side, he is anticoagulant. On one side, he is antifibrinolytic, on the other side, he is profibrinolytic. And this sensitive balance is dependent upon what the body needs or what the body is forced into. And hence, this is critical, therefore, in the final outcome of DIC. As far as obstetricians are concerned, the key organ in DIC for us is the placenta, because the placenta itself is an activated coagulation system. The vascular belt of the placenta, as we know, contains the fetal trophoblastic cells, and these have endothelial cell-like ability to regulate hemostasis by TF expression, altered anticoagulation function, suppression of fibrinolysis, and exposure of anionic phospholipids. So therefore, on one side you have the normal endothelial, and on the other side you have the placental trophoblast, where there is a constant flight between coagulation and fibrinolysis. This is what the mother is doing on one side to permit proper placental perfusion. On the other side, the maternal response is telling her, stimulate your coagulation system, otherwise you will bleed to death. And hence, the placenta is a critical organ to coagulation. Let's move on to the diagnosis of DIC. Of course, as we suspect DIC in the presence of the obstetric complications that I listed in the beginning of the lecture. But what we see are hemorrhagic manifestations: subtle bruising, purpuric rash, epistaxis, the IV line bleeding, and more dramatically with profuse bleeding from the operative sites and PPH. The thrombotic sequelae are rarely present in acute DIC and are overshadowed by the hemorrhagic diastasis. But what we need to remember are three critical organs where the thrombosis is going to cause lifelong ischemia or lifelong fulminant failure, leading to probably death if things are not corrected. And that is the kidney, the liver, and the lungs. The diagnosis of DIC is often with the DIC profile, as we call it in our parlance. It is the reliance on interpretation of several hemostatic parameters rather than an isolated test, and therefore we have a profile of tests. The classic findings are prolonged PT, which tells you that the extrinsic factor has gone wrong. The APTT, which tells you that the intrinsic factor has gone wrong. The low platelets, so the platelet plug is not going to stop the bleed. The low fibrinogen, that means the coagulation factors are affected, and elevated products of fibrin breakdown or D-dimer, which are telling you that the fibrinolysis is more rampant than the profibrin formation mechanism. A simple rule of thumb: PT 15 seconds, APTT twice its value 30 seconds, platelet count 10,000 times, 1,000 times more, 30,000 or less, fibrinogen 100 or less, and FDP 10 or more. These should be the warning signs for you that things may go wrong or are going wrong, and you need to correct things very rapidly or you will lose the patient. But there are pitfalls in this, because pregnancy itself is an altered coagulation state, and hence we have to think about the concentration of all these coagulation factors, because they change in pregnancy, especially they rise in pregnancy with the exception of factor 11. And this physiologically causes shortening of the PT and APTT. Any consumption of the coagulation factors would prolong these measurements, but the overall clot time may still be within normal non-pregnant ranges. And therefore, we must not rely only on one test or one value of PT or APTT. It should be 2 or 3 values which give you a trend that things are going for the good or things are going for the worse, and you need to act accordingly. Physiological thrombocytopenia of pregnancy is often encountered and needs to be considered before interpreting the platelet count. Not just looking at the Coulter values or the counter values, but you need to look at the slide as well and ask your pathologist whether on gross counting also you find thrombocytopenia. A serial drop is in fact more significant than a single measurement as far as thrombocytopenia is concerned. We were all taught that fibrinogen is not sensitive for DIC in pregnancy. In fact, in the earlier Williams, they said that if there was one marker which was sensitive for DIC in pregnancy, it is fibrinogen. The concept has changed after 2000. And this is because normally the levels of fibrinogen can double in pregnancy from non-pregnant stage. And hence we really don't know what are the normal fibrinogen levels, especially in a patient suspected to have DIC. But fibrinogen is a very good marker for PPH severity, and I'll talk about this a little later with an actual example. D-dimer. We were all obsessed with this marker during COVID. Friends, D-dimer in pregnancy is inherently high and therefore cannot be used alone as a marker. It is not meaningful, but you may use it when you are suspecting an embolism, when you are suspecting that there is something wrong. The accuracy of a high D-dimer value, therefore, is not well standardized in pregnancy. So the moral of the story is that you need to do serial tests which are more helpful than a single time point of assessment, because it is pregnancy and the coagulation system is altered. There is a score which is called as the DIC score, and this score is available on the net both as a PDF as well as an app. It looks at all these markers. Simple way to remember is that if the score is more than 5, it means there is over DIC. If it is less than 5, it is non-over DIC, and you need to repeat the test repeatedly. There are other tests which are available. These are more experimental, expensive, and impractical in the acute setting of DIC. There is what is called as a clot retraction profile, and these are of 3 patients. Patient A, in whom there was a normal response even though the patient had PPH. That means she had a body fighting capacity. Her coagulation system could again and again restore itself to normalcy. The patient B had no evidence of clot lysis. That means she had a hypofibrinolysis-like tendency. And the third group of patient had a hyperfibrinolysis kind of tendency. So it is something that we are born with, we are genetically built with, and this is a very important marker how the body will respond to a hemorrhagic or a hemostatic crisis. Let us move on to management. Obviously, the primary approach for all of us is to address the obstetric abnormality. Once this is corrected, thankfully the DIC will subside. But we need to support the woman with specifically aimed strategies to correct the coagulation abnormality, especially in some cases. One important and cardinal principle is obviously replacement of blood products. Some important points in this. Control the bleeding as far as possible with surgical or radiological intervention. Aim to try and restore the circulating blood volume with fluids and blood products. Control the exacerbating factors for abnormal coagulation, especially hypothermia and acidosis, and blood product support should be given. Red cells, O negatives first. Obviously, a good blood bank, a pool of blood banks if massive blood is needed. FFP, 1 unit of plasma for 1 unit of red cell. Aim for the PT and APTT less than 1.5 times the normal. I told you, the rule of 15, 15 and 30 should be your targets. Less than that when you are giving FFP. Platelet transfusion are important and should ensure that the platelet count is more than 50,000. If it falls less than 30,000, it's critical. She may even bleed with unprovoked hemorrhage. Fibrinogen, cryoprecipitate is an important life-saving blood product, and we must aim for the fibrinogen level over 1 gram per liter. A dilemmatic therapy is heparin. We all know heparin is an anticoagulant of choice in things which we routinely use in antiphospholipid antibodies. Probably the day is not far where we'll use heparin more commonly in pregnancy than even iron and calcium. The effectiveness, friends, has not been negated. We really don't know its benefit in routine cases. Also, whether there is improvements in lab abnormalities, but whether this translates into clinical benefit, and hence we cannot give it to patients who are overtly bleeding or at high risk of doing so. Antithrombin 3 has been used as a monotherapy in patients with obstetric DIC and an antithrombin value or effective value or effectivity of less than 70%. It's especially useful in severely preeclamptic women where it can be combined with unfractionated heparin. The improvement has been shown to be greater, and further trials are needed to use it in routine practice. APC has been also shown to be effective in patients with sepsis and abruption-induced DIC. It is to be given IV for over 100 hours, but what we need to be careful is that serious bleeding can occur, and that's what a risk management approach should be taken. To manage the massive hemorrhage, aggressive resuscitation is the key to positive outcome. Massive amounts of blood loss is most common in PPH, where surgical control can be difficult and where occasionally hysterectomy will need to be performed. The usual management remains the same: medical, mechanical, and surgical, with blood products providing the life support in large quantities. It is therefore useful that we have a hospital policy for massive transfusion with regular drills for relevant personnel to be constantly prepared. I'm going to be talking about a newer thing that is coming up, and probably we will see it more and more often routinely in our patients of PPH and DIC, and that is activated factor 7. We are seeing better responses, especially in intractable bleeding and massive obstetric hemorrhage. It has to be given in supraphysiological concentrations. Recombinant factor 7A is available. It activates the factor 10A on the surface of locally activated platelets. The response rate is as high as 90%, and the measurements which have been evaluated include less need for blood, avoidance of uterine artery embolization, and obstetric hysterectomy. But there are certain unresolved issues. We don't know what is the optimal dose. It ranges from 15 to 120 micrograms. Foxy is thinking about coming up with some research, some position statement on its use in DIC in PPH, and we are going to have a technical committee meeting very soon. Platelet count over a lakh, and those with less severe coagulopathy are more likely to respond. So is early transfusion indicated? Acidosis and low fibrinogen levels retard optimal function, has been associated with thromboembolism, and at present is very costly. In today's world, we need to talk about the relationship with COVID, pregnancy, and DIC, especially because we know that thromboembolism in pregnant women with COVID was a nightmare that we faced in the last 2 years. In this paper, which came up and talked about the largest experience of thrombosis with COVID, they said and went on to say, and RCOG backed them, saying that you need to give low molecular weight heparin prophylactically in patients who were confirmed or suspected with COVID, especially if the birth was not expected within the next 12 hours, and continue this for the next 10 days postpartum. They also came up with this important point, which I emphasized earlier, that despite the elevated D-dimer in COVID pregnancy, DIC is infrequent, it's not a good marker. To diagnose coagulopathy in a pregnant woman with COVID, they went on to say that you need to do a screen, do a basic test, use these to calculate the pregnancy-related DIC score, which is a modification of the routine DIC score, and is useful if the woman needs delivery and can guide blood product replacement. One important point: don't use tranexamic acid, because the recovery for DIC is dependent on endogenous fibrinolysis to break down the disseminated thrombi. This is inhibited by tranexamic acid. If there is bleeding associated with DIC, give blood product replacement, not tranexamic acid. Increased thrombosis risk in pregnancy is a high risk for suspicion of venous thromboembolism, something we should keep in mind. In a woman near to delivery, the coagulation factor parameters and the platelet count will have potential implications for delivery, and a hematologist's guidance and involvement has to be taken for every individual patient. This is the modified DIC score in pregnancy. It helps us to identify patients who are at risk. It it's likely to reflect the severity of the ensuing obstetric hemorrhage. So it's prognostic in nature. Major contribution to mortality is delayed diagnosis. Utilization of an effective and validated scoring system may assist the clinician in identifying the severity of the clinical situation and intervene earlier in cases of severe obstetric hemorrhage caused by DIC. 6 parameters, platelet count, PT, fibrinogen, FDP are the ones which are used in this score. The score is slightly modified. It's available on the net. In the pregnancy related score, the higher limit is 26 or more. In the non-pregnancy related score, it is 5 or more. One important key thing that we need to do, and it should be done with every obstetric unit, is the protocol for massive blood transfusion. So you have different
Sorry to
roles for
interrupt, sir.
individuals.
Time is getting
Last slide. Different roles. You have the director who activates this massive protocol, runners or volunteers who start getting it, and reporters who inform everybody about what's occurring. You need to give massive blood transfusion if things are going wrong. You need to give it in a systematic manner and repeat it repeatedly, and therefore requires drills. At Manyata, we have included this as a part of routine emergency PPH management. I urge each one of you to identify the individual roles in your staff so that this can be activated and can be the key point in immediate recovery of the patient, especially in DIC. So to conclude, the key to management is early recognition and timely intervention. The score will help in prognostication. Blood product replacement is the cornerstone of treatment, as well as the placenta removal. Newer therapeutic agents and diagnostic biomarkers are newer approaches which are more effective. And in massive obstetric hemorrhage, a well-prepared approach is crucial, and collaborative trials to include pro-hemostatic agents could translate into improved outcomes. Like the Gita told us that crisis is integral to the human life. Those who rapidly and correctly counteract it will survive and succeed. This is the approach of the obstetrician, my dear friends, in managing the dreaded complication of DIC. Thank you.
Thank you, sir. Any questions from audience? Thank you, sir. Your lecture on DIC, which is a nightmare for all obstetricians, was very informative, elaborative, and full of tips and tricks. Thank you.
Thank you, chairpersons. You all have very nicely conducted this session. I would request you all to felicitate the speakers for today. I would request Anjali Jamma Madam, Milind Shah sir, and Manik Guram sir to please join them on stage. We felicitate Dr. Samarth Rama sir. He has come all the way from south, traveling such a long distance. It is a very nice gesture of you, sir. We thank you from the bottom of our heart. Thank you very much. Next we call on stage Dr. Rashmi Kahan Madam. She has elaborately spoken on amniotic fluid embolism. We thank you so much, Madam. And we present an E trophy to Dr. Amay Purandare sir for giving an online lecture. Thank you so much, chairpersons. We request Anjali Jama madam to felicitate our chairpersons. Please felicitate Dr. Sampath Baldawa sir. Please felicitate Dr. Guru. And please felicitate Priya Kadam madam. Thank you so much. This session is over for now. Now I call upon, we have the most exciting part for today, the panel discussion on adrenaline surge causing situations in obstetric practice. As obstetricians, we commonly face such situations where we are facing the unexpected and unanticipated. I call upon stage none other than Dr. Sneha Bhuyar madam from Yavatmal to moderate this session. Dr. Sneha Bhuyar madam needs no introduction. She is one among us, but still a level above. She's been practicing the last 29 years in the field of obstetrics and gynecology. She has lots of awards and accolades to her credit, the highest being National Individual Award FOXY in 2008 for her outstanding work in rural obstetrics. She has held many positions in FOXY and is continuing to do so. Her panelists for today are Dr. Lakshmikant Marda sir, who is practicing. Dr. Lakshmikant Marda sir from Mangalveda. He is practicing since the last 29 years in rural western Maharashtra and has participated in many national and international conferences. His main area of interest is to improve obstetric care in rural area. We welcome you on stage, sir. Next panelist for today is Dr. Ajit Gandhi, sir. He is an hardcore obstetrician and a fetal medicine specialist. He needs no introduction for the SOGSians. Our next panelist for today is Dr. Vijay Pawar, sir. He is an assistant professor at the BMMC Hospital and a consultant at SIMS. Our next panelist for today is Dr. Chandrakant Zadav, sir, a consultant obstetrician gynecologist at Sanjeevani Nursing Home and an assistant professor at VMMC Solapur. Our last but not the least panelist for today is Dr. Pradeep Patil, sir. He's been practicing at Ashwini Rural Hospital and Ashwini Hospital, and he takes care of high-risk obstetric patients. Madam, I hand it over to you. We are all awaiting an exciting time. Thank you.
Thank you so much, Pratibha, for that generous and kind introduction. A very good evening to all of you. Namaskar. I can see Madam Anjali Chitnis, Dr. Girish Kumtekar, Dr. Baldava sir, and so many seniors and dear friends from Solapur, Dr. Anjali and Dr. Monica. Thank you for having me here. I think the last two talks have already covered the topic very well, and this is like a post-test. So I think it's going to be very interesting. It's like a practical discussion after listening to the talks. So without much ado, I welcome my panelist, Dr. Lakshmikant Marda, I think Dr. Vrinda Chaudhary has not joined, Dr. Ajit Gandhi, Dr. Vijay Pawar, Dr. Chandrakant Zadav, and one more, Dr. Pradeep Patil. I'm quite surprised having the fetal medicine specialist on this panel. Welcome Dr. Pradeep Patil and Dr. Ajit Gandhi. Yeah. So welcome all of you, but all of us are basically obstetricians, so I'm sure basic obstetric emergencies we all should be able to tackle, and that's why we are here. मध्ये मध्ये थोडं मराठी बोलेलच. ऑब्स्टेटिशियन्स आपण इतक्या सिरियस इमर्जन्सीज मॅनेज करत असतो. आय एम शुअर इथे देर आर सो मेनी सिनियर्स हू आर sitting in this crowd, and so many are here practicing in Solapur, but still every labor is a new experience, and unless she delivers, you can't label her as normal delivery. Really, it is a very stressful situation, and you don't know what time it's going to be abnormal. So, are you a good disciple? Are you ready to learn? Never stop learning, because life is never going to stop you teaching. We have labeled this panel so because it increases our adrenal surge, but the situations which we are facing and we are talking about is near miss. Friends, this terminology we have borrowed from the airlines, and that indicates the gravity of the situation and the urgency it demands of the appropriate and timely intervention. And that is how we are going to discuss all about this. So I need not go into the theoretical aspect what near miss is. It is actually defined as the pregnant woman who has almost died but survived of this complication, and that is during maybe during pregnancy, during childbirth, or maybe within 42 days of the termination of pregnancy. Why do we need to analyze all this? Because we really get to learn what has gone wrong and at what stage, and that's a opportunity to improve ourselves. Of course, it's a learning lesson for the others. So, Amey had just said that the women die not of the disease, but people think that their lives are not worth saving. And this gentleman who is so sensitive says, MMR is not just statistics, not just rest and ratio. These are not figures and numbers, but these are women. They have their faces, and we obstetricians have seen these faces in the phases of their agony, despair, and distress. They continue to haunt our dreams. I'm sure those who have faced this situation lifelong, they remember the face. And that is why even Ian Donald, who talks about this, that looking back about the clinical times, one take it for granted the success, but these are the failures which stand out like keloids. It is never to be forgotten for that particular person, but definitely it's a learning lesson or warning to the others. So, as we all know, any pregnancy, whether it is associated with comorbidities or no comorbidities, it is a potentially dangerous situation, and anybody can go through. So, if at all, even a minute clinical insult that leads to systemic inflammatory response syndrome, that can lead to organ dysfunction, and this is a point where you have to catch and treat. If that is missed, that leads to organ failure and death, and that is what the spectrum is saying. I will not go into the theoretical aspect of this. I will straightway go to the case. So, Dr. Lakshmikant, this is a case for you. We have this second gravida, previous cesarean section, 1.5 years old baby. She just has 7 days overdue. UPT is positive, pregnancy test is positive. She wants medical termination, medical abortion, and she requests you for the MTP kit. So you have prescribed MTP kit, given her necessary instructions, and you have called her after 7 days. She just gets little spotting, and at 1 a.m. on fine days, she is brought by the relatives in a collapsed condition. What do you feel is the diagnosis? What are the learning lessons from this case?
Looking at the scenario of this case, my probable diagnosis will be the ruptured ectopic pregnancy First thing I will do, as she is in collapsed condition, resuscitation, IV line, send the blood for investigations, grouping, cross-matching, alert for the blood parameters, and I will do bedside sonography. In that I will confirm the diagnosis. Sac is not in the cavity, is empty, and intraperitoneal bleeding is there.
Okay.
So immediately after settling and arranging blood, I will go for laparotomy, as it is a ruptured ectopic.
So you will go for some intervention, that is surgery. So whether, I think if there is some newer crowd here, whether you would go for laparotomy or laparoscopy?
As patient is collapsed and ultrasound will tell how much bleeding is there.
Yes.
If bleeding is more, I will go for laparotomy then
Correct.
laparoscopy.
Okay. Whether you will go for salpingectomy or conservative surgery?
Yes, I can, depending upon the situation, I can go for salpingectomy.
It's a ruptured ectopic.
Yes, I will go for salpingectomy.
Yes. So it has to be a very clear-cut message. Because she is collapsed, you have to manage her intensively, you have to correct her hypovolemia, you have to arrange for blood and emergency arrangement for operation theatre, and you have to take her for the emergency surgery, so that is laparotomy. What you have said is yes, because it's a rupture, you have to go for salpingectomy. While describing the case, I had said you have given her necessary instructions. So what instructions you had given to the patient?
Basically, prior to prescribing abortion,
I would come to that question, whether you need to do any investigations or other. I would directly come to the questions that whether you should do ultrasonography before prescribing any medical MTP kits for that matter.
Definitely.
Whether it is a recommendation, whether it is mandatory.
As it is not mandatory by law, but we should do it. Whether sometime patient give false history also. She says 6 weeks pregnancy and it turned out to be 10 weeks pregnancy.
Correct.
So dating
So
also,
before that you would not like to go for clinical examination?
the clinical examination is mandatory. That
Yes.
we do.
Yes.
But sonography is also, I think we should do.
Yes, so the sequence of examination is clinical history examination. You have to confirm your diagnosis that yes, pregnancy test is positive, but she is pregnant, and what is the exact size, whether the uterus is enlarged or not, whether its uterus is normal size, but there is an adnexal mass. And then, of course, before prescribing this MTP kit, you have to give ultrasonography, because you have to be safe. And what instructions, of course, whenever you have, the tubal distension and stretching, that gives you fainting attacks. So you have to warn the patient that if she is having only spotting, she has to report when she gets this fainting itself, rather than reporting in this collapse condition. So naturally, as you have already discussed about the bedside investigation, the midnight availability of the ultrasonography also so difficult sometimes at a smaller places. When you don't have your own ultrasonography machine, it becomes little difficult for the patient diagnosis confirmation, and in this scenario you may have to just open the patient because it's a dire emergency. So counseling, as we have discussed, it has to be discussed very appropriately. Basically, whenever you are prescribing any medication or any methods of MTP also, you have to tell the patient that these are the options available, these are the pros and cons, and which one you would like to choose, that she has to give it as a informed consent. So ultrasonography, though it is not mandatory, it is advisable for the safety of the patient as well as you as doctor. So very well discussed, Dr. Lakshmikant. So we go to the second case now, and this case is, I think anybody can take up this case. We have this 36-year woman who conceived after IUI. 36-year-old woman who conceived after IUI. The husband stays in Dubai and she stays at a village. Because she's so happy after infertility treatment she conceived, she came to you regularly till 24 weeks. And once everything is fine, she disappeared. All of a sudden, One fine day she goes to the PHC for pedal edema. Her blood pressure is 176 by 116, and the fetal growth restriction, proteinuria plus, otherwise rest of the investigations are quite within normal limit. So at PHC she was prescribed tablet labetalol. She was advised admission, but she did not get admitted. So what do you feel, what has gone wrong here for this patient basically? What is the diagnosis? Then we go ahead with the discussion.
I think it seems that she has developed preeclampsia. That's obvious from your data.
Right.
Now I have to ask you first question, why she has not undergone the uterine artery screening in the first trimester? She is IUI conception.
Yes.
She must have had so many examinations.
Yes.
She must have had an NT scan.
Correct.
Why she didn't undergo uterine artery screening?
That is what the message we have to give, because she was from a smaller place. After IUI, she got registered at a local practitioner. So that is what the message we have to give, that whenever ART pregnancy itself is a high-risk pregnancy, but for that matter, we take it as every pregnancy is a high-risk pregnancy, and as a routine, right from early pregnancy, 11 to 13 weeks ultrasonography, where we talk about the cervical length, the fetal soft markers, and of course the uterine artery PI, as you have rightly pointed out, should have been done, which is missing here. So now this patient presents to you at PHC, that too at a very high blood pressure, and there she receives only tablet labetalol. Now this patient is, she was advised admission, she did not get admitted. After 2 days, she comes in a very bad shape again. Blood pressure is very high. The doctor prescribes her only tablet nifedipine added, and now her blood pressure is still in the range of 180, 100 to 110 millimeter of mercury diastolic. So she was on tablet nifedipine, tablet labetalol, and magnesium sulfate. So any comments on this treatment? Her initial blood pressure was 176 by 116. What should have been, what is the drug of choice? If such patient comes to you, what drug should we start?
Well, see, in it's such kind of hypertension, nifedipine does work. Labetalol is not that effective. And
Absolutely. The message is very, very clear. 170 by 110, it is severe hypertension. And for such severe hypertension, either you have to give intravenous labetalol or you have to give capsule nifedipine oral. So tablet nifedipine, which is a sustained release, slow working tablet, doesn't have any effects. Now what happens to this? These are the flaws which have gone wrong during the initial treatment. Now this patient comes to the tertiary care center. She undergoes cesarean section, and after 12 to 14 hours, suddenly she develops severe cough, breathlessness and restlessness. Her pulse rate is 115, blood pressure is 220 by 118, oxygen saturation is 70%, there's a wheeze in the chest and no clear breath sound. So what is your diagnosis here?
So obviously it's a LVF leading to pulmonary edema.
Correct.
To manage on that line. The hypertension is not properly managed. Now she has landed up in the pulmonary edema.
Correct. So that is how we have to analyze. But then what is your management now that she has landed into pulmonary edema? So how do you manage this case?
Well, so you have to give diuretics, you have to give digitalize, you have to make the patient proper, put oxygen if required, you may ventilate, you may put BiPAP or ventilation if required, if it is severe.
Yes, 70%. The oxygen saturation is 70%. You have to really hurry up with all this ABCD, your algorithm you have to follow. You have to see that the patient is breathing well. If not, whether the airway is patent or no. If she is breathing well, you supplement with oxygen. If she is not breathing on her own spontaneously, then maybe mechanical ventilation, as you have rightly said. And then meanwhile, you start with the diuretics. Now, which diuretics, how much? Loop diuretics, preferably the...
You have to use Lasix.
Yes, Lasix you have to give.
It has to be given as a IV bolus. You start with 20, 40, you may go to 80 till that you find that she's
Correct.
well.
So that is how diuretics, otherwise we give the message to the obstetrician, we always talk about that during pregnancy, there should be absolutely no use of diuretics unless it is pulmonary edema. So here the baby is delivered already. So even if the baby is inside, this is a case where you have to give diuretics because it's a pulmonary edema. Okay, so now she receives injectable labetalol, which actually she should receive at the very first visit at PHC, because such kind of cases should never be managed at PHC. 176 by 116, this is a very, very high blood pressure. If the patient is not getting ready, not getting admitted, it has to be explained to her, informed written consent has to be taken, and the patient has to be referred to higher centers at any cost. That is what our stand should be. If we just allow her to, dilute what the gravity of the situation, such complications can happen. This is a dire emergency. Naturally, your intensivist, anesthetist, everybody has to be involved into this. Now this patient actually develops cardiac arrest in this situation. What next? How do you manage it? Yes.
I think when there is a severe hypertension, there should not be used two drugs. With Nicardia, that is calcium channel blocker, so we can use the labetalol also. That gives the best control to the heart rate also. And in these situations, if a patient has in left ventricular failure, the 40 mg Lasix does not
exactly.
That should be dose to should be up to the 120.
Yes.
And for the severe hypertensions, we should start with the nitroglycerin drip.
Yes. So
and this seems to be a peripartum cardiomyopathy.
Yeah.
Bromocriptine should be added.
We have to rule out. We come to the next question. See, we have two questions here. What is the dosage, which antihypertensive, and what is the dosage? Whether somebody can describe about injectable labetalol.
When there is increased blood pressure as well as heart rate, labetalol will be the choice of drug. But before
how much labetalol? That's the question. And how? Whether oral or intravenous?
Only contraindication for using labetalol will be you have to see for the contractility of the heart. Firstly, if you do when the patient is being treated at higher center, tertiary care center, it is prudent to do a 2D echocardiography for the patient.
Correct.
And look for the contractility. If the contractility is less, already patient is left ventricular failure. So labetalol may not be a choice of drug.
Yes. So that is how you decide. Basically, whenever you have a case of pulmonary edema, along with other investigations, you have to do ECG and echo. Okay. And why this has to be done? Because you want to rule out the other causes of pulmonary edema, and like severe hypertension, as you have already said, some other cardiac disorders, cardiomyopathy, and so many, the pyelonephritis, varicella pneumonia, this also can happen due to the long-term use of tocolysis. So all these factors have to be ruled out, but that is a theoretical situation. What we are talking about is our patient has severe hypertension, and this is because of the mismanagement of the hypertension. So my question still remains to all the panelists, because this is a very, very important question, that for severe hypertension, which drug and how? Which drug you want to use? It can be labetalol or nifedipine. Nifedipine, we have already clarified, it should be capsule nifedipine 10 milligram orally. But for labetalol, it has to be injectable. Oral labetalol will not work at this point of time. This is a very severe hypertension. And how do you give injectable labetalol? Can anybody describe? Have all of you used sometime?
Yes, it comes
Yes.
with a 20 milligram vial.
Yeah.
You can give a 20 milligram bolus, and then you set in the dose depending on your response. You
Yeah.
can repeat the bolus every 10 to 20 minutes till
Correct.
she settles down.
Correct.
Once she settles down, you can put with the syringe pump about 20 milligram per hour.
Yes.
And maximum administer up to 600 to 800 milligrams per day.
Yes. So the protocol says that you start with 40 milligram bolus dose, you wait for 10 minutes, see for the response. If you don't get the desired response, that is fall in blood pressure, then you repeat 40 milligram After 10 minutes, if you still don't get the response, then you give 80 milligram. So that is how you can give, as Dr. Ajit has said, maximum you can give it as 600 milligram. So pulmonary edema, the basic principles of management, what is pulmonary edema? You have the accumulation of the fluid in the interstitial spaces, and thereby the lung compliance is reduced. There is ventilation perfusion mismatch, and there is hypoxemia, increased work of breathing. So you have to support this patient, as we have already described. So this is how you monitor and manage the acute crisis of this patient. But as obstetrician, as prophylaxis, we have to see that at what stage what has gone wrong. And the message here is very, very clear that whatever, and basically right from early pregnancy, she should have been screened, whether that you could have predicted that she could have developed hypertension. Nobody can prevent hypertension, but if she is at high risk, you can definitely start her on aspirin, 150 milligram, that is a recent recommendation. If you have protected her from Aspisol 150, then you have to observe this patient serially. At least you control her blood pressure with effective drug therapy. If at all this patient comes to you in such a severe condition, appropriate drug, that is oral nifedipine or intravenous labetalol, should have been started at the very first visit at PHC, so that this dreaded complication could have been avoided. At the same time, because she was posted for cesarean section, that time also all of you will agree to me that anesthetist ask you to give preload this patient. So that preload also adds to her load. You are giving oxytocin, maybe oxytocin, methergine, so many other drugs. Because she is a case of severe hypertension, impending eclampsia, you have given her Maxalf as well. So all these drugs lead to water retention and adds to the risk of pulmonary edema. So prevention is always better than cure, and that's the very reason we should talk about or think about prevention first. So Dr. Ajit, this is a case for you, 20-year-old primigravida with 9 months amenorrhea. She was referred to the hospital at 11 p.m. with history of admission at nearby nursing home at 3 p.m. So after 7 to 8 hours of labor pains, she was found to be a case of failure to progress, and she was posted for cesarean section. As a routine, bladder was catheterized, there is no urine output. So it was a small nursing home, so they referred this patient to the tertiary care center, saying that there is no urine output. When you examine, there is tachycardia, blood pressure is 110/70, severe uterine contractions, the fetal heart is almost 100 to 120, cervix is 7 centimeter dilated, membranes absent, hemoglobin 8 gram%, platelet 1 lakh, PT INR 2, APTT prolonged, FTP present, and fibrinogen is 150. Very clear cut case I am giving you. What is the diagnosis and how would you manage this case?
Okay, before going to diagnosis, there are certain things. Why there was no urine? Was the catheter in vagina? Usually the catheterization is left to the most junior in the team, and he invariably puts in vagina when there is, especially when the head is impacted.
Yeah.
And, may not get that.
So actually it was confirmed that it is in the urethra and there was no urine.
That it is in the urethra, and
and she was labeled as having anuria.
That is one. Number two, what prompted you to do this coagulation profile in this case?
Yes.
Why this has been done?
Yeah.
If a postgraduate presents this case with, and if he tells me,
if you talk about the diagnosis, I think, if you look at the case, if you talk about the diagnosis, there is a answer. The uterine contractions are very severe, tense, severe in intensity, almost not relaxing, and fetal heart is going down.
Has she received any prostaglandins?
No. Yes, the answer is coming from the audience.
Then it has to be abruption then. If the uterus is not relaxing, if it is a
Yes.
stone-like hard thing,
Yes.
then it is an abruption.
Yes, and that is why all these investigations are done. So, Dr. Ajit, what is the diagnosis here? What all problems you have to tackle for this patient?
Well, see, you have to manage the DIC, you have to manage the labor.
Yes.
You have to look at the renal function, you have to look at the liver function. All those things you have to tackle.
At this point of time, when she is having abruptio placentae with obstructed or labor, with anuria, with fetal distress. So do we do liver enzymes and wait for that, or how?
What is the fetal status?
FH is 100.
100?
100, yes.
Okay. CTG?
No, we have fetal distress right now.
No, that's okay.
It's an emergency. We don't have time to do.
Yeah.
Yeah. So I think anybody from the panelist. This was, anybody from the panelist?
I think this is a clear-cut case of abruption.
Correct.
So at 7 centimeter obstructed labor, patient is going into DIC. So immediate termination of pregnancy. Since it is obstructed labor, we have to immediately post her for emergency crash cesarean section.
Yeah.
So within 30 minutes, you have to deliver the
baby. I got your point. Whether you will do cesarean section immediately, you will arrange for the blood and blood component immediately.
It will be crash.
What will you do first?
It will be a crash cesarean section. This obviously.
What is that crash cesarean?
Within 30 minutes, decision to delivery interval has to be 30 minutes.
Yeah. Meanwhile,
within
what
those
will
30 minutes, you have to cross match the blood. 4 bloods, 4 PRP, 4 platelets will be arranged. Central line access evaluation by the anesthetist. Stabilization of the patient, IV fluid and crystalloids to be given, tranexamic acid 1 gram IV will be given, and
so in short, you have to do everything simultaneously.
Right. So it is call for help, so everybody has to be there. And these things have to be done in a institute where you have a ICU backup facility has to be there. So that is why I think the patient has been first of all referred from
It's a tertiary care center,
hospital.
that is what.
So we assume that the ICU team will be there for the stabilization.
Yes.
So in our institute, we immediately shift the patient to the operation theatre. We have the anesthetist team on call, which goes on looking at the head end of the patient, and we look after the delivery part of that. And so it is always a teamwork that has to be done simultaneously.
Given an opportunity, whether you would like to try for vaginal delivery?
Because you have written it is obstructed.
No,
labor.
I just
Otherwise,
want.
if she is 7 centimeters and by the time she is shifted to your institute, she should be full dilated. Assisted vaginal delivery, if possible, will go ahead with.
Very rightly pointed out, because all of you must have experienced this. If you have a placental abruption, there is myometrial, irritation. And because of this, the labor progresses very fast, even, very, very fast. Unexpectedly, we are so happy the patient delivers very fast. But when either the baby is dead or baby is absolutely non-affected, then only we can tell. Here we have fetal distress. So, not to stress the baby further, if everything is arranged, you take her for cesarean section. So, any comment on the blood pressure? What do you think the cause of abruptio here?
She must be actually hypertensive.
Correct.
Her blood pressure because of the bleeding. So it may be grade 2 abruption by Share's classification. It will be
correct.
So
almost grade 2 to
she is
grade 2 to grade 3,
and renal failure she'll be going. So that's why I said central line and management of the fluid according to that will be required post-operatively.
Correct. So almost grade 2 to going towards grade 3. So before she goes to grade 3, I think we are supposed to control everything and manage this patient. So as you have rightly pointed out that we have to arrange for blood and blood component, arrange for operation theatre, the expert obstetrician, expert neonatologist, anesthetist, and you tackle the situation fast, you deliver the baby fast, and now because this patient already has abruption, as I have already said, the blood has intravasited. Most of the times these are the patients who land up into PPH, postpartum hemorrhage. So there also you have to be very ready because this patient who has already having some kind of hypotension, because she may be hypertensive here. So you have arranged everything, you are simultaneously giving the transfusions, you are managing the patient, operating, remove the baby and the placenta, but you have to take care that she doesn't bleed again. And continuously you have to monitor all the coagulation profile as well. So my first question to you is, suppose this patient has come to you, so the lab takes quite a lot of time to give all these investigations. This I am giving you ready-made here because it's available, but suppose this patient comes to you and you want to see whether she has abruption because of that, whether she has these problems. So clinically, do you have any test which you can do at your place?
Clot retraction.
Yes.
Clot retraction.
So apart from bleeding and clotting time, you have clot retraction and clot lysis time. So bedside you can just take simple blood in plain bulb and you can just see after how much time it clots. Then after some time you see whether the clot is lysed. So clot retraction or clot lysis time, that is what very simple bedside investigation you can use. So naturally the principles of management is to stabilize this patient, to correct her hypovolemia and coagulation factors as well, expedite the delivery whatever is suitable and best possible at that point of time, and of course you have to restore the hematocrit and electrolytes, everything, see that she doesn't bleed again. So all in all, you have to take care of this patient, all the 4 components, the hypovolemia, the labor, anuria, and of course the postpartum hemorrhage. So very well described. Now Dr. Vijay, this is a case for you. 32-year-old para 1, I think this will be the last case because we have less number of panelists also. Do we have one more panelist to discuss? We have this 4th case. Previous cesarean section, male child, 1 year old, now 6 months amenorrhea. She's got previous cesarean section only 1 year back. Now 6 months amenorrhea, she comes to you with bleeding PV. And this is the first visit. Because of the job transfer, she has come to a different city and reported as emergency. By the time she reached hospital, the bleeding stopped. When you take her history in detail, she gives history of spotting previously also. And when you do ultrasound at 26 weeks, placenta previa with absent RP leg, anomaly scan is normal, internal os is normal, os closed, cervix length is normal. You call the patient after 1 month for a follow-up. 30 weeks, she started bleeding profusely at home. She started just bleeding. She started bleeding, and by the time she reached hospital, she collapsed. So what is the diagnosis here also? My first question is, what has gone wrong? Whether you need to counsel this patient initially when she was diagnosed to have this abnormality, and what could have been the management to avoid this complication, that we will talk first, because we are stressing on the preventive aspect mainly.
She has a case of placenta previa in the bleeding phase. The thing goes wrong is
placenta previa
in bleeding phase.
Okay, is it only placenta previa or something else?
Well, see, one thing you have mentioned there is absent retroplacental leg, isn't it? It's not a retroplacental leg, it has to be sonolucency, I suppose you wanted to put it over there.
It is absence of sonolucent zone on ultrasound, or it absence of retroplacental leg.
This particular sign is pointing you towards the past. Placenta accreta spectrum.
Right.
And she's likely to have a placenta accreta spectrum. And actually at 26 weeks, when it was diagnosed and it was suspected, she should have been on a very high vigilance kind of thing. She should have been indoor, should have been instructed about the bleeding. This case should have been prepared for any...
she was not suspected, she was diagnosed to have this.
Not?
she was diagnosed to have this.
Yes, she was diagnosed, but
Yes.
it seems that she is not prepared for the particular management of PAS, which should have been.
Yes, yes, exactly. So what advice? That is what I'm asking you. How should have been this patient managed, or rather how the patient and the relatives could have been counseled?
This patient had early pregnancy bleeding, and there was a USG report suggestive of low-lying placenta as well. So,
Previous seizure.
Further, she should be further evaluated whether placenta is still low-lying and being previa, or whether it has gone upwards. And
It is showing at 26 weeks, it is placenta previa with absent
yes.
RP leg. Yeah.
So she should have been advised and explained that she has
Yes.
placenta previa. And
Accreta.
She should be further evaluated whether it is or confirmed on MRI. How much is the invasion?
There is no need for MRI. The diagnosis is confirmed. We have the diagnosis. An expert sonologist with a good resolution of sonography machine can diagnose. So we have a confirmed diagnosis of placenta accreta. MRI is needed only when you want to do something, you want to map the placenta, then that comes later. Okay, so we have the diagnosis of ultrasonography.
She should be advised about the rest.
Yes.
Or
What kind of rest you want to? What instructions? Strict bed rest or yeah.
Strict bed rest is advisable.
Strict bed rest we should not advise. Yes.
But she should be hospitalized, number one.
First and foremost, she has to be hospitalized.
She has to be under observation.
Yes.
Your blood bank has to be ready for any disaster, any time. Number two, her anemia is very thoroughly corrected.
Correct.
Number four, counseling part. Counseling is the most important thing in the past problem. Well, see, the relatives have to be counseled for the need for the surgery, the extent of surgery, the magnitude of surgery, the risks involved
Before
in
that,
the surgery.
even the progress that any point of time she can bleed profusely.
Might bleed and may have to be taken up in the theater.
Yes.
Well, she may require hysterectomy. You may have to take a obstetric hysterectomy.
Yes.
The obstetric hysterectomy technique is different in past.
Correct.
Then you have to tell about the possibility of bleeding, possibility of death, neonatal rest, so many things are there.
Correct.
The ureteral injury, the bladder injury.
Yes. So now suppose you have taken, for this patient, you have decided that yes, okay, she will go ahead, we will monitor her very well and we will plan her cesarean section after 34 weeks. But suddenly she has collapsed now, she has started bleeding. So what will you do now? Now she has started bleeding, what will you do?
As she is collapsed, we should alert all IV bore line, take the blood for cross match, ask for the anesthetic to come to help, having a fluid resuscitations with crystallites, catheterizations, and we should simultaneously shift to the operation theater for this patient.
Yes, Dr. Ajit, you want to add?
Before a major bout of bleeding, there are many minor bouts of bleeding, and sometimes they may stop.
Yeah.
You can use the things like tranexamic acid to bring about hemostasis to some extent.
Yeah.
And if the bleeding stops, you may continue the pregnancy for some time.
Yeah, but we are not talking about that. Now our patient has collapsed.
If the patient is collapsed,
yeah.
If there is a massive blood loss, blood volume loss, and if she is still bleeding, we need to operate her.
Yes.
There is no other alternative.
So there is no alternative. But as you have rightly pointed out that when you have to advise the patient bed rest or not exactly bed rest, but rest with minimum straining, not to lift heavy weight, to avoid internal examination and intercourse, all these things have to be advised. She has to be hospitalized, and there comes the question whether we can prevent it. So what is the role of os tightening in your opinion?
No.
Absolutely no. Unless there is a shortening of cervix, that is the length of less than 2.5 centimeter, there is no evidence that we should go for os tightening. Do you think any place for tocolysis?
No.
Yes. So what precautions you have already described. So what does RCOG recommend, or what do you feel that suppose you want to avoid this, at what point of time earliest you can diagnose placenta accreta, or whether you can diagnose it earlier?
Well said. Even the diagnosis can be done as early as at an NT scan if it is a severe one.
Yes.
But at 20 weeks that scan, you should be able to suspect that probably she would go for a pass.
Correct.
And now the classification which we used to do as type 1, type 2, type 3 now has changed.
Yes.
That you look at the placental age, if it is inside 3 centimeters of the
Correct.
internal os,
Correct.
then it is a previa. If
Yes.
it is beyond 3 centimeters at any time during pregnancy, it is not a previa and she is not at risk.
Correct.
And again, then you put it as a major and minor degree. If it is covering the os, it is a major degree. If it is not covering the os, it is a minor degree previa.
Yes.
And then you look for the signs of pass.
Correct.
Signs of pass, the most important and the sign which you will be able to see in each and every case is a loss of sonolency.
Yes.
That is consistently will be there in all the patients.
Correct.
The second sign is the presence of placental legs.
Correct.
You will have the sonolencies which are different from the what you see in the sort of the legs which we normally see in the
Yes.
placenta. So
Yes.
these are quite vascular, and if you put a color on that, you will
Yes.
be able to find the flow in that.
Yes.
The color Doppler signs is the increased vascularity. You will get lot of vascularity.
Yes.
There will be penetrating vessels
Yes.
which will go and connect to those placental sinuses.
Yes.
In the severe, the percretas and those things, they will have
Yes.
the loss of lining of the uterus.
Yes, the loss of interface between the myometrium and the
There will be
bladder as
something
well.
like a honeycomb
Yes.
appearance of the lining.
Yes.
And in the severe cases, you will be able to see it percreta. It might have been invading into the bladder, and you will be able to see
Correct.
the
Correct.
invasion into the bladder.
So just to sum up for the audience, at the earliest 11 to 13 weeks also you can make a diagnosis of placenta, whether it is low-lying, whether it is adherent, it is, there is no plane of cleavage which we clinically say, or the absence of the sonolucent retroplacental zone, as Dr. Ajit has very correctly described in details about the presence of the increased vascularity and the loss of interface between the myometrium and the bladder. All these things we can diagnose at the earliest by 11 to 13 weeks. If not, after 16 weeks, definitely you have to see whether the placenta is lying within 2 centimeter of the internal os or more than 2 centimeter away from the internal os. That is how you label the patient as having low-lying placenta, and you observe it serially. Subsequently, you classify as placenta previa. So definitely you have to keep a watch and follow up the patient so that you can make a diagnosis of placenta previa accreta. And once you diagnose, you keep this as a protocol that right from the beginning, whenever you diagnose the patient as having placenta previa accreta, you have to tell the patient and the relatives that she has to be hospitalized, blood has to be always reserved for her, and her course will be always unpredictable. At any point of time she can bleed. There may be problem with the baby, there may be problem with the mother may even face some serious complications, and if at all she reaches 34 weeks, meanwhile you start giving her antenatal steroids, maybe magnesium sulfate just before you plan for cesarean section for neuroprotection. And then preferably 34 weeks completed. If at all you feel that there is further danger, you may plan her cesarean section, but this cesarean section has to be planned. It has to be a planned procedure. It should not be such emergency that, because all the senior obstetricians, senior anesthetists, the blood bank, neonatologist, the entire team, if at all sometimes you need the oncosurgeon or urosurgeon, you may need the stenting of the ureters, you may need the interventional radiologist. So all this team will be available in the daytime. The procedure has to be done in the tertiary care center, and it has to be with all this team. So it has to be with proper explanation to the patient and relatives, and there has to be an informed written consent about the elective obstetric hysterectomy. It is not emergency hysterectomy, it has to be elective obstetric hysterectomy. Only one last question. Is there, suppose she is, not about this case, but suppose she is primary and she says, I don't want to remove my uterus. So is there any other procedure where you can try and save? Suppose she has patchy, because she is bleeding. The very fact, let me share with you that if it is a complete placenta previa accreta, usually it is adherent to the full extent. It doesn't bleed profusely before labor or before seizure. But if it is patchy, then it separates and bleeds. So for this patient, suppose she has patchy adherence, so would you do some other procedure if she desires?
We should don't remove the placenta.
If she is a priming, unless there is some endometrial insult, she won't develop accreta percreta.
She has sometimes history of DNC.
There is an endometrial insult, then she is likely to develop accreta percreta.
Yes, this is her first baby.
Yeah.
Okay, but she wants to conserve her uterus. So any other procedure you want to offer her?
Don't remove that placenta. Just
Close the uterus.
Cut the cord and afterwards use the methotrexate. That will dissolve. One thing. Then there are three.
This is not acceptable. Even last 30 years, I have seen some of the cases of placenta accreta. Maybe 30 years back, maybe first 1 or 2 years, I have seen in medical colleges, but you leave the placenta behind and give methotrexate, doesn't work at all. First and foremost, even the evidence says that there are thousands of cases saying this placenta, when you live inside, you have to give higher antibiotics, keep her hospitalized. How long you will keep her hospitalized, and the placenta gets slowly autolyzed and gets expelled. But this is really theoretical. This patient can land up into septicemia, severe hemorrhage. So it's a hanging sword on your head. So evidence doesn't support methotrexate. And doesn't support
Second
even,
thing is, we can do for the pelvic devascularization, uterine artery ligation, ovarian and internal iliac artery ligations.
Okay.
Third is 3P technique. We should go above the placental edge in the upper segment.
So that is what I want to ask you. What is the triple P?
Triple P.
Yes.
That is, we have to take incisions above the margin of the placenta.
Yes, there comes the role of MRI for placental mapping. Yes, very good.
Then we have to go for the pelvic devascularization. And then third is we have to cut with the myometrium and then repair it.
Right.
That placenta should be cut from the myometrium, and that myometrium should be repaired.
Yes. So perioperative localization, then you do the pelvic devascularization, and then you do the patchy myometrial resection, but then you have to close it very thoroughly, and still you have a risk of subsequent bleeding. You have to be really ready to face the emergency. It's not a very successful method still, though it is described. There are many cases, but as a research only. Then practically we don't have many cases on this. So I think with this we end with our panel discussion, and I hope you find it interesting, quite routinely faced cases, I think. Definitely as obstetrician we face all these emergencies. I do have many cases here, but I'm not going to take much of your time because we have inauguration waiting here, and I will just give one message for this last case. I will not ask the panelists about this. Here this is a case of diabetic ketoacidosis where unexpectedly this lady landed up into an emergency, got operated for cesarean section, and she started behaving looking very confused, drowsy, and started vomiting. So when we examined, she didn't have any bleeding, her blood pressure was normal, everything was fine. So it was a non-hemorrhagic sort of emergency, and when we did her bedside glucose with the glucometer, it was more than 450 and the ketones were large. So this is a case of diabetic ketoacidosis. Of course, all of you know how to manage. You can manage with the help of physician also, but the very simple test of this glucose level that you should do for laboring women anytime. As an obstetrician, single step oral glucose tolerance test has to be done for each and every woman at the very first antenatal visit, and of course it has to be repeated at 24 to 28 weeks. That's the only message I want to give from this. Such a simple investigation can, protect you from such a disastrous condition. So with this, I conclude my panel discussion. Every obstetrician, every obstetric unit and every person of obstetric team must be trained and skilled to manage the maternal collapse. No, there is no time for immediate referral because the patient may die during transfer, and unsettled patients, shifting of these patients will worsen the situation. You will land up into multiple issues. So the team should manage effectively then and there only, but for this we should have efficient multidisciplinary team and not only HDU. So it's a manpower as well. Thank you so much. Once again, every life counts. Thank you, and we are the saviors. I thank all the panelists and the interactive audience as well. Thank you so much.
Thank you, Sneha Madam. It was a very nice interactive panel discussion. Madam, I request you to be on stage, Madam, for a minute. I request Sneha Buha Madam to please felicitate all our panelists. Dr. Ajit Gandhi, sir. I request Anjali Jamma Madam, Milind Shah sir and Guram sir to please join them on the stage. Ajit Gandhi sir, please stay on the stage. We need a group photograph too. Please felicitate the remaining panel. Dr. Lakshmikant Marda sir. Dr. Vijay Pawar sir. Dr. Vijay Pawar sir. Dr. Pradeep Patil sir. Dr. Chandrakant Zadav sir. Audience, please don't go away. We're going to have the inauguration right away. I request our president to please felicitate Sneha Buhar Madam, who has done an excellent job moderating this panel. A loud round of applause, please.
अश्विनीला थांबवलं होतं.
We request everybody to be please seated in your place. Can you please be seated?
Please take your tea and please be seated. We are shortly starting the inauguration process. Hello, may I have your attention please? Please be seated everybody. Yes, please be seated. We are starting the inauguration ceremony. Vaishali Kadukar Madam, Guest of Honor Dr. Rajendra Singh Pardesi, Organizing Chairpersons for today's conference Dr. Anjali Jamma, Dr. Milind Shah, Dr. Manik Gurram, esteemed Chairpersons of SOGS, Dr. Monica Umardand, Organizing Secretary Dr. Nanda Magai, respected office bearers of SOGS and SOGS, invited esteemed speakers of the conference, senior members of our society, media representatives, and my dear friends. A very good evening, one and all. Motherhood. As it is rightly said, it is a divine journey of transformation of a woman to a mother. We obstetricians are privileged that we are a part of the journey to honor a woman and honoring the birth process. Journey of labor, as you all know, is a physiological process. It is predictable that the baby will be delivered, but sometimes there may be some unexpected storms. At that time, we as obstetricians have to navigate the ship with our friends to reach the bank smoothly. With these opening remarks, We welcome you all today for inauguration of our unique conference, Revisiting the Journey of Birth. To begin with, I would like to call dignitaries on dais. May I call Dr. Anjali Jamma, President SOGS, to come on dais. May I request Dr. Vaishali Kadukar, DCP Solapur, to please come on dais. May I request Dr. Milind Shah, Organizing Chairpersons of today's conference, to please come on dais. May I request Dr. Gurram Sir, Organizing Chairperson, to please come on dais. May I call Dr. Sneha Bhuyar, Chairperson, Medical Disorder Committee, AMOGS, to please come on dais. I would like to call Dr. Rashmi Kahar, Chairperson, High Risk Pregnancy, AMOGS, to please come on dais. I request Dr. Monica Umardand, Chairperson, Public Awareness Committee, AMOGS, to please come on dais. It's my pleasure to call Dr. Nanda Magai, Organizing Secretary, to please come on dais. I call Dr. Virkar, Treasurer of today's conference and Vice President of Solapur, OBGY Society, to please come on dais. I invite Dr. Archana Khare, Secretary SOGS, to please come on dais. I would like to invite Dr. Supriya Jadhav, Clinical Secretary SOGS, to please come on dais. Thank you, everyone. Before starting any function, we take blessings from God. I call upon our own society members, Dr. Meena Gunzotikar and Dr. Archana Shah, for Saraswati Vandan in their sweet voice.
या कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युत शङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्म विचारसार परमाम् आद्यां जगद्व्यापिनीं वीणा पुस्तकधारिणीम् अभयदां जाड्यान्धकारापहाम् हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्.
Thank you, Dr. Archana and Dr. Meena. I now call upon our charming and dynamic President of SOGS, Dr. Anjali Jamma Madam, consultant at Jamma Hospital, and she has special interest in cosmetic gynecology. Madam has taken immense efforts to make this conference a success. Her work always inspires us to dream more, learn more, and do more. Over to you, Madam, to express your views.
Good evening, dignitaries on the dais.
esteemed faculties, and my dear friends. At the outset, let me take this opportunity to extend a warm welcome to our chief guest, Dr. Vaishali Kadukar Madam, DCP Solapur. Guest of honor, our AMOGS President, Dr. Rajendra Singh Pardesi Sir, Dr. Sujata Dalvi Madam, Secretary AMOGS, Dr. Amey Purandare Sir, Second VP AMOGS, Dr. Sneha Bhuyar Madam, AMOGS Chairperson Medical Disorder Committee, Dr. Rashmi Kahar Madam, Chairperson High Risk Committee AMOGS, our own Dr. Monica Umbadan, Chairperson Public Awareness Committee AMOGS, and Chaitanya Shembekar Sir. We have organized this conference in association with these committees of AMOGS. This conference had conceptualized in my mind much before I took up the reins of SOGS presidency. The current trend in our fraternity is mainly towards updating ourselves about recent advances, high-risk cases, infertility, laparoscopy, and so on. In this quest of conquering a new and latest, we often tend to lose touch with basics. That is why we thought of this labor conference, which would be a platform to refresh our knowledge of labor from basics to advance. Majority of us nearly perform deliveries on daily basis, and I wanted to work on that. Childbirth is more admirable than conquest, more amazing than self-defense, and as courageous as either one. Labor, as we know, can take unexpected turns, putting the woman's life and baby's life in danger. Normal labor is the most essential art every gynecologist should master. We are fortunate to have rich treasure chests of knowledge in the form of our esteemed faculties from all over the country to help us achieve mastery in this. We will prove to be an academic and leisurely feast, along with workshops, informative lectures, debates, panels to stimulate our brains, and we have a memorable Bollywood-themed tribute to Lata Mangeshkar planned for the banquet. Welcome once again, and thank you for the attending in a large number. Thank you once again.
Thank you, Madam, for those kind words. On behalf of the Solapur Obstetrics and Gynec Society, we would like to felicitate dignitaries on dais. May I request Dr. Anjali Jamma, Madam, to felicitate our chief guest, Dr. Vaishali Kadukar. Thank you, Madam. We would like to felicitate Dr. Rajendra Singh Pardesi, Sir, AMOGS President online with an e-trophy. Is it there? Okay, we will take afterwards. May I request Dr. Milind Shah, Sir, to felicitate Dr. Sneha Bhuyar, Madam. I request Dr. Gurram Sir to felicitate Dr. Rashmi Kahar, Madam. Thank you, sir. I request Dr. Virkar Sir to felicitate our own Dr. Monica Umardand. Can we have the e-trophy for Pardesi, sir? Yes. Hello? Dr. Pardesi sir, can you hear us? Yes. Okay. Thank you, sir.
Yes, thank you.
Thank you, sir. By lighting a lamp of knowledge, let us dispel the darkness of ignorance. I request all the eminent dignitaries on dais to please come forward for lamp lighting ceremony.
हर तुम्हें पापम संध्यादीपनमोऽस्तुते ओ दीप ब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीप ब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठे गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः 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 शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तु
Thank you, everybody.
ओ दीप ब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीप ब्रह्मरूपस्त्वं
With a clear vision and positive attitude, all roads open up and nothing is impossible. This holds very true for none other than Dr. Milind Shah sir. He is a person of capacity to transform vision into reality. He is an eminent gynecologist, editor member of Foxy website. He has shared his experience and knowledge by delivering lectures in various countries. Also, he has authored a book on hypertensive disorders in pregnancy. I now invite Dr. Milind Shah sir, organizing chairperson of the conference, to express his views.
Thank you very much, Dr. Ketki, for your kind words. Friends, but I am here in front of you as a friend of all of you rather. I must say a big thanks to Dr. Vaishali Kadukar for taking out time and coming here as a chief guest. The president of Solapur OBGYN Society, Dr. Anjali Jamma, my co-chairman, Dr. Mani Gurram, Dr. Archana Khare, who is the secretary, Dr. Supriya, who is the treasurer, as Dr. Monica, Dr. Nanda Magai, who has put a lot of sweat in this particular conference organization, because we were held up in various actually the problems, but she took the lead and she has done the maximum work for organizing this particular event. Nanda, we always remain for that. Dr. Vivek Virkar, my very two close friends, yes, Dr. Sneha Bhuyar and Dr. Rashmi. We have been working together for years together in the Vidarbha, and that's why people call me that I am from Vidarbha, not from Solapur. That's how, friends, it's a group and team work with which we are bringing this new actually revisiting concept of the labor. You understood that yes, we have changed a lot in our protocols. We have changed a lot as far as the management of labor is concerned. Just now in the previous scientific program also you learned that there are certain new things which are coming up, and as just now we were discussing with our chief guest Dr. Vaishali, yes, the cosmetic gynecology after this childbirth is again becoming very important branch. We need to be always abreast with this scientific development to give maximum to our patients, and that's how quite often suppose we won't do that, the medico-legal problems may peep in. And that's why we have kept a very didactic lecture on that as well to understand about those things. But from our side, from other side of the table, the respectful maternity care is also important because the woman comes to your office with a lot of faith and confidence. So taking into consideration all these aspects of labor, friends, we are presenting in front of you this 2 days very magnanimous event for which the Solapur OBGYN Society has taken immense help, immense efforts to do the best for this scientific program, and that's how I as an organizing chairman, I take this opportunity to welcome you all for this event. I understand whatever the best credit you are going to give, you must give it to the organizing committee, but more so the Solapur OBGYN Society, Dr. Anjali Jamma. Whatever lapses you will find, you can give it to us because we were, bit held up with certain things. But I'm very sure you will enjoy this particular 2 days event, and you will learn a lot about labor. Thank you very much.
Thank you, sir. Someone has said, do not go where the path may lead. Go instead where there is no path and leave a trail, which holds very true for none other than Dr. Manik Guram, sir. A multifaceted personality, an eminent gynecologist, who has special interest and expertise in NDVH, bipolar and laparoscopy. So I now call upon Dr. Guram sir, organizing chairperson of the conference, to express his views.
व्यासपीठावरील उपस्थित डॉक्टर स्नेहा भुयार मॅडम, डॉक्टर रश्मी खर मॅडम, डॉक्टर कडूकर मॅडम, त्यासुद्धा डॉक्टरच आहेत. त्याच्यानंतर जम्मा मॅडम, मिलिंद शहा, विवेक विरकर, नंदा मगई, मोनिका उंबरदंड, अर्चना कारे, सुप्रिया जाधव. जर्नी, रिव्हिजिटिंग द जर्नी ऑफ बर्थ. प्रवास करणे हा एक आनंददायी अनुभव आहे. आपणा सर्वांची सुरुवातसुद्धा अशाच एका प्रवासाने झालेली आहे. पण गंमत म्हणजे हा प्रवास कधी झाला आहे आपल्याला माहितीच नाही प्रत्येकाला. पण ज्या अर्थी आपण सगळे डॉक्टर्स आलोत, काही एम आर आहेत ते एम आर झालेत आणि छानपैकी इथं आपण बसलोत, त्या अर्थी नक्कीच तो प्रवास आपला आनंददायी झाला असणार, आपला IQ चांगला असणार, म्हणूनच आपण इथं बसलो आहे. मग अशा आयुष्याच्या प्रवासात आपण याच प्रवासासोबत अभ्यास केला आहे की ज्यामुळे या जगात येणाऱ्या सर्व प्रवाशांचा सुद्धा प्रवास सुखकर करतो. म्हणजे आम्ही गायनेकॉलॉजिस्ट याच प्रवासाचाच आपण अभ्यास करतो आहे. माहिती आहे की आत्ताच्या जमान्यात नवीन नवीन येत आहेत की कॉस्मेटिक सर्जरी, लॅप्रोस्कोपिक सर्जरी, रोबोटिक सर्जरी, पण तरीसुद्धा यंगर जनरेशनला जर का काही चांगलं शिकवायचं असेल तर हा जो प्रवास आहे तो जन्माच्या सुरुवातीचा होणारा प्रवास, तो चांगलं हे फार महत्त्वाचं आहे. आणि या रिव्हिजिटिंग द जर्नी बर्थ या या महत्त्वाच्या प्रवासाच्या नवीन नवीन गोष्टी आपण सकाळपासून शिकत आहोत आणि उद्यासुद्धा आपण नवीन गोष्टी काही शिकणार आहोत. आपण जर एखाद्या चांगल्या ठिकाणी जात असेल, प्रवास करत असेल, तर आपण गुगल ड्राईव्हवर शोधतो द रूट टू फॉर दॅट प्लेस, द प्लेसेस टू विजिट, द थिंग्स टू डू ॲट दॅट प्लेस, थिंग्स टू परचेस. आणि अशा अनेक गोष्टी आपण बघतोय. अगदी त्याचप्रमाणे या 2 दिवसात गर्भाशयातून सुखरूपरित्या बाळ बाहेर येण्याचा प्रवास याचा अभ्यास आपण करतोय. कारण बाळाचं रडणं हे आपल्या सगळ्यांच्या चेहऱ्यावर आसू फुलवतं आणि जर का बाळ रडलं नाही तर आपल्याला सुद्धा रडावं लागतं. तर आशा आहे की या 2 दिवसात जे काही आपण शिकतोय त्यानंतरचा उपयोग आपण करूया आणि या ऑप्सटिक गायनॅकमधल्या ऑप्सटिक हा जो विषय आहे ह्याच्याकडे जास्तीत जास्त नवीन यंगर जनरेशन येतील यासाठी प्रार्थना करूया. धन्यवाद.
Dhanyawad, sir. It's my privilege to introduce our today's chief guest, a guest of honor, Dr. Rajendra Singh Pardesi. Sir is at present President of AMOGS 2224. Sir has many national and international paper presentations to his credit. He has won 7-time Best Paper Award in FOXY AICOG journals. Sir was a past president of FOXY and AMOGS. As Sadhguru has rightly said, integrity, insight, and inclusiveness are the 3 essential qualities of a leader, and that's so true of Dr. Pardesi sir. May I request Dr. Pardesi sir to address us on this occasion online.
Hello. Hello.
Yes, sir, we can hear you. Yes, sir. Yes.
Good evening, everybody. Respected Chief Guest, Dr. Vaishali Kudukar ma'am, our office bearers, organizing committee, Dr. Melisha and Dr. Manikuram, our old friends, then Dr. Anjali Jamma, Dr. Vivek Kudukar, Dr. Nanda Magai, Dr. Archana Khare, Dr. Supriya Jadhav, and our 3 stars from AMOGS, Dr. Sneha Goya, Dr. Rashmi Kar, and Dr. Monica Umbardan. Dr. Monica Umbardan from Solapur Society, she is the rising star in AMOGS. I wish to congratulate Solapur Obijaya Society for taking this initiative, as Dr. Guram told about. This is a journey, revisiting the journey of birth, and still it's very important to learn many things about that. Basics of PFM and postpartum fetal monitoring, induction of labor PPH, children dystocia and maternal collapse, all these topics, they are covered in this conference, which helps to reduce maternal mortality. Dr. Vaishali Kudukar, just I wish to introduce our AMOGS work, that maternal mortality rate was highest in 1990, it was about 600 deliveries, means 600 maternal mortality per 1000 delivery was the rate, and WHO and FOXY AMOGS has taken this initiative to lower down. Now, India has target of 70 per 1 lakh in 2030, and now India's maternal mortality rate is 103, and proudly I will say the maternal mortality rate of Maharashtra is 38 only, and this 38 rate is because of the training and these workshops, CNEs, and services of our doctors. These are our doctors, gynecologists in this field. So congratulations to the organizers and Solapur Obijaya Society for organizing this conference. I wish every success to this conference. Thank you so much. Thank you so much for inviting me.
A great Rajendra Singh to have you. Actually, we wanted you to have physically here, but we are really happy to have you online as well. Thank you very much.
Thank you.
Thank you, sir.
I now request our dynamic Dr. Monica to introduce our chief guest, Dr. Kadukar. I'm sorry. I request Milind Shah sir to please introduce our chief guest, Dr. Kadukar.
Well, friends, we are really privileged to have a chief guest, Dr. Vaishali Ishwar Kadukar, who is a DCP of our department. You know, friends, there is a very interesting story. Last year, I was holding the office of Indian Medical Association, and where I saw the way she was working so dynamically, that itself is a great introduction of her. Basically, there were a lot of issues, that related to the medical practice as well as administration. But being a very efficient officer, she managed to tackle all those situations very, very effectively, and that is really remarkable on your part, Dr. Vaishali Kadukar. She is from Gadhinglaz, Solapur, and she has joined Maharashtra Police Service since 2010. She is also a doctor, and I think will be the best guest for this particular event because she understands the both aspects of childbirth. Her hobbies are trekking and cycling. She worked at various places in various positions, like from 2012 to 2014, Upavibhagiya Police Adhikari Usmanabad, 2014 to 2017, Upavibhagiya Police Adhikari Haveli Upavibhag Pune Gramin, 17 ते 19 अपर पोलीस अधीक्षक CID महाराष्ट्र राज्य, 19 ते सप्टेंबर 19 पोलीस अधीक्षक नागरी हक्क संरक्षण कोल्हापूर आणि 24/9/2019 पासून पोलीस उपायुक्त सोलापूर शहर आणि सोलापूर उपायुक्त म्हणून काम करत असताना जी शिस्त त्यांनी सोलापूरला लावली आहे सगळ्याच फील्डमध्ये ती खरंच वाखाणण्याजोगी आहे. So it gives me really immense pleasure to present in front of you our very dynamic police officer, Dr. Vaishali Kadukar. Thank you.
Thank you, sir. May I request our chief guest, Dr. Vaishali Kadukar, madam, to please address us on this occasion.
Good evening, everyone. All respected doctors. मला वाटतं गेस्ट सहित सर्वच डॉक्टर आहेत या ठिकाणी. हा जो काही इनॉगरेशनचा प्रोटोकॉल आहे, रिव्हिजिटिंग जर्नी ऑफ बर्थ, ही जी आपली आजची आणि उद्याची कॉन्फरन्स आहे त्या कॉन्फरन्सचा हा जो फॉर्मल पार्ट आहे इनॉगरेशन, त्या इनॉगरेशन फंक्शनसाठी डायसवरील सर्व डिग्निटरीज ज्यांना मी गेल्या 3 वर्षांपासून ओळखते आणि लॉकडाऊनमध्ये ज्यांच्यासोबत काम केलेलं आहे, असे विजनरी व्हेरी डेडिकेटेड डॉक्टर मिलिंद सर, डॉक्टर मोनिका मॅम अँड बाकीच्यांना मी फर्स्ट टाईम पाहते. कारण लॉकडाऊनच्या वेळेला मिलिंद सरांशी जो इंटरॅक्शन होता त्यावेळची जी गरज होती आणि त्यावेळचं जे इंटर डिपार्टमेंटल कोऑर्डिनेशन होतं, आय थिंक इट वॉज वन ऑफ दी एपिटोम इन दी हिस्ट्री. आणि मला वाटतं आपल्या आयुष्यात ही वेळ एकदाच आलेली आहे. कित्येक पिढ्यांमध्ये ती आपल्या वाट्याला आली आणि आय थिंक वी वर लकी इनफ की आपण या सोसायटीसाठी सर्विस देऊ शकलो, त्यांच्यासाठी काहीतरी करू शकलो. आज या ठिकाणी जी काही कॉन्फरन्स आहे आणि या कॉन्फरन्सचं टायटल आहे रिव्हिजिटिंग द जर्नी ऑफ बर्थ. मगाशी मॅमने सांगितलं की बर्थ इज अ फिजिओलॉजिकल प्रोसेस. फक्त त्याचं नेव्हिगेशन करण्याचं काम ऑब्स्टेट्रिशियन्स करत असतात. पण हे नेव्हिगेशन आपण करत असताना आपल्याकडे इनफॅक्ट द प्रेग्नंट लेडी इन्क्लुडिंग हर फॅमिली इतका आशावादी दृष्टिकोन असतो, खूप आशेने पाहत असतात आपल्याकडे. आणि जेव्हा आपल्याकडून समोरच्यांच्या डोळ्यांमध्ये आशा आपण पाहतो तेव्हा आपलं काम करणं हे फार अजून जबाबदार बनतं. कारण आपल्याला फक्त आपलं काम करायचं नसतं, तर त्यांनी जे आपल्यामध्ये आशा बघितलेल्या आहेत, आपल्याकडून ज्या काही अपेक्षा केलेल्या आहेत त्याची पूर्तता करायची एक मोठी जबाबदारी आपल्यावर असते. हे जे काही निर्मितीची प्रक्रिया आहे, मी बेस्ट ऑफ माय नॉलेज फक्त जननी आणि जन्मभूमी या दोघींमध्येच ही कॅपॅसिटी आहे, ही शक्ती आहे. आणि या निर्मिती प्रक्रियेमध्ये स्मूथ लँडिंग करण्यासाठी आपण जो पायलटचा रोल या ठिकाणी निभवता तो फार महत्त्वाचा आहे. आपण आपल्या आईवडिलांप्रती ऋणी असतो, कारण आपल्याला त्यांनी जन्म दिला, या पृथ्वी तलावर मानव म्हणून त्यांनी आपल्याला जन्म दिला. वी आर इक्वली थँकफुल टू ऑल ऑफ यू की आपण हा जन्म सुकर आणि सुसह्य केला. मगाशी परदेशी सरांनी सांगितलं की मॅटर्नल मॉर्टॅलिटी रेट जो 660 पर 1 लाख डिलेव्हरीज होता, तो महाराष्ट्रासाठी 38 MMR आहे. अँड ऑल क्रेडिट गोज टू यू, युअर कन्सर्न, युअर डेडिकेशन. कारण एका निर्मितीबरोबर एक जीव देखील तुम्हाला सांभाळायचा आहे, तो लॉस देखील होऊ द्यायचा नाही आहे. आणि ह्या दुहेरी जबाबदाऱ्या पार पाडत असताना आपल्याला बऱ्याच गोष्टींना सामोरं जावं लागतं. माणूस हा खरोखर फार कृतज्ञ आहे असं मला म्हणावंसं वाटतं, कारण इन्सिडन्सेस काही सोसायटीमध्ये असे घडतात. अदरवाईज डॉक्टर्सचा जर पोलिसांशी संपर्क तेव्हाच होतो बट समथिंग हॅपन्स रॉंग. मग त्यावेळेला असा विचार करावा लागतो की माणूस काही गोष्टी सोयीस्कररित्या कसं काय विसरतो. म्हणजे लॉकडाऊनमध्ये आपण 2 वर्ष जे काही सहन केलं, जे काही भोगलं, जे काही त्रास झाले ते आपण सोयीस्कररित्या लॉकडाऊन रिलीज झाल्यानंतर विसरले. एक डॉक्टर म्हणजे ह्या निर्मिती प्रक्रियेमध्ये किंवा एका नवीन निर्मितीच्या प्रक्रियेमध्ये जे काही तन मन धन ओतून प्रयत्न करत असतो, त्या प्रयत्नांना आपण सोयीस्कररित्या कसं काय विसरतो, हे काही वेळेला आम्हालाही प्रश्न पडतो. हा काही मी माझा मोठेपणा म्हणून नाही सांगत आहे, पण सोलापूर वॉज द फर्स्ट एक्झाम्पल. बेस्ट ऑफ माय नॉलेज की पहिल्यांदा महाराष्ट्र राज्यामध्ये सोलापूरमधून डॉक्टर आणि हॉस्पिटलवर हल्ला करणाऱ्या व्यक्तींना तडीपार करण्याची प्रक्रिया ही मी केलेली आणि ती सोलापूरमधून केलेली आहे. कारण या गोष्टी अजिबात ॲक्सेप्टेबल नाही आहेत. हां, आपण हे मान्य करतो की डॉक्टर इज नेक्स्ट टू गॉड. जिथं देवाच्याही हातात नाही आहे तिथे आपण डॉक्टरकडून, ती देखील व्यक्तीच आहे, त्यांच्याकडून किती अपेक्षा करायचा हा देखील प्रश्न पडतो. आणि मग ज्यांची अपेक्षापूर्ती होत नाही तो जमाव मग अशा काहीतरी कृती करतो. त्यामुळे मग आम्ही ठरवलं की या गोष्टींना अजिबात आपण टॉलरेट करायचं नाही. दो देर वॉज अ लॉस्ट ॲट देअर पार्ट, कायदा हातात घेणं हे त्यांचं काम नाही आहे. त्यामुळे आम्ही एक 5 महिन्यापूर्वी 3 लोकांच्या गँगला आपण सोलापूरमधून 2 वर्षासाठी तडीपार केलेला आहे. वी आर ट्राईंग आवर बेस्ट की जी काही कायदा सुव्यवस्था आहे, जे काही इश्यूज डॉक्टर्सना फेस करावे लागतात, त्यामध्ये ॲज अ पोलीस ऑफिसर बिंग अ मेडिकल प्रोफेशनल आमचीही काही याच्यामध्ये मदत होईल. सरांनी प्रेसिडेंट असताना अँटी स्पीड मूवमेंट सुरुवात केली होती. दॅट वॉज ऑल्सो व्हेरी नाईस इनिशिएटिव्ह. आत्तासुद्धा व्हॉट्सअपवरती काही ग्रुपवर अँटी स्पीड मूवमेंटबद्दल येत आहे, जे आपण 1 वर्षापूर्वीच सुरू केलं होतं सर. तर एक सरांची इच्छा होती की सर्व हॉस्पिटल्स हे ऑनलाईन पोलीस कमिशनरेट्सशी जोडले जावेत, जेणेकरून ज्या MLCचा इश्यू होतो तो इश्यू रिझॉल्व्ह होईल. तर सर आय एम रिअली व्हेरी सॉरी, माझ्याकडूनच ती थोडी दिरंगाई झालेली आहे, बट आय विल डेफिनेटली वर्क अपॉन दॅट. या ठिकाणी यू ऑल आर व्हेरी हायली एज्युकेटेड, ऑल आर डिग्निटरीज ऑर हियर. त्यामुळं माझ्याकडून सांगण्याचं किंवा बोलण्यासारखं काहीच नाही आहे. इन केस इफ यू नीड एनी हेल्प फ्रॉम पोलीस डिपार्टमेंट, feel free to communicate me, and I wish you all of you a very good luck. Thank you.
मनापासून खूप खूप धन्यवाद मॅडम. यू आर अ रिअली इन्स्पायरिंग. मे आय रिक्वेस्ट द मोस्ट लविंग, एनर्जेटिक ऑर्गनायझिंग सेक्रेटरी डॉक्टर नंदा मगाई to give vote of thanks. She is rightly the backbone of this conference.
Good evening, everyone. Respected dignitaries on the dais and my dear friends, it is indeed an honor and privilege to present the vote of thanks on this auspicious occasion. Myself, Dr. Nanda Magai, being the organizing secretary of this conference, would take this opportunity to welcome you all with the warmth in my heart on behalf of Solapur OBGY Society. This conference has been organized in collaboration with various committees of AMOGS, and I am highly indebted to them. Today, we are truly blessed to have DCP Dr. Vaishali Kadukar as chief guest, who was kind enough to accept our invitation in spite of her busy schedule. Thank you, Madam. My highest regards and heartfelt thanks to Dr. Rajendra Singh Pardesi, President AMOGS, for his valuable presence today. My sincere gratitude to Dr. Rashmi Kahar, Chairperson High Risk Pregnancy AMOGS, Dr. Ameya Purandare, Second Vice President AMOGS, Dr. Sujata Dalvi, Secretary AMOGS, Dr. Sneha Boyar Madam, Medical Disorders Committee AMOGS, and our own Dr. Monica Umbardan, Chairperson PAC AMOGS. My heartfelt gratitude to all the 3 chairpersons, Dr. Milin Shah, Dr. Mani Guram, and Dr. Anjali Jamma, under whose guidance we could organize this conference. My heartfelt thanks to the esteemed faculties who have traveled long distances to share their experiences and knowledge with us. At the same time, we highly appreciate the efforts put in by the chairpersons, dear members of our societies. Can't thank you enough for working in various committees tirelessly. Of course, we would be very happy to felicitate you individually in the valedictory function. My sincere thanks to all those who have presented papers and posters, an integral part of the conference. We are indebted to the participants of the cultural extravaganza who have really taken great efforts to make sure that everybody enjoys the gala night. My heartfelt thanks to Dr. Archana Shah and Dr. Meena Gunjotikar, who have brought grace to the inaugural function with their melodious voice.
I also extend my heartfelt thanks to the pharma companies who have played an important role as an educational partner. I also extend my special thanks to conference team for spreading the news far and wide for those who would want to join but could not and provide online facility. Definitely, I would thank all the delegates without whom this conference would not have been possible. My special thanks to Dr. Sujata, who readily agreed to conduct this inaugural function, and she has done it very beautifully along with Dr. Ketki. So with this note, wish all of you a happy learning. I am sure you will enjoy the conference as much as we enjoyed organizing. Thank you so much.
And special thanks to Dr. Nanda for taking so much, the efforts for this conference. And also take this opportunity to wish all the best to Dr. Sneha, who is contesting for the post of VP of Foxy. Sneha, all the best.
Thank you everybody. We declare this inauguration ceremony over, but I request dignitaries to stay there for 5 minutes for a photo. I request everybody who is there, please join us for a photo with SOGS and AMOX. Ashwini, Pawar sir, Pradeep, Patil, Madhura. Please everybody come for a photo. We have Dr. Vaishali Kadukar madam with us. So many dignitaries. Come on, come on. Sachin Jadhav sir. Please come on time for the banquet. At 7:30 p.m. sharp.